We are live. Now
Okay.
you can start.
Yeah. Hi, good afternoon to all of you. A warm welcome. A warm welcome to the 12th program on 12th. This is Explore ENT program, which we are doing with Dr. Satish Jain and team, Dr. Rajiv Pachori and others. This is the 12th program. And today I can share with you that this time that we have wanted to have the program by 2 o'clock. What has happened that when we have sent this information to all the doctors yesterday, around 10,000 doctors yesterday, I've received many calls, I received many messages, and my colleagues have received many messages stating that whether it is 2 o'clock or 10 o'clock. On a Sunday, where doctors used to have a relaxed day, and many of us has to have a relaxed day on a day which we were expecting in the week, that is Sunday. Now Dr. Satish has made the expectations that his webinar will be on. That itself, it's a great success, and only Dr. Satish can make all this difference in one's life. So once again, my heartiest welcome to all of you. And today we have with us the legend, Dr. Satish Jain, and the program Karta, I would say Dr. Rajiv Pachori, who has made this program possible for Sun Pharma, and Dr. Subhendra Kumar. Warm welcome to Dr. Subhendra Kumar in our panel today, and Dr. Sumit Mre, and Dr. Paramita Saha, and of course other leading panelists.
Yeah, our Otolaryngology team.
Yeah. So a warm welcome to you once again on behalf of Sun Pharma. This is Mahendra Varman from Pharma Care Division of Sun Pharma, which deals with Cipodem, Recipar, Riconia, and Montecapex, these products. So once again, warm welcome to all of you, and have a great webinar today. Over to Dr. Pachori.
So good afternoon on Sunday, all my friends from this country and abroad. This is, I think, 12th. This is our 12th program with this Sun Pharma MS by Satish Jain, us, our team, and I welcome all of you again with lots of just have some energy till late night, and we have wonderful cases like cochlear implant, polystodermal surgery, subtotal petrosectomy, with lots of discussion with radiology. So I think you should prepare yourself for next 8 to 9 hours today again. And I would like to thank Sun Pharma again for this wonderful event, and they are just doing from their core, from their heart, and with their full team. And again, I would request everyone, please put the questions related with the surgery going on, the steps going on. And I think you all must have gone through the previous presentation on the YouTube recordings, etc. So we will try. We keep the questions, and those were related with the topic. So sometimes we miss the questions. Don't take it other way, because these questions have already been discussed in previous webinars, or we expect that these questions will come again while Dr. Satish will take care while doing surgery, etc. So again, a warm welcome. And today is we are starting with the cochlear implant, and we have our audiologist team from Dr. Inju and Dr. Meenakshi from Delhi, and they will discuss on and on in between regarding. We have quiz also, so we can prepare yourself. We can ask any questions in between. And there's some, I think, regarding this cochlear implant. We have some even amongst the ENT, we have some discussions, conception. But just before starting, I would like to share a few things. That cochlear implant is not any hidden thing. It is an extended version of the hearing aid. It is used when hearing loss is beyond the correctable range of the hearing aids. And implant is recommended below 5 years of age usually. And it somehow the speech is developed. It can be done at later age. It is not fully concealed. Some part has to be outside, that we will discuss in detail when we start.
I've joined. Okay.
And regarding the implant, how it works, just basic thing, it bypasses damaged inner ear and stimulates the nerve directly. It differs from the hearing aid where less functioning ear is function. So if the nerve is absent, even the cochlear implant will not work. That we have dentist implants, etc. But before that, we have to find out many things. So keep in mind, in the brain, the speech area develops till the age of 5 years, provided it gets regular auditory feedback. These are basic points. Before the long discussion, I want to enumerate with you. So early implantation is recommended for the best result, and I think is 9 months or 8 months to 2, 3, 4 years. 5 years is the maximum limit to get a perfect rate. And adults, those who have good speech implants have very good result in those cases also. One main line, keep in mind that if there is no hearing, then child will not able to speak. So no hearing, no speech, and that thing we have to keep in mind. These are few unfit cases where we cannot do surgery. But that we will discuss in detail. And it high risk pregnancies and so many things are there that you have to build. One more thing which I can share with all of our country people or the ENTs, in fact all over our globe, that cochlear implant nowadays is not for the rich only. It can be done in even a very poor person, poor patients, poor family, those who are not affordable at all, because there are so many schemes are going on in our country, so many free schemes are going on by the central government, by the different state governments. So please keep in mind that, give a message to all your patients that it can be done for a poor person free of cost with perfect same results. So that we have to keep in mind. And that's why I say that no democratic state has right to reject or not to permit any service made for the betterment or eradication of disease on the basis of economic, means poor. That it is not like that poor cannot do cannot go for the implant. Place, caste, and religion. That's you have to keep in mind. The handicap of deafness is not in the ear; it is in the mind. That again is the main point. So please avoid this sign that for this person is handicapped. We can avoid it. This handicap. We can give a normal hearing to the child. So just find out the disease as early as possible, and they make this word deafness free. That is the main purpose. And we can, even suppose there's a moderate loss, medium, severe loss, we can correct the hearing by maximum, by different. There are so many things are there. We can correct the hearing part, and those who are hard of hearing, we can communicate very well with the visually also. So please, this is the point that sign language is the last. This should be the last option for anything. So we should correct, and we should not promote this sign language in any case. So that was from my side. I think I should go ahead with, and I should give my Dr. Satish. He would take care of next half an hour. Anything from Dr.
Satish, please welcome our dear friend Dr. Sandesh before we start with the actual scientific proceeding. I'll say a few things. Just say hi to him and I'll tell you what Satish Mahekar is. Sandesh, welcome.
Thank you.
Unfortunately, I'm on the phone, so I can't see the full screen. So Satish, this is introducing you to Sandesh, a very, very dear friend.
Hi Satish. How are you? I still remember my Jaipur trip to, when I came down there.
So Sandesh is a top-notch dental surgeon who deals with the smiles of many a glittering people, from the Lata Mangeshkars to the top people. So the way I say it, he works on the teeth, but touches the soul of the patient and wins their hearts. That is the USP of a Dr. Satish Mahekar. The really who's who, they really trust him. And in fact, jokingly, I say he has very few patients, but a lot of fans, or in fact, a lot of addicts. Once a dental work is done by Sandesh, they will send a private plane for him and call them to their city, but not allow anybody else. That is the surgical caliber and the merit of a Sandesh Mahekar. I will let Sandesh tell why is he here today. He's going to join us very briefly, but Sandesh, you can say why you are here today.
So one more thing is the why is also I'm doing TMJ. So ENT is very close to my heart.
Yes.
There's a very small line between TMJ and ENT. But why I'm here, basically, our dental fraternity has been crazy that whether we should work or not. And every week I listen from Ashish that Satish is doing surgeries for I don't know how many hours, people don't even sleep. It's from morning till late evening. I just, Satish, just want that magic touch of yours to me so that I can also work. So the problem here is dental fraternity, though we are very close, you are also very closely working. I want to tell dentists that here is a guy who works so much, and what are you scared of when you are covering yourself so much and you are treating on or symptomatic or maybe negative patients. So that's the reason I came to see, and I'm going to watch you working so that I can tell dentists यार ENT और ophthalm कुछ बोलते नहीं है, आप ही बोलते जा रहे हैं कि dentist को problem है, indirectly they are killing our profession. So I just want to give your example that every Sunday you people work so much, so there is nothing to worry if you protect yourself. So that's the reason I was here. thank you for giving your example to all my dentists that here is a guy who works so much and this fraternity is working so much. Why are you scared where you are not doing so much of bloody job or in the saliva? I think that's a great job you are doing, Satish, and of course I congratulate you and hope my dental fraternity learns from you that yes, let's go and do the work. That's what I want to.
Thank you, Sandesh. Just a word of caution: Satish is an alien. He's not a human being. He's from some another planet.
And actually, it is twice a week.
I was touching him like a kitty, you know. Thoda mere ko de de yaar.
Okay, Satish.
Thank you very much. Thank you.
And it is twice a week, not once.
He's also on Thursday, Sandesh.
Thursday, Sunday.
Okay, but that's another addition. So I have to tell my doctors that this is what they are doing. And
so he's working every day, Sandesh. He's a madman. He's doing surgeries every day. Only 2 days he's demonstrating. He's conducting webinars.
But I just want a small clipping of this webinar or something to show it to my dentist in my webinar. In my webinar, see, this is the guy working without, and he's working day in and day out.
Yes.
So actually, day, night also in. So I think that's a good example.
Yeah. Okay.
Doctor, another attribute of Dr. Jain is he is a wonderful cricketer as well. So he is another team of cricket.
Yeah, so we'll have a great event today, Dr. Satish Jain sir. We are thankful to Pachori sir, Satish Jain sir for organizing an event today for cochlear implant, and we have all the expertise with us. We'll also have Dr. Milind Kirtane sir with us. We have Dr. Subirendra Kumar, Dr. Sumit Mrik, and many more will join us. So we will have a great otology and a cochlear implant event today. I think all the concepts will be cleared today as much as possible. So over to Satish Jain sir.
To see you all again today, and it's a great day for us. Today our day is committed to otology and some advanced things as well, and we are pleased to have with us some luminaries, and I welcome Subirendra Kumar sir, who has joined us from Muscat. He is our own, and believe me, how deeply he is into academics is unbelievable. He was ex-faculty, prestigious All India Institute of Medical Sciences, Delhi since '98, and then he shifted to Muscat, and he is involved in residency program of Oman. I have visited his department several times, and the kind of academic events going on there is something amazing. And the way he has earned his name, fame, and the popularity there with his work and commitment is something amazing. Thank you, sir, for being with us. He has a deep interest in cochlear implant and otology, and is working on heading the otology unit there in prestigious Al Nada Hospital in Muscat. Thank you once again, sir. And then we have this young man, our dear friend, Dr. Sumit Mrik. We all know him. He's a committed cochlear implant surgeon. Besides his other interest in ENT, he is heading the prestigious, unit of the prestigious Saket Smart in Delhi. And he has been trained from all prestigious medical colleges in Delhi. He is catering so many patients from abroad. He is very popular in many countries, and a lot of patients coming from other areas to him. Besides that, he is instrumental in framing guidelines for cochlear implantation for our AOI. He has done more than 300 implants, and he is invited faculty of many of the cochlear implant and other conferences and workshops. Thank you, Sumit, for being with us. And we have had earlier a lot of sessions with Sumit and had a lot of interactions. So today, I am sure Sumit will fire again, and hope we'll have a great time.
It's always a pleasure to catch up with you.
Thank you.
I never say no to you.
This event is obviously, courtesy Sun Pharma, who has been so instrumental in providing all the help and basic facilities to organize this event.
Actually,
obviously,
I think I will just add to what Dr. Ashish also said. It is not a Sunday; it is a Satish Day. So we should reframe it in ENT as a Satish Day. And I think you have kept all of us alive. And in this lockdown, during this Corona, when very few people are operating, you are actually sharpening and revising our skills every day. So that thanks to you.
Thank you, boss. And this event is courtesy. Yes, sir.
I just wanted to say a couple of words. One is just, I'm not heading the unit at, we have a committee, members of faculty here. And
they
Dr.
keep changing.
Marvin is the head of otology. Yeah, that's, it keeps, but you know, he continues to be the head of department. As far as interest in your webinars here is concerned, it's not very common to have surgical webinars. You know, you may have lectures, you may have other kind of webinars, but it's very uncommon to have operating, you know, live operating sessions. And this period of lockdowns has helped our residents here. They are almost always, they're very keen to attend to your webinars. And that's the compliment I would like to convey from this side.
The lecture webinars are a thing of past now. It is for babies. The real men show live surgery right there on the screen in front of 12,000 people.
We have now Mrs. Meenakshi Vadera, Dr. Kirtane sir here, and Dr. Asim Desai.
Rajiv,
yeah.
Can I just pass in a message to Dr. Subhendra Kumar? Dr. Ajit Mansingh from Max Hospital, our fellow colleague, he has just said hello to him.
Yes, yes.
And
yeah. Hello.
So he might be joining for a bit, you know. So he said, say hello, and he will join. Yeah.
Then, since our day starts with a cochlear implant, so we have another guest who has been heading our cochlear implant program for last 16 years. She is, I welcome Mrs. Ranju Verma, who has done Masters in Audiology and Speech Language Pathology from the prestigious Ali Awarjung Institute in Mumbai, and handling our cochlear implant department for last 16 years, ever since we started since 2004 when Kirtane sir kicked off our program by his mentorship. Thank you, sir, for being with us on this day. So Ranju, as I mentioned, she is heading our entire program. I admit truly from my heart with so much of pleasure, this program should always be dedicated to or should always be headed by audiologists. For the reasons I tell you, what I have faced in my practice. We being clinicians, you know, busy in other work and so many other things. This cochlear implant is such a dedicated, you know, job, wherein a lot of counseling sessions are required with the parents, with the patients, a lot of repeated investigations, workup, so many hours and hours of session, counseling, involvement of the parents, and so many things required, and it can be done by a committed person, and there cannot be better than an audiologist. And this is what we have observed in last so many years, and that's how this program has gone successful in our setting. Like for example, any patient coming to me, my job is to filter a potential candidate for cochlear implantation, and then I refer solely to Ranju. She works up with her hard work, having so many sessions with the parents in counseling them the need of the implant, need of early implantation, repeated workup to, you know, pick up the right candidates, and then counseling them for the particular implant, for, you know, committing them for the post-op rehabilitation. All those things are important, and this is for this you need a dedicated person. That's how an audiologist can be a core part of the team. So if you ask me, being a surgeon, in my entire program my job is 10%, just 10% honestly. 50% is by Ranju in pre-op workup, counseling, post-op rehabilitation, sometime for years together, mapping and everything, and then rest by the parents. A committed parent is an important prerequisite for a successful program, and that's how it works. So thank you, Ranju, for being with us. And of course, Kirtane sir has been mentor of so many mentors now. Like we have been mentoring some of the centers, Sumit has been, but Kirtane sir has mentored almost all in our country, and that's how this program is kicked off. Welcome, sir, and today he'll be here to, you know, guide us in many of the important issues and situations. Welcome, Ashim. Ashim, we have seen him, his otology work, how committed he is. So today, can you connect? Before we start the live surgical session, this first case, who is a child, 4-year-old child for the cochlear implantation, we would like to throw some light on certain important issues. And the most important is the candidacy, the evaluation of a child. You know, picking up a right patient is the main thing required in the success of the program. And this requires lot of evaluation. It's not like any other surgery. You see the patient today and tomorrow you can operate. This requires lot of workup before taking up the patient for the surgery, because it will require a lot of rehabilitation also later on. So evaluation has so many goals. Audiological and imaging, of course, we'll discuss in detail, has a main role in the evaluation part. Besides that, all these things, speech and language, your psychologist's role, your medical workup, it's a teamwork, you know. The pediatrician has a big role in physical examination of the patient. ENT surgeon has a big role in overall ENT examination, vaccination. Then the audiologist has a role in family counsel, expectation, and so many other things. So my first thing, the most important is the audiology. And we all know there are so many investigations, you know. Can you change to slide? There are so many investigations are directed for the workup of these patients. So here my goal with these experts with us would like to know how these patients can be worked up best, when these investigations should be picked up, in what situation, and how these patients should be followed. So Ranju, I want to ask you, we have Mrs. Meenakshi Vadera as well, will have her opinion as well. You have been working up all these patients. So what is your protocol from beginning and how you follow to the other investigation?
Yeah, Dr. Jain. As soon as the patient comes to me, I first start with a detailed case history itself. Because the case history itself gives me a lot of input in the what I'm going to get from the child. That is so important. Dig out the root cause of the problem also. Like if I ask if the child has an immediate birth right after the birth, or did he had any neonatal jaundice, or was he got any exchange transfusion done? Because these are the small things which give me a clue.
Regarding audiological part.
Regarding audiological part, yes. Because suppose the child has got the neonatal jaundice and has got the exchange transfusion done, then I'm very much careful about auditory neural dyssynchrony. Because these are the cases who are likely to develop dyssynchrony. So I'm more careful in doing my...
In a regular patient, in a normal child, without having such all histories, do you get all these investigations done in all patients, or you choose? How do you choose?
The routine case history I start, and then I do start with the behavioral observatory automatically.
Out of them, which is most important? Would you recommend anything which is most important and essential, or all of these essentials?
All of these are essential. All of them are essential. BOA, we cannot leave them behind, because it's not that the child is going to have a simple hearing loss. Very unlikely we are going to get just a simple hearing loss cases. Some of the time they are associated with some behavioral issues also, some multiple disabilities also. We do get a child who is 3 months old and no response to the sound the parents are saying at all. But the behaviorally we see that whenever we give some sound, he has certain responses in terms of like his breathing pattern changes, he just flickers his eyes and all. But the kind of behavior the parents are expecting, that he turns his head or he blinks or he startles, those kind of behavior are not present because of the other abnormalities. So we start with the BOA, followed by the BERA, OE and ASS. The BOA, it gives the ABC of the first step, followed by the BERA. We do correlate the objective and the subjective findings. But my first priority is on the subjective findings. Suppose my objective and my subjective are not correlating, I go with my subjective.
So that's a very important thing. You know, what we get OAE, BERA done are objective tests. And an audiologist cannot be satisfied unless she confirms with some subjective test. And that is how the behavioral audiometry and audit audiometry are very, very important. Ranju, you mentioned ASSR. Are you getting done in ASSR in every patient? For audience, ASSR is auditory steady state response, and this is something like a frequency specific audiometry. Like BERA is something like when you use a tone burst and the click sounds up to 100 decibel. ASSR is frequency specific, where we can go up to 120 decibel, that too frequency wise. So Ranju, why are you getting or are you getting ASSR done in every patient?
Yes, nowadays I'm making it a point that I do ASSR in all the cases. Because in BERA, the information which we get is restricted to the basilar membrane, the basal part of the basilar membrane. The responses which we get are ranging from 2000 to 4000 Hz. They are not catering for the mid frequencies and for the low frequency region of the basilar membrane. So if the child is having a good residual hearing on the mid or the low frequency, we are going to miss out if we just restrict ourselves to the BERA. If we go for the ASS, we get the specific frequency, specific threshold for 500 Hz, for 1000 Hz, for 2000 and even for the 4000 Hz. So even before the cochlear implant, when we fit the hearing aid, that gives a very good insight for us how to start fitting the hearing.
Okay, Sumit, you have a teamwork. I know at Saket.
Yeah.
So who does all this for you?
Yeah, as Ranju said, she actually hit the nail that you will not see all the centers, maybe all the audiology centers or the surgeons even discussing with their audiologists. But then, as you rightly said, I completely agree that my role is only 10% in cochlear implantation, and I always tell the parents that your best friend is the audiologist and the AVT therapist, not me. Of course, my job is just to give you a very safe and clean surgery without any complications that we try our best. But I think Ranju has made a very, very important point. Many of people and surgeons also, they are not aware about the modality of ASSR. We all know about OE as a screening tool and BERA going afterwards when you find a problem with OE. But especially if you want to give a 3 months trial of fitting of a hearing aid, not just because the hearing aid is going to help the child in any ways, because the child is already having a severe to profound loss. It is the acceptance and the preparation to use some device post implantation. So ASR is absolutely, she's right that it is frequency specific, and it can actually help you in map in those frequencies from 500 to 4000. So in our team, in the program I run at MaxSmart, we have an audiologist who is a very, very key player. In fact, it's a multi-speciality tertiary care center, so we have an access to a psychologist, a pediatrician, and all the people. So a complete evaluation, and most of our patients, depending upon we see whether we are facing a syndromic deafness, we have a complete radiological evaluation, the cardiac evaluation for these children, because we expect a lot other comorbidities and problems with syndromic deafness as well.
Yes. So, how I look at the ASSR, why I specifically ask about it, and I always make sure before my all patients I take up the Ranju does ASSR for them. My reason for doing ASSR is ASSR you can do up to 120 decibel.
That's more important.
BERA up to 1900, you cannot differentiate between sometime a severe and a profound loss. Absolutely. And we want to pick up certain subset of patients who have residual hearing, which you cannot, make out from BERA. So any patient has a response on a high intensity ASSR, suppose 110, 120, having some residual hearing, it can help us choosing the ear for implantation. Like for my patient, if one ear is completely blank with the ASSR up to 120, other ear has some response on high intensity ASSR, I will choose the blank ear for implantation and other for the hearing aid if I am doing on one ear. That is how ASSR is important. So
I just had one point, Dr. Satish, you're absolutely right. If you have a residual hearing for a child, for a very young child, you are going to be very careful in preserving that residual hearing. So you will have either a soft technique, which we learned from Dr. Keith, the soft opening of the endoscope when you enter the cochlea if you're doing a cochleostomy, and you try and limit the bone drilling in the area of the round window niche area. So if you have an adult who is profound deaf, he doesn't have any residual hearing, and but in comparison, if you have a child, you have an indication from an ASSR.
In general, how do we get to know that the patient has a residual hearing in one ear? At least one ear if you are implanting unilateral, and if you have information as the patient has some residual hearing in one ear by means of ASSR, it certainly has a big impact on choosing the ear for implantation. That is one. And once we know that a patient has a residual hearing, if it is good, we can, if you are doing bilateral or something like that, we can use something like electroacoustic, stimulation in case as a patient has a good residual hearing in the low frequency. Kirtner sir, are you getting ASSR done in every patient?
Yeah. Can I just say something here?
Yeah.
Satish, if you do an ASSR and you get some response at 110 decibels,
yeah,
you call it residual hearing, but it's not useful hearing. So if I did a ASSR
can be amplified, can be amplified.
Hello?
Can be amplified.
No, but if I had a profound deafness to the extent that I was getting responses at 110 and the other ear not giving me a response at all, I would rather operate on the ear that at 110 because I have a better chance of giving him a result with a cochlear implant. I don't know.
Got it. But if you are doing unilateral.
Yes.
Can
I do agree with you, sir. Yes, also, I was having a discussion with Dr. Jain, because if he is responding at 100 decibel, there are chances that even in amplification, we are not going to make use of this amplification for speech perception or for developing the speech. But that's an indication that he has certain audibility over there. He will do with it.
So it would be better to implant that here.
That,
we can involve both the ears. We can give him a sort of binaural hearing if the other ear can be amplified by means of using hearing aid.
But Satish, at 120 decibels, the amplification is really
no,
not
in the lower frequency may be good.
Sir,
because Bara, you cannot differentiate between a severe and a profound hearing loss.
No,
all you can differentiate only on the basis of ASSR.
Decibels. If you're getting a low frequency response at 70, 80, I think yes, you can use that here. If you're getting a response beyond 100, I don't think...
see, 110 decibel is something it always overexpresses. So, something like 100 or 110, still you can amplify. That is, a lot of people do it and we can use it for a binaural hearing purpose in case it can be amplified. That is something, I look at the ASSR, sometimes it can be important.
Meenakshi wants to say something.
I actually, 110 decibel. See, I agree with the ASSR is an important tool, wherein if we have a hearing by like 85, 90 decibels, that is audible. Anything beyond that, we start, suspecting some dead zones. And whatever amplification, so much ever gain we do, we will never be able to give any useful hearing in that ear.
So you mean to say,
with ASSR, we should also always, look into, as Ranju was saying, that our aided thresholds are better tools, because ASSR can have a lot of artifacts. Sometimes we have seen that in aided response, in ASSR we don't find any response, and in aided we might find something useful. So aided is much better tool.
That we always do. On the slide on the top, we have behavioral and aided audiometry is always part of the workup, and that is very important. Next, for the workup, this E-Bara is a pickup like, it has come up like anything. We don't have tool to do E-Bara. Sir must be doing it. Sir, are you doing?
No, because you don't get very consistent responses. Interpretation of E-Bara is a little difficult, and I have done it in a few cases, but sometimes it's very difficult to make up your mind on the E-Bara. So I go more by the response that my audiologist tells me. Do the aided behavioral or aided audiometry, and if you're able to show some kind of auditory response, then you have to accept that as proof of a functioning nerve. With E-Bara, Sunil Dutt and Bangalore, his audiologist Apurva are doing it.
Yeah, he has got the equipment.
The responses have not been that consistent that you can rely 100% on it. So I would rather go by a good radiology, if I can see even a thin nerve and continuity of the nerve, and then my audiologist tells me that there is some response.
So the bottom line is,
patients where we had no response and the nerve was not visible, in 66% of these, we have managed to do implants and get some.
So the bottom line is, that is, I think, a very important idea. With the imaging and the aided audiometry, if you get some responses, particularly in lower frequencies at 1K or so, if you get some, you will go in for a CI straight away. You can counsel the patient that, with the prognosis guarded, of course, that a CI may work, rather than relying on E-Bara. So you are not relying on E-Bera. It's not because of its merit. Not because of you are not having, or not because of its merit. Most of the people are not having E-Bera. It's not easily available. But literature supports it in a big way. But your point is very clinical, very understandable. 1K response on aided audiometry is a good indication that probably the nerve is working. But if we have E-Bera, then anybody, any experience with the E-Bera? Sir, your voice is mute. Survendra sir. And I will, the literature supports E-Bera like anything. Most of the time.
Survendra sir. Yeah.
No, we are not doing E-Bera. And so that's something to be looked into.
Yes. Okay.
Dr. Satish, can I add one thing?
Yes, please.
I think we are also not doing E-Beras. I agree with Dr. Kirtane very well. See, even in patients who have got hypoplastic cochlear nerve, the ball is in the court of the surgeon. The radiologist will give you an kind of a report that the possibility of hypoplastic or an absent nerve cannot be ruled out. You go to the console, you see the cut section at the internal auditory canal, the sagittal. But your audiologist's opinion is very important. If your audiologist tells you that they can achieve a little bit of aided response on a hearing aid use, they are able to sense a behavioral audiometry with the child, they are able to generate some response. Now, these clinical responses are far more important in
obviously.
To actually
that's what sir
go
said.
ahead with implanting a hypoplastic nerve.
That's what sir is saying.
Yeah, so they are. I think it is very important, and sometimes you are in a phase that legally the parents ask you, sir, will we have a success after doing a cochlear implant? And you always have a kind of condition. See, I can't tell you how many actual fibers are going through the internal auditory canal, but definitely we are suspecting a hypoplastic cochlear nerve based on the internal auditory canal diameter or the cut section where you, the sagittal section where you don't see the fourth nerve as same diameter of the other nerve. So I think in these cases, even the E-Bera may not help you, but your clinical evaluation and your audiometers.
Perception of a brainstem response in E-Bera is a good indication that your nerve fibers are intact somewhere. Somewhere the nerve is responding. That is the only idea. A lot of people get cortical responses done for the same region. That if you get cortical responses, that gives you indirectly an idea that your nerve is somewhere functioning. You may not be picking up on imaging very well. You may not be finding on other tests, but still you have some responses which can be very helpful for the patient.
Yeah, Satish, but cortical responses also are not easy to interpret. There are a lot of artifacts, and I mean, I've talked to people who do cortical, and we've tried doing
neurologist.
It has not been all that conclusive.
Sir,
yeah, it's difficult.
Sir, actually, corticals, when we're talking about corticals, we say when a child is hearing impaired, the cortical responses matures with auditory input. So since the child is not used a hearing aid, we might not get that important information initially. This could be a very good guiding tool later on. Corticals,
okay, her point is valid, because the maturation of the auditory system is dependent on the hearing, on the sensory stimulation. If the child who is prelingual deaf, her system may not be mature enough to give responses. So that's a valid point. That's why those responses are considered insignificant, inconsistent many of the times. So besides this workup, for the surgeons, the most important part of the workup is physical examination of the patient, ENT examination, like I mentioned in the slide, rule out any otitis media or something, because this can be a disaster in a child having history of otitis media and implanted. That's fine that you control on a medical ground, with medical management and implanted. If with the implant in situ, later on patient develops otitis media, can be a disaster with the implant in place. With a foreign body in place, with infection in the ear, it becomes so difficult to control, and the foreign body acquires the biofilms, it attracts the biofilms, it helps in biofilm formation, and then many a times it can be a disaster in propagating the ascending infection, or it may sometimes warrant the explantation as well. So that workup from ENT surgeon is very, very important. And for that reason, the vaccination and other protocol is equally important. So all these things to be taken care of in the workup by and large. That's what our meaning, what we wanted to say. Coming to the surgical part.
Satish,
Yes.
Before you move on to radiology, I think I can see your slide.
Yeah.
I just wanted to give little input as far as how we work here.
Yes.
We have a universal newborn screening program where we have been able to achieve 93% to 95% coverage of entire Oman. So we have been receiving cases much earlier than what we were before. So now we are able to implant most of the children between 1 year to 3 years, unless meningitis, which can go below 1 year also. So our catchment has improved a lot. It's a smaller country, so it is possible. India, it may not be so feasible, but it can be thought about. The second point is we have a combined clinic. Once a month we run combined clinic where the entire half a day is spent over it, and this combined clinic constitutes the surgeons, the audiologists, radiologist if required. It's a difficult sort of imaging then, and the psychologist is standby. The patient goes to them, but otherwise the main discussion between the audiologist and surgeon, that is mandatory. So during that 1 month, whatever cases are selected, then they are on that day discussed together. We are not individually deciding, we are deciding it together with the parents.
Yeah. Yes, sir.
Good concept. Yeah.
Yes, sir. So now moving on to the important part before surgery is the radiology. And the goal of radiology is to pick up the right candidate, to pick up the feasibility of implantation, whether the implantation can be feasible in that particular patient. Like I always mention, there is a basic functioning unit which is required for the implantation to be successful. And that is how the, the application have expanded. Cochlear implant, ever since it started in 80s, now the indications have expanded like anything. Not only children, it started with the children, but now for any age group, for any reason, patient having hearing loss which is not benefited by hearing aid, that too significant a hearing loss not benefited by hearing aid, is by and large a candidate for cochlear implantation, by and large. And for that cochlear implantation feasibility, the basic functioning unit which must be intact for the cochlear implant to be functioning is an intact cochlea having fluid in the cochlea and the intact cochlear nerve. So we need certain investigation to confirm whether the patient has a basic functioning unit intact or not. Patient has a cochlea with fluid or not and an intact cochlear nerve, and that is best demonstrated on an MRI, which I am going to show you in what sequences and how MRI is so useful for other regions as well. So first of all, the role of radiology is to show the feasibility whether cochlear implant is feasible or not. And number two, the anatomical details of the area where we are going to operate, to give us the to show us preempt difficulties which the surgeon can come across surgically, and any other malformation or anything in the anatomy which can have a significant impact on the overall outcome, which can change your surgical approach, we can change so many things in your protocol. So the radiology is a key role in selecting the patient for implantation and selecting the approach, selecting the electrode and everything. So in radiology, what kind of radiology you need? We need both CT scan and MRI by and large. MRI is a different role, as I said, for confirming the basic functioning unit, and the CT scan gives us more and more anatomical details of the temporal bone. So in CT scan, like we have a CT scan on the screen, we need to have a fine section CT scan. Ideally is to have a cone beam CT scan which can give you 0.05 mm sections if you want. And by and large, you need to see yourself the CT scan. Because radiologists can give you information, but I'll tell you certain areas which can make your life surgically simple. You need to see on your own the radiological part. Like, for example, just an example, if you are going by the posterior tympanotomy approach, you can have fairly good idea through the radiologies by certain means that how your round window is going to be visible through the posterior tympanotomy, which radiologist is not going to tell you. Radiologist can tell you if there is any abnormal anatomy or anything, any malformation, abnormal anatomy. Otherwise, by and large, he'll report as a normal anatomy of the temporal bone, which is not of, by and large, any use for us. So here in radiology, quickly, what all to be seen from cochlear implant perspective. In the last Sunday, we saw the radiology of the temporal bone in perspective of otosclerosis and Stippy's surgery. Here now, we are looking at the radiology of the temporal bone in perspective of cochlear implantation. So first thing, in cochlear implantation, as I said, the anatomical details and any malformation or abnormal anatomy, we need to look at both the aspects. So first of all, the first structure, if I am seeing the axial CT scan from up to down, the first structure we come across is the superior semicircular canal. You know, amongst all the inner ear malformation, the semicircular canal malformations are amongst the commonest malformation, and superior canal is one of them. We need to look at if there is any pathology which is mostly not observed in the superior canal, more we see in the lateral canal or so, but we need to look at it. And then what we need to see here, as we go down, the first structure which is coming in the view, let's go on the right side which we are operating. This is the superior canal, this is the ampullary end, and this is the non-ampullary end of the superior canal behind. And as I go down, this is the petromastoid canal between the going through the superior canal. And as I go down, the first important thing to be seen from cochlear implant perspective is the internal auditory meatus. Dimension and the shape of the internal auditory meatus has a significant impact. This dimension of the internal auditory meatus, you can check yourself. See, like for example, in this patient, the dimension of the internal auditory meatus is something like 4 millimeter, which comes in the normal category. This dimension gives you an idea if it is abnormal, this patient could be having some issues. Like if this dimension is too narrow, below 2.5 mm, it gives you suspicion of a hypoplastic or a absent cochlear nerve. If it is, you have to confirm further like we discussed with other tests, but it gives you fairly good idea if there could be some issues. Then the dimension, if it is increased, if the auditory canal becomes larger, bulbous, then you have to be careful about, there could be a direct communication with the inner ear which can result in gushers. You know, once you are operating on these children, you know, majority of this congenital hearing loss is because of some or other abnormality. You know, many of them are non-syndromic, but still they have some abnormality. Many of these abnormalities you can pick up on a CT scan, but the malformation at the membranous level you may not pick up at the CT scan or MRI, and still all those problems can happen to occur. But the obvious regions which can result into problems like gusher, you have to be careful, and the dimension of the internal auditory canal is very, very important. If it is bulbous, having communication with the cochlear base, you have to be prepared with that. And our policy now, as compared to the past, all those malformations who are prone to give CSF gushers, like common cavity, IP1, IP3, we have changed our approach solely to a subtotal petrosectomy approach, so as to take care of the gusher forever, the CSF leak problem forever, because the CSF leak, if happens to occur post-operatively, can result in meningitis and can be fatal. So we'll discuss that part later, but here the dimension of the internal auditory meatus is very, very important. Now as we go down at this point of time, what we see behind is the vestibular aqueduct. Can you see here? This is the vestibular aqueduct containing the endolymph connected to the vestibule, and this has a significant impact in some of the malformation. This is one of the commonest malformation you will see, the enlarged vestibular aqueduct. Sometimes this is enlarged as a sole abnormality, giving rise to the sensorineural hearing loss, and those patients requiring cochlear implantation. So we have to be very careful while looking the CT scan if this vestibular aqueduct is enlarged. By and large, in the dimension right from the vestibule to the posterior fossa in the middle, if it is more than 1.5 mm, you can say it is enlarged. There are so many criteria for the consideration of the enlargement of the vestibular aqueduct, but yes, if it is enlarged, you have to be careful, you have to be prepared. It's not a contraindication for the surgery, but it makes you prepared to deal with some sort of oozer, if not gusher. Gusher is unlikely to come from an enlarged vestibular aqueduct, as that kind of flow is not going to come through the pulsations from the posterior fossa, but yes, enlarged aqueduct can lead to some sort of oozer, and then you have to be prepared to deal with it. Now, from the internal auditory meatus here, as we go down, we see certain nerves going from it. The most important nerve here, the anterior superiorly, the facial nerve. In certain malformations, the facial nerve is abnormal, and we need to have a good information of this, the course of the facial nerve pre-operatively to prevent injury to the facial nerve. Facial nerve is important in every otology surgery, we know. But here in cochlear implantation, particularly the most popular approach is the posterior tympanotomy, and we need to have a work over the facial nerve. We need to be well versed with the course of the facial nerve surgically, and we should anticipate the course to the radiology pre-operatively. So here, this is the labyrinthine segment of the facial nerve going, that's the genu, and that's the horizontal segment of the facial nerve. You can see as you go down, this is the mastoid segment of the facial nerve, and that's how it goes down to the stylomastoid foramen. Now, the most important thing for the posterior tympanotomy approach, that's what we are going to do today. This posterior tympanotomy is what? Posterior tympanotomy gives you a space to work to go to the posterior tympanum through the mastoid from behind. And this area is a safe area to go from mastoid to the posterior tympanum, but this is bounded by certain structures medially, facial nerve, and laterally chorda tympani. By a good radiology, I will show you exactly here both the nerves. You can make out the dimension of the facial recess. You can make out how round window is visible through the facial recess or not pre-operatively, because some of the patient may have orientation of the cochlea different than the usual. Some patient may have a narrow facial recess, though this facial recess dimension is stable since birth. There are certain things in for everyone. There are certain things in as far as the anatomy of the cochlea and the middle ear is concerned is stable. A child who is born has the same dimension of the middle ear and inner ear what he has otherwise in the adulthood. It doesn't change. Facial recess at the same time, the space between the chorda tympani and facial nerve is a stable dimension. It doesn't change. A facial recess dimension of a 1-year-old child, 6-month-old child would be same like an adult. Because this doesn't change. What all changes in the temporal bone, there are a lot of good publications you can make out. What all changes in the temporal bone is the dimension and the orientation of the extraauditory canal and the development of the mastoid and the growth of the mastoid further. These are two things which changes over the period of time. Otherwise, the entire middle ear, ossicle, inner ear, they remain stable throughout the life, and they remain as such what they were at the time of birth. So here, we need to see in this approach, the posterior tympanotomy approach, this facial recess. How you can make out? See on this dynamic CT scan. First of all, let me take you through the CT scan, through the facial now. See this facial now. Keep an eye on this.
Yes.
This is mastoid segment. Can you see this?
Yeah, very clear.
See this mastoid segment. I am going down, down, down. See here, some nerve is emerging from the lower part of the vertical segment. Can you see very clear?
Satish, see this. Zoom a little bit. Is it possible?
Yes. See this small nerve. See this small nerve emerging, sir.
Yeah, now it's now you can.
Yeah.
This small nerve is emerging from the facial nerve here. See this. This small nerve is emerging from the lower part of the facial nerve and going laterally as I am going up, 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 up. Can you see here?
Yeah.
Right there. This is the medial part of the canal wall. See very clear. And this is the facial nerve, and this is what the facial recess is. You can reconstruct this facial recess in many of the reformatted sequences. Like if you do the longitudinal, sagittal reconstruction, you can have both the nerves in the same plane, the chorda tympani emerging from the facial nerve, and you can see the triangular facial recess. Here you can see the dimension of the facial recess very well by means of this CT scan. If I measure the length, the distance between, see this chorda tympani and this is facial, and to me this is 3.05 millimeter, and this is adequate. Now, if this is adequate to visualize my round window or not, that I have to see some other parameter for that. So, for posterior tympanotomy approach, which is the most popular approach for the various advantages, we need to be, or we should be able to see the round window through the posterior tympanotomy, that is through the space between the chorda tympani and facial nerve. Now see, we are looking from outside here. Like when I start operating, I will start drilling from here. This is the posterior canal wall behind which I will drill and go medially. So I'll draw a line at this point. What all we need to see is the cochlea. Can you see? This is the basal turn of the cochlea, where we need to implant in the scala tympani of the basal turn of the cochlea. And I will show my straight shot implant in the cochlear tunnel in the basal turn of the cochlea. So what I mean to see, my implant should go right in the straight basal turn of the cochlea. This is the level of the round window, and this should be visible through this space between the facial nerve and chorda tympani. How you can make out? Let me know. Let me tell you first of all again to show you what is that space. This one. This is the space between the. Oh, sorry. Length. Yeah. This is the space. Why it is delete. This is the space between the facial nerve and the the chorda tympani. Now if I am coming from laterally, my guide will be the canal wall. We always go behind the canal wall, keep thinning the canal wall and go towards the facial recess. At the level of the, what we have to look at the level of basal turn of the cochlea. At this level I draw a line along the canal wall. This will be my anterior limit of visualization surgically. If I come laterally, I will be along the canal wall, and posteriorly my limit for this thing is, the same line. If I draw parallel to the anterior border of the facial nerve, see this, at the anterior border of the facial nerve. Now I am looking through this narrow space surgically, exactly which I am going to show you during surgery, between this canal wall where there is laterally the chorda tympani, and this is demarcated by the canal wall, and behind my medial limit is the facial nerve. If through this space, if I am able to see my basal turn of the cochlea straight away, this my approach, my visualization of the round window is favorable. I'll have in this patient this wide space to visualize through, to go into the round window and further to the cochlea. And this you can anticipate through your pre-operative CT scan, whether you will be able to see that or not. There are many ways to, get this information by so many lines and angles and so many things. This is the most practical way you can see yourself without remembering anything, that this is your anterior limit posterior canal wall, this is your posterior limit the facial nerve, and in between this, if you in the straight line, if this basal turn of the cochlea falls, that means a favorable situation, and you will be able to see your facial nerve, your round window and the scala tympani easily through this approach. This is one way. Now why it is a difficult situation sometimes, why we are looking at it, why we are so concerned about it? The reason is, sometimes your round window may be rotated because of your rotation of the cochlea overall. There are so many people describe the cochlear rotation differently, but by and large, let me tell you, by and large, what happens? Hey, just a minute. Yes. See this. This is the mid-sagittal plane. Can you see this?
Yeah.
Now, if at this point of time, this is your basal turn of the cochlea. If I draw a line, just to give you an idea what is rotation, cochlear rotation. This is the mid-sagittal plane, and if I draw another line passing through the basal turn of the cochlea, can you see this?
Yeah.
Now this angle between these two lines, between this and between this line, is something which very important people have described,
Yeah.
And what is this? This is the angle that you have to measure. Radiologically you can measure. If it is by and large between 50 to 60 degree, that gives you a fairly good idea that your cochlea is not rotated. It is not so malformed and rotated that you will not be able to access it from behind. By and large, though we don't consider this as a major factor in visualization of the cochlea. The best way is what I told you in the beginning, your two lines through which you see the round window. If your basal turn of the cochlea falls into it, that gives you that it is favorable. Yes. Yes, you are asking something? So this is one. Now what happens sometimes in the adult, there is a little difference. I told you, there is always a rotation of the extra-auditory canal or the period of time with the age. And that makes sometimes the, this visualization of the cochlea easier or difficult the way it rotates. So if the extra-auditory canal rotates, this extra-auditory canal rotation will tell you whether you will be able to access the cochlea easily or not. What happens in the difficult situation? So this was the easiest situation. What would have been difficult? Had this round window been rotated behind, had this round window been pushed behind, when you see through the posterior tympanotomy, through the lateral to the facial now, when you access the round window, if the round window is posteriorly and medially rotated, it may not be accessible through the posterior tympanotomy so easily, and that you can pick up through the CT scan. And in that situation, suppose if it is rotated posteriorly and medially, what to do? Then you have to tilt the patient behind, then your canal wall will come in the way to access the cochlea. And then even if you get the space, you will do a sort of vertically recessed implantation access to the scala tympani or the basal turn. There are many ways to, overcome this problem. Nowadays, it's not a difficult one for a regular cochlear implant surgeon. There are many ways to overcome. Even if the cochlea is rotated, even if you don't have a radiology and you find that your round window is not visible, it is difficult, it is rotated, there are so many maneuvers you can do to overcome this issue. Simply what you can do, when I will show you, when I do the posterior tympanotomy, in case you find difficult, what all you can do, you can remobilize the part of the canal wall, you can remove the canal wall and reconstruct with the cartilage or the bone later on, just keeping the tympanomeatal flap intact. Or in the for any difficult situation, for that matter, in any difficult cochlear implant situation, maybe forward sinus, lower dura, facial nerve abnormal, or any given situation, if you are not finding difficult with the regular approach, you can always convert to a subtotal petrojectomy and implant through that approach. That is to overcome all the issues. But here, for everyone, we should be able to know if the implantation is difficult in the particular situation by means of, or the access of the round window is difficult or not. And that you can make up very well with the radiology. There are people using various angles, lines. Those are useful, I don't deny, but that is unnecessary to complicate the situation. What you need to see is yourself practically, that once you are passing through here, you are looking at the basal turn of the cochlea between these two structures, whether you will be able to see the basal turn or not. That is the simplest way. So this was regarding the facial. Now we need to look at the facial now. Go back here and see if the course is abnormal or not. In certain cochlear malformations like common cavity or even sometime in IP1, the facial nerve may be anteromedially pushed and it may not be at the same place where you expect, and you have to be careful about that during implantation to prevent injury to the nerve. Then the second nerve at this level, if I go down one level down, what you see here? The cochlea.
Yes.
Can you see the picture of the cochlea on both sides?
Yeah, very, very clear.
So this is the mid-modular view where you see the modulus. You see some thickening of the modulus, some sort of, ossification at the level of the modulus, because this is a porous bone. And this is what we need to see carefully at this region, a lot of things. The number one thing, see this was the intra-auditory meatus, where superiorly I am going above, down, superiorly was the facial nerve going, and inferiorly is the cochlear nerve entering through this cochlear aperture into the cochlea. And this we clearly saw during the temporal bone dissection, where I demonstrated how the cochlear nerve was forming from the spiral ganglion neurons. So here this area is very important. In all situations we should be able to know that how much is the dimension of the cochlear aperture. You can make out on your own. See, this is 1.8, this is adequate. If it is more, suppose more than 2.5, there could be a direct communication between the cochlea and the intra-auditory meatus, giving a possibility of a gusher. If it is less than 1.4 millimeter, then could be a situation of a hypoplastic cochlear nerve, and both the situations should warn you and should make you able to deal with those situations. So this is one of the factors which you should know and see yourself in every case. Then coming to the cochlea, like in this patient we saw the modulus. There are so many malformations of the cochlea have been described. At this level, we should be see if there is any malformation in the cochlea. I told you, in many of the congenital hearing loss, in spite of having malformation, the malformation which we pick up on radiology, the bony malformation or visible malformation, are only 20%. The rest are at the membranous level, which cannot be picked up by radiology. So here, whatever we can pick up, it can make us, alert to deal with that situation. And here all the 3 tons of cochlea we should be able to see. And this kind of malformation, the guy who has worked most in this field, who spent years and years in the orthopathology labs, was Professor Senaroglu, and who devised and described this classification of the middle ear, the inner ear malformations, and that is very, very practical pathologically as well. And he described, owing to the the malformation in the fetal period, how the cochlea growth normally happens to occur. So by and large, quickly I can mention here for everyone, our cochlea start developing at the age of, in the fetus, at the 3rd week of fetal life as a otocyst. At that time, see all these malformation, this cochlea from 3rd week till 25th week, it goes into maturation, and at the 25th week, it becomes like adult cochlea. Any point of time, if this during this embryological development, if the embryogenesis stops, that will be the final stage of the cochlea, what we see in that patient when the patient is born, when the child is born. So like, for example, the embryogenesis hampered at the 3rd week, child will born with no cochlea, no vestibule, nothing, no labyrinth, and that will be Michel's aplasia. If the development goes on in the late 3rd week, there could be some development of the vestibule. Cochlea develops later than vestibule in the beginning, and there could be cochlear aplasia. Then the cochlea, this otocyst, develops and becomes bigger in size as a common cyst, and bigger in size in the 4th week, and further development, if it stops, then the final picture will be a common cavity. Again, the common cavity is a very, very difficult malformation, because in that situation, the labyrinth is not differentiated into cochlea and vestibule. That is so early embryogenesis stopped with the communication with the intra-auditory meatus directly in the medial part. So that is common cavity, and implantation of the common cavity is a difficult thing, but yet it is possible and can give benefit to the patient, because still the sensory epithelium is there in the wall to stimulate. If the cochlea further grows, in the 5th week, if the the cochlear growth where it differentiates into cochlea and vestibule and the embryogenesis stops, that cochlea without any internal architecture is a sort of incomplete partition, with a cochlea separate cavity, vestibule separate cavity, without any internal architecture, is known as incomplete partition 1. And again, majority of these patients have a abnormal communication with the intra-auditory meatus, because the differentiation has not gone to that level to separate from the intra-auditory meatus. So in the 5th week, if the embryogenesis stops, it is IP1. If further, the embryogenesis happens, can lead to, before the cochlea adults the adult size, there are a lot of cochlear hypoplasia described into 1, 2, 3, 4, the variety of situation. IP2 is the situation when the embryogenesis stops in the 7th week, and until that cochlea is quite mature. The vestibule is large in that situation, along with the enlarged vestibular aqueduct. That's why we call it as a Mondini, the triad. But cochlea itself develops good architecture. The basal tongue is separate, but the apical and the middle tongue, they coalesce. There is no interscalar septa to form a single cyst, and that is Mondini's deformity. Another deformity which is rare, fortunately rare, is a very difficult situation, is the IP3, wherein the modulus is not developed and there is through and through communication with the intra-auditory meatus. So here what I want to see, we need to see the architecture of the cochlea in every case, if there is any malformation, so that we should be prepared to deal with. That is not a contraindication to the surgery, but that require a lot of counseling of the patient, because all these malformations have a more possibility of giving complication as compared to regular implantation. They may require a different, spatial array, not a very long one for the small cochlea, small array and all that. So the radiology can, in the beginning, tell you about choosing the approach, choosing the electrode, everything. If you go through the radiology carefully, if you find any, abnormal, malformation in the cochlea at this stage of time. Now here is the vestibule. Enlargement of the vestibule as is one of the commonest inner ear anomaly, and we should be knowing about it. Itself, enlargement of the vestibule can lead to hearing loss and may require cochlear implantation. Though these are all favorable patients, but we should be able to see this, as they can give rise to some sort of oozer, and we should be able to prepare to deal with it. So all internal ear structures, cochlea, vestibule, interauditory canal, the semicircular canals, all this should be thoroughly looked into to rule out any malformation, and that is the role of, that is how the radiology can help you in ruling out. Now, coming down to the level of the basal turn of the cochlea. Now, once we are going by the posterior tympanotomy approach, if some anatomy abnormal you come across can complicate your situation, you can still pick up by the radiology. Now see the most important thing here. Can you see some bulge of something here?
Yeah, jugular.
That is the jugular bulb. See the level of the basal turn of the cochlea. This is the level of the round window.
Yeah.
And at the level of the round window, you are able to see the jugular bulb. That means this is a high jugular bulb. Though it is covered by the bone all over, it is not dehiscent. So it's not going to give problem, but you must know this fact, that jugular bulb in the vicinity, and if you try to do some drill out, you have to be very careful. In terms of exact distance from the jugular bulb, what you need to do is, you have to reconstruct into coronal plane. Now I have reconstructed in the coronal plane. See this? And how you can pick up? Let me show you how you can pick up. First, on the axial, you go to the, through this software, go to the jugular bulb. See this? And this is your jugular bulb on the coronal. Now, go to the coronal and see the relationship of this jugular bulb to the, this is round window. Can you see?
Yeah.
You can make out, this is round window, and you can make out how far the jugular bulb from the round window is. It is so important. We have seen couple of patients who had a even higher jugular bulb, dehiscent jugular bulb, yet you can manage if you know this and you know how to manage it. But you have to be prepared with it. Otherwise, you may have to cut a sorry figure intraoperatively. And this jugular bulb is covered by a good bone over here. See this, and this is the round window. Another factor at this level, what you can, I must emphasize, the distance of the facial now from the round window, vertical facial. As I said, in all difficult orientation of the cochleas, the round window goes medially and posteriorly, and then it comes closer to the vertical portion of the facial now. So the distance between the round window and the vertical portion of the facial now, see this, that is the vertical portion of the facial now. I show you a separate, cut of the cochlea to show you the vertical course of the facial now. See this. This is double oblique coronal section. You can ask your radiologist to reconstruct, or you can reconstruct on this software yourself. This is double oblique coronal, and this gives you the best idea about the entire course of the facial now, vertical, genu, horizontal, right up to the first genu in one section. In middle ear surgery, like next case cholesteatoma, how useful this information is. If you relate your pathology to the facial now, if you want to see any dehiscence of the facial at any level. So what I mean to say,
doing in atresia also, Satish. This
yes.
you told my radiologist.
Atresia surgeon is woken up, my dear. So this is very important. Very much important, Ashish. Your point is valid. This point, this why is saying Ashish so. In atresia, the facial nerve course is abnormal. Many a times in the facial nerve course, in the middle ear is abnormal, and that you can pick up by radiology. I have seen one of the patients at Ashish's place where he was doing some hearing reconstruction in the atresia, and the facial nerve was quite anterolateral. Quite anterolateral, few millimeters lateral even to the annulus in the lower part. That was surprising. And if you are not prepared with the radiology, one can easily injure that facial nerve. Thank you, Ashish, for making this point. So, in radiology, you have to be careful about all these things, that how your radiology can save you from a lot of issues. Now, the next situation as we go down, we have seen this jugular bulb. The next situation is, see what is this? Carotid artery.
Yes.
See, this is basal tunnel of the cochlea, and we saw in the dissection many a time the bone separating between the cochlea and the carotid is very thin or sometimes absent. And this bone sometimes absent, it works like a third window phenomena, where the current, the sound energy reaching the inner ear is leaking through one of the windows in the inner ear, and sometimes it works as a third window. Not only that, in cochlear implantation, there are certain reports, publications mentioning this, where the implant inadvertently went into the cochlear canal, the carotid canal. So, particularly in patients or the surgeons, when they are using cochleostomy approaches and happen to go to the infracochlear region rather than inside the cochlea, can happen to reach into the, Eustachian tube, carotid canal and all these areas, if they are not careful. And if this carotid is descent, when you pass your electrode to the round window even, in the basal tunnel of the cochlea at 180 degree in front, the electrode may go straight into the carotid canal if it is descent. So this is so important to understand the anatomy on the CT scan, that how your cochlea is, how the relationship with the round window to the jugular bulb, posterior canal, the carotid artery. Sometimes the facial nerve here is very superficial. In one of the case, I can never forget, one of the case the facial nerve was so lateral, and we found this on radiology, and we did that, the same thing we did by the retrofacial approach, where the round window was easily accessible rather than going to the posterior tympanotomy. So, by means of a pre-op radiology, you can avoid all these difficult situations as a surprise, which may you otherwise come across during surgery. So, radiology has a big role. You need to have a three-dimensional fine-cut CT scan, because every information, if single information you want, sometimes you get in a better way in a different section. Like for example, cochlea. A lot of people measure the length of the cochlea. And this is sometimes important. If your cochlea or a cochlear duct is 35 millimeter long, 30 millimeter long, 25 millimeter long, in cochlear hypoplasia, if it is so small, you cannot implant at the same regular electrode in every patient. We all know we are not supposed to implant deep into the cochlea beyond certain limit, beyond the spiral ganglion. And here, there are a lot of people, they use certain, tricks, certain formula to calculate the length of the cochlea. And this view of the cochlea, particular for that, to see this is double coronal oblique view. And this gives you the entire length of the cochlear duct in one view. Similarly, there are views like for the, for the superior semicircular canal, like see this is superior canal view. Entire superior canal can be seen in one view if there is any dehiscence. This is also called as a vestibular aqueduct view. This is vestibular aqueduct, and in case of enlarged vestibular aqueduct, you can have a fairly good idea of the entire course of the vestibular aqueduct in particular view. So we need to know, once we see the CT scan ourselves, that what structure to be seen in what particular view. This is important so that we can get fairly good information or get the maximum out of the given CT scan, the maximum information we can gain for that particular patient. So,
are these a part of the software? You can say the superior semicircular canal view and it will show you?
Yeah, you can yourself cut.
Okay.
See
now,
this cut.
Like...
See, this is the line. I cut this section in this way. What this is? This is transverse, this is sagittal, and this is sagittal oblique. When you go sagittal oblique, you will get a superior semicircular canal view.
Okay.
This is double oblique coronal. Coronal, then you reconstruct to coronal and then again oblique on the coronal. That is double oblique coronal. And in this way, you get the complete information of the facial nerve as well as the cochlea in one view. So this is
Dr.
how.
Satish,
Yeah.
hi, you are working on Windows or Mac?
Pardon?
You are working on Windows software or Mac
This is
software?
Radiant Dicom. This is Dicom viewer.
Dicom. Okay, okay. So we have actually, if you see now, so we have our software for the Mac as well. What you call it as an Osirix software.
Osirix is same.
And yeah, Osirix is absolutely same.
Yeah.
And as we have clearly demonstrated, please ask your radiologist, the team, to give you either it in a pen drive or maybe they can transfer the file as a PDF.
I always mention to acquire CT scan on a DVD or a pen drive.
Yeah, so
because
just transfer it to your software.
What we are getting is in complete information and dynamic information. For example, if you order a CT scan and patient bring you few printouts, what exactly that is? One printout may have 15 to 20 pictures, you may have 3 or 4 printout. This area scan, you know, how many slices here? Almost 400 plus slices we have, number one. And that too, we get dynamic information. Any structure I want to see, I can see in all 3 planes.
All 3 planes, yeah.
Like for example, the round window, I can see round window in all 3 planes. See this round window? In coronal, see the round window here. It is such a learning tool, such an important tool, giving you 3-dimensional information. It gives you complete information. Like for example, in this patient, if you want to see the semicircular canal, suppose, in a simple printout, whatever given to you, you may miss the canal dehiscences. For example, see this. This is the vestibule. Can you see the vestibule?
Yes, yes.
Now, if you want to see the superior semicircular canal as a whole, dynamically, now see, I am going,
we can see.
Even if there is a smallest dehiscence, I cannot miss.
Yes, yes.
See this? See the lateral canal. I am following the lateral canal till end. See, this is ampullary and non-ampullary end. See completely?
Yeah. Opening into the vestibule, you can see it very beautifully.
See, this is posterior canal. See, posterior canal forming the crus commune with the superior canal. See this?
The superior canal. Yeah.
Entire thing, what you see is dynamically, which you cannot get in printout. And a printout is too inadequate an information to plan your surgery properly. This is the need of the time to see all this information on a dynamic scan. You yourself need to see, because all these angles, line, length, your radiologist is never going to give. We tried. Initially, we made a proforma like I showed in the otosclerosis last time. We made a proforma having 380 points given to the radiologist. In 3 days time, he came back, boss, sorry, I am not going to do your scan anymore in future. I cannot do this. This will take more than 3 hours to report that. And for that matter, that is useless even if he reports. Because you don't have 2 hours to read that report. And that too again is static, not dynamic. What you see dynamically yourself is a different information, which is, unmatchable by all means you get. So this is about the CT scan. Then another thing I would like to mention here.
Just don't mind again that surgical orientation of the posterior tympanotomy with those 2 parallel lines with the posterior, just before you go for the surgery.
Yeah, see Ashish. See Ashish, for everyone again. This is facial now, can you see?
Yeah.
Now, if somebody shows you on a printout, this is facial now, I cannot believe it. Unless I see dynamically that it is facial now. How will I see? See this. See this? This is horizontal course.
Yes.
And this is following this. This is the vertical course. Can you see now?
Yes.
Here is the chorda tympani. Can you see this now? Small now?
Yes, beautifully, yes.
If you want to see chorda, you can see how it is arising from the facial.
From the, yes.
Lower down.
Yeah.
Chorda arises few millimeters above the stylomastoid foramen. And then it is going towards the annulus. See this? Now this is the difference. This is the distance between these two. Okay? Very clear?
Very clear, yeah.
Now this distance is here, this one. See this, Ashish?
3.01,
yes.
okay.
Now, what is going to be your approach? My approach when I come from postoral region, this is my postoral area.
Yeah.
My anterior limit will be the posterior canal wall. See this posterior canal wall all the way?
Yes.
This will be my anterior line, okay? Of visualization, limit of visualization. I cannot see beyond the posterior canal wall anteriorly, okay?
Correct, yeah.
Right from lateral to medial.
Yeah.
Now my posterior limit is what? Facial nerve.
Facial nerve. Yeah.
See, this is the facial, the anterior border of the facial nerve.
Yeah.
Now this posterior tympanotomy, we all know, is a narrow area. Area of few millimeter, 3 point something millimeter, through which we have to go in the depth to look at the round window. Now this area is here, same between these two lines.
Yeah.
Now between these two lines at the level of the round window, see this. This is round window and this is the complete length.
Basal ton, yeah.
Basal ton where you want to implant.
Yeah.
This is so favorable.
This would be the easiest of the surgical situation.
Yes. So in order to see the visibility of the round window, how easy it is, you can use this. But see, once you are experienced, you don't need all this, because any given situation of this, difficulty of the round window, even if you come across intraoperatively without having a CT scan before, if you are experienced, there are so many maneuvers by means of which you can still find out an implant. But this is important for the beginner and for teaching point of view. This is very, very important. Now another thing which we need to see this is jugular bulb.
Yeah.
This is round window. Close to the round window, can you see this small duct?
Yes.
What is this?
Cochlear.
Cochlear aqueduct. Cochlear aqueduct is a narrow aqueduct, is a perilymphatic duct, which the lateral end of which is opening close to the round window. Within 1 millimeter of the round window. Within 1 millimeter of the round window, you see this cochlear aqueduct lateral end, and medially here it opens in the posterior cranial fossa. And this is in very close proximity to the superior part of the jugular bulb. In surgically, in the Thursday, we have an acoustic neuroma case, and we'll see this is one of the most important anatomy, inferior limit of your translabyrinthine approach, that is cochlear aqueduct. But here in cochlear implantation, it is a different role, because a lot of people involve that enlarged cochlear aqueduct, which is communicating to the subarachnoid space medially, can lead to a gusher, because it has a communication with the perilymphatic space. It opens in the round window. Actually, this has been believed, but so far, not a single report implicating an enlarged cochlear aqueduct in gusher is not reported.
Gusher, yeah.
Most of the time, our gusher is almost always an abnormal communication of the inner ear to the intra-auditory meatus through a defect in the cochlear aperture that leads to a gush of the cerebrospinal fluid into the inner ear. This is rarely implicated, but for cochlear implant surgeon, this is important to understand. This cochlear aqueduct is a very, very important anatomy, and this is responsible. It has been proven by several studies. It is the connection which is responsible for transmitting the meningitic infection from the CSF space to the inner ear. So, post-meningitis, particularly pneumococcal meningitis, when it involves the inner ear, the infection spreads through the cochlear aqueduct into the basal ton of the cochlea, the scala tympani of the basal ton of the cochlea, which is the first area to be involved. And then from the infection goes to the other turns to the helicotrema, then to the scala vestibuli, then the vestibule and other areas of the inner ear. That is how it spreads, and that is why when the ossification starts, this starts for the first time, or to begin with, the ossification starts in the basal ton of the cochlea. What's my point? So cochlear aqueduct is responsible for spreading the infection of the inner ear to the inner ear from the from the subarachnoid space. Now we have seen the
deviate. Can you point out the singular nerve? Where is it likely to be here?
Yes. See, let me show you. This is intra-auditory meatus.
Yeah.
Singular nerve supplies what? Posterior semicircular canal.
Yeah.
Singular nerve leaves the intra-auditory meatus few millimeters before the fundus of the intra-auditory meatus. Few millimeters before the lateral end of the intra-auditory meatus as a separate canal. And see, this is intra-auditory meatus. Keep an eye.
Yeah.
My posterior canal is here.
Yeah.
See this, keep an eye. Keep an eye, keep an eye, and this nerve.
Yes, beautiful, yes.
See, this is posterior canal.
Yeah, lovely.
This is the nerve, very small nerve going to the posterior canal. Can you
Fabulous,
see?
Yeah.
Can you see very clear or not? This is singular nerve. I know why you are asking.
Yeah.
In the cadaver, I demonstrated singular nerectomy, transcanal. You can do a transcanal singular neurectomy in a resistant BPPV, recalcitrant BPPV, where Apley's maneuver and all those, everything fails. And this was popularized by Gesek as a very important procedure. Believe me, we have done a few. You can do transcanal, and it's a very small procedure. Just elevate the flap. Just elevate the flap, go behind the round window. Little bit curate is required, like we do for the stay piece. Expose the round window and just medial to the posterior edge of the round window. Just medial to it, drill with a small burr, diamond burr, 1 or 2 millimeter maximum. You will find the, this nerve arising from the intra-artery meatus and going to the posterior canal. Exactly here you will find. See this singular now. Now see this, Ashish, what I was saying. This is round window.
Yeah. Right
see,
there.
I am going medial to it. Just a minute.
Yeah.
Now see the singular now.
Yes, absolutely. Yeah.
See how close it is to the medial edge of the round window, and the moment you transact it, this is the answer for BPPV.
Yeah.
When other thing fails. So this is about the. We'll see the anatomy of the inner ear from different perspective in different situation. Now coming to the important aspect, I told you the basic functioning unit where the cochlear implant is feasible or not, is that what you need to see through the MRI. MRI will tell you whether the cochlea has fluid or not. For a cochlear implant to be effective, our cochlea should be fluid filled. If there is no fluid, how the implant is going to function, how the implant is going to be inserted. Like I mentioned about the meningitis, post-pneumococcal meningitis, this is one of the major reasons for the cochlear ossification. And if that ossification happens to occur, how will one insert the implant? In the early ossification, there are many ways you can drill out the basal turn. If the scala tympani is full, then you can go through the scala vestibuli. You can, if that is again ossified, you can go through the scala media. Even if that is ossified, you can make a complete trough all around the modulus and at least put some electrodes to stimulate the sensory epithelium. So that is one of the most difficult situation. And how you can rule out? See this. What I see at this, sequence of the MRI is this. This is 3D cis image. This is 3D CISS cis image, constructive interference image. And this gives a clear picture of the CSF, bright, prominent, and the nerves as a dark things in the white background. Can you see? Now, this is cerebellopontine angle of this side. See carefully. See the nerves emerging from here. See the nerve emerging, and what is there anteriorly? This is cochlea.
Dr. Satish, you can zoom in a little bit. So that would be better.
Yes.
Yeah, better.
Can you see the cochlea?
Yes.
This is the basal tongue, this is the scala tympani. In between is the partition, and this is the scala vestibuli. So what is this? Is the osseous spiral lamella in between. This is scala vestibuli, this is scala tympani. We discussed this anatomy detail during the temporal bone day. What is scala vestibuli tympani? And this is the cochlear aperture. See what is this black? This black modulus is because of the modulus, because modulus is a bone. And bone in every sequence of MRI is dark. So this is modulus, and see carefully what is emerging from here. See this now?
The cochlear nerve.
See this cochlear nerve. So this is vestibulocochlear nerve. See, cochlear nerve is going anteriorly here, and vestibular nerve is going behind to the vestibule. Can you see this?
Yes.
Very clear?
Very clear.
Yeah, and see here the vestibular nerve goes. There is little bit of the thickening of the vestibular nerve here. Can you see this?
Yes.
This is Scarpa's ganglion.
Yes.
This is where the ganglion of the sensory ganglion of the vestibular nerve, which you find as a thickening over here. So this is a 3 Tesla MRI where dynamically you can see all the nerves intact. Number one, you see bright CSF as a CSF has a bright appearance. This is pure CSF. This is vestibule, and these are the semicircular canals. And behind is the vestibular aqueduct. You can see very clear. Can you see all these structures? And that is the posterior fossa dura. So on MRI, you should be able to see, for feasibility of the implantation, a fluid-filled cochlea and the intact cochlear nerve. This is what Sumit was saying in the beginning about the cochlear nerve. Sometimes this cochlear nerve is thin. Suppose like on the CT scan we saw, if you see a narrow cochlear aperture or a narrow intra-artery meatus, giving us a suspicion of a thin cochlear nerve or absent cochlear nerve, you have to actually confirm on MRI. MRI is the imaging of choice for the nerve to be seen. Now, in other three-dimensional reconstruction, if I see the sagittal MRI, if I see the sagittal cut of it, I can show you that all the 4 nerves in sequence in the intra-auditory meatus, and there you can have a fairly good idea that how the nerves are oriented. This is sagittal. See this?
Dr. Satish, one thing. Do you ask your radiologist to do always a T1, T2 for the sequence for the MRI, or
all sequence? We get all sequence done, because here role of the MRI is not only to give us details of the inner ear structures. When we are getting MRI, we need to look at the overall brain. If there is any central pathology which may have an impact on the implant overall. In many of the situations, particularly in prelingual children, you have some associated central pathology in the brain as well as, which can have a significant impact on the outcome. Like many of the patient has cytomegalovirus infection, white matter lesions, so many lesions, which can have a negative impact on the outcome. Now see, this is the sagittal cut of the inner ear. Again, in a printout, you will find this cut. You don't know which nerve is going where. Now let me show you. See, this is the orientation of all the 4 nerves. What is there behind? These 2 are vestibular nerves.
Yeah.
Can you see here anterosuperiorly? This is facial nerve.
Yes.
And this is cochlear nerve. Now how to see dynamically? See the cochlear nerve going to the cochlea. Can you see this cochlea?
Yeah.
On sagittal cut. And see, this is the cochlear nerve which was going to the cochlea. Can you see very clear or not?
Yes, yes.
That
Dr. Satish, important here is to see the diameter of the facial and the cochlear.
Yes,
that can definitely tell
important.
You
Amazing point it is. And this, I remember, I asked one of the case, we had a thin cochlear nerve. I called up Kirtner sir, long back it was. He said, compare the diameter with the facial nerve. If it is smaller than facial, then it is hypoplastic, otherwise okay. And
yes,
that is what the point. See this. This is the facial nerve. This is the cochlear nerve. And if the dimension of the cochlear nerve dimension is otherwise bigger than the facial nerve in normal situation. If the dimension of the cochlear nerve is smaller than the facial nerve, it is considered hypoplastic. And then it is a big dilemma. If you don't see a cochlear nerve, sometimes you get a very, very thin cochlear nerve. I give you an example. Just 1 minute's time. What was that patient? I give an example to corroborate that, what I'm trying to say. What is thin cochlear nerve? Just a minute. See this.
In fact, Dr. Satish, many places people don't have the access to all the scans like you are having on DICOM. So they
you have to, boss. You have to, otherwise you will miss. See this. This is the example. This patient we have now in the pipeline to implant. This young patient, this 3-year-old baby, has a thin cochlear nerve, and how did we pick up? See, it is so important otherwise to miss. See this. How's the picture?
Yeah, perfect.
Now, first I am showing on the right side here. See, this is cochlear aperture. There is no nerve. Can you see?
Yeah.
It is absent cochlear nerve on the right side. Can you see?
Yes.
Absolutely. Now look at the left side. Look at the left side, and what is there? See, this so thin,
very thin.
Very thin cochlear nerve. And I refer this patient to Ranju. She did added audiometry. I discussed with Kirtner sir as well. This patient sir must be remembering. And we did an added audiometry, and we got some responses at 1K. And that is how we discussed in the beginning, how important it is. It is so clinically important to have added responses rather than relying on E-BERA, that this thin cochlear nerve still is an indication for the implantation for this child rather than sending for ABI. Even the best result of the ABIs are below par the results of the, even below par results of the cochlear implantation. So that is never a first choice. So this is how you can, make out how the cochlear nerve is, a thin cochlear nerve is, and just a minute. Oh,
And one thing, Dr. Satish.
Yeah.
Pawan Singhal wants to know what means about the rotation, cochlear rotation, what exactly it is, and
cochlear rotation is. See, I tell you. First of all, this is a misnomer. Cochlea never rotates. Cochlea is what exactly at the time of birth remains till adulthood. It is the location of the cochlea in the cranial bones. In relation to the cranial bones, it looks rotated. It never rotates. It is the cranial bone, the morphology of which changes and looks like pushing the cochlea in a different position. Cochlea remains in the same position. The surrounding cranial bones rotates and they push the cochlea in that position. And that is what, in that situation, if the cochlea rotated, suppose, and if it is rotated in this way that your round window is pushed posteriorly and medially, it may be difficult to access to the posterior tympanotomy. And that you can make out from the CT scan. If it is, I will tell you the maneuver during surgery, how you can overcome that situation. So on...
Dr. Satish, can I add something?
Yes, please.
There is a very beautiful classification, St. Thomas classification of the round window access, which you can grade it intraoperatively. And you're right, it's a misnomer. Many times the surgeons, when they fail to achieve a scalar tympani insertion, they say that the cochlea was rotated intraoperatively. So it is actually the radiology which you should be able to read very well before you take up a patient, and you can identify how much difficulty you may face by approaching the round window, and which you can see radiologically as well as confirm intraoperatively also.
Yes, absolutely. And you know, this radiology is so important for us to understand, and you can go through certain publication, and one of the very important publication, you know, our own Dr. Neelam Ved had published. Her husband is a radiologist, and through their coordination they published a very important paper on radiology of the cochlear implantation, a structurally, clinically relevant report. What a surgeon need to know from radiology when it comes to cochlear implantation. So this is what I mentioned here is a dynamic way of assessing the radiology to get maximum information out of the radiology for that particular patient, and then we'll move on to the surgery. Sir, you want to add on something?
Just a few points. The facial nerve, important you said. If you have an abnormality in the vestibular labyrinth, if you have a hypoplastic lateral semicircular canal or absent lateral semicircular canal, the chances of getting a facial nerve abnormality are much higher.
Yes, sir.
And usually it will be displaced anteromedially. It may even run over the promontory.
Yes.
And the second thing is, you talked about the deficient nerve. The radiologist will call it deficient. He does not commit that it is absent.
Yes.
If you have a nerve which you cannot see and you've got a deformed cochlea, say you've got an incomplete partition 1 where the development of the cochlea got arrested early, you may have the cochlear fibers running along with the vestibular nerve fibers. And that's why even if you can't see the cochlear nerve, like you said, you asked Ranju to do the audiometry, you may not see the nerve, but the fibers could be running along with the vestibular nerve and you may not see them. Lastly, the MRI, very rightly you pointed out, you have to look at the central nervous system, because you can have few malformations, be it patients with absent corpus callosum, things like that. But if you have white matter dystrophy, what you call leukodystrophy in the temporoparietal region, then the central processing of sound may be poor and you may not get the outcome of a cochlear implant that you want. So looking at the central nervous system should be an integral part of the evaluation.
Yes, sir.
Lastly, one point, a lot of the senior surgeons, experienced surgeons are now saying that in children, they are not doing a CT scan as a routine. They don't want to give that radiation to the child. They do an MRI, and some of them say, well, if in the MRI we find an abnormality, which is in about 20% of patients, then we would go and do a CT scan to see the course of the facial nerve, etc. But otherwise, they say if we do an MRI, it may be sufficient for them to go ahead and do a cochlear implant without doing the CT scan. Only reason being that they want to avoid radiation. So this is a general trend that is coming with some of the senior surgeons.
Sir,
what I would say is that for the novice surgeon, it is better to see a good CT scan, study it, and as Satish put it, you have to read your scan yourself. The radiologist reports to you, but you have the advantage of knowing the internal anatomy of the temporal bone 3D because you do so many mastoid surgeries. So you will be able to read into it much more than a radiologist can, and it will be in your head as a 3D map for you to know whether you're going to anticipate any trouble. So learn to read your own scans. Don't purely go by what the radiologist says.
Sir, can I add 2 points here, sir?
Please.
Like, but the one point you mentioned about the need of CT scan, some people don't get CT scan and get directly MRI done. If there is no malformation, they can go ahead with surgery.
That's right.
That can be done by the experienced surgeon, but there are certain anatomical details because MRI doesn't give any bony detail.
No.
You can get from CT scan only. How big your mastoid is, how is your dura, how is your sinus, how your, overall space where you are working, it cannot be gained without CT scan. Nowadays, regarding the radiation hazard, I mentioned in the beginning, we get cone beam CT scan done. Cone beam has much less radiation. Like
yes,
I recently...
I'm just talking about some experienced surgeon who says whatever the configuration of the mastoid, I can do a mastodectomy, so I don't want to do it. We still have both the CT and the MRI done because we
it's
have
always better to get done. Once you are doing such a major surgery with patients, lakhs of rupees are involved, and you may have to cut a sorry figure because of lack of anatomical details, and you get a difficult times is not warranted rather than getting a good CT scan done, that to a cone beam with hardly any radiation. Number one. Number two, the point you evaluated by the facial nerve, sir. I mentioned also, and your point is valid, the facial nerve, in a regular situation, the surgeon must be aware of two things regarding abnormality. One, like sir said, during abnormality of the semicircular canal, lateral canal. One of the commonest abnormality in the inner ear is lateral semicircular canal abnormality. And in those situations, the abnormal facial nerve is very highly likely. One has to be careful once you are going by the posterior tympanotomy approach. And other I already mentioned, like Ashish mentioned, microtia surgeon, about the course of this nerve in congenital ears, sometimes very lateral. And that's a valid point. And I expected this from Ashish. Ashish, is a complete ear surgeon right from external to inner ear. There are few people who do external work, few people who do middle ear work, some people do inner ear work, but he is the one who does all, external, middle and inner. And that is that is the important point which has come
now
up.
With your and Kirtanes's help, we are going to do the implants.
Oh, Kirtanes sir has helped so many, so he is always ready for all this.
No, I already have his permission.
So, do we go ahead with the surgical part or any questions pertaining to that?
Is it possible that absent cochlear nerve with normal cochlear aperture?
Boss, I tell you, the absent cochlear nerve is a difficult terminal. I showed that on MRI on one side it was absent. Absent with absent.
Yeah, you can say hypoplastic
Hypoplastic is
nerve
one
with
situation.
normal aperture.
Like sir said, sometimes you don't see the nerve at all. Still you get responses, and sometimes these fibers may have been passing through the vestibular or other nerves, and that you may not see on a cochlear nerve per se. That is one. In spite of a hypoplastic cochlear nerve, the development of the inner ear is not affected by the cochlear nerve. In spite of the cochlear nerve which is related or connected to the cochlea and supplying the cochlea, whatever, it is not affecting the inner ear maturation. So we always assess the cochlear nerve, like sir said, even if some fibers passing through, still CI is indicated. All we want to tell patient is a guarded prognosis, because if CI doesn't work, then only finally we should go ahead with the ABI or something else. But in spite of all odds, the CI is the first choice, giving a guarded prognosis to the patient. Subhrendra sir, you were reading something.
Satish, I think one of the reported complications in cases of wide cochlear aperture is misdirected electrode into the internal auditory canal. It's not only for the gusher, but sometimes if it is especially the modulus hugging kind of electrodes can get misdirected into the internal auditory canal if it is a very wide aperture there. So, but it's very, very uncommon.
Yes, sir. Yes, sir. We will discuss all this in the complication part. Yes, boss?
Any indication of contrast MRI for CI cases?
Yes. Yes, that is important, and I tell you the reason for that, and we get done many a times. And Mostly earlier we used to get this for other purpose, but now for the implant as well. What is that? Not for regular patients. That is a 3D flare sequence. That is a contrast 3D flare sequence which gives you earliest indication of any biochemical change in the inner ear fluid. Now, first of all, how we started getting done? Started earlier for the acoustic neuromas when we plan in patients showing good response on pure tone audiometry, not having good speech discrimination. On 3D flare, you will find some abnormal signals in the cochlear fluid indicating that the hearing loss is already, the cochlea is already affected. Even if you preserve the hearing by go by any hearing preservation approach, it is actually not going to preserve the hearing. Second, then we started getting that because that gives you earliest change in the inner ear of biochemical change. Then we started getting for the sudden sensorineural hearing loss patients to prognosticate. All patients of sudden sensorineural hearing loss, they come and ask, doctor, will it come back? Will my hearing come back? One of the tests which is highly sensitive to answer this question if the patient comes early is to get a 3D flare MRI sequence wherein in a slightest change in the biochemical composition of the inner ear fluid will tell you the prognosis. If the change has occurred, then it is unlikely to recover. Many of the patients do not recover and many recover. And those are the patients who do not have any change on 3D flare, absolutely normal. Your steroid and other treatment do well. So this is to prognosticate. Here in the CI as well, many a time you don't get membranous abnormalities, on the MRI and CT scan, but yet the things going on in the cellular level, in the biochemical composition, you can get in the 3D flare MRI. So that can have a value. We are working on it, but not, propagating this for many patients, but it has a role.
So your experience, Ms. Kitne sir and Satish, your experience with different syndromes like Down syndrome, implant in these cases, what is the experience?
Yes, see, for any syndrome is always a difficult situation. Let me give you. These are some of the syndromes which are commonly associated, with the hearing loss, and which are common. There are many or more syndromes which are associated wherein children born with a sensorineural hearing loss or develop sensorineural hearing loss, an implant is the answer. But you have to be careful in certain situations. Like we had 2 patients with a Jervell-Lange-Nansel syndrome. This is one where the patients have a propensity to develop cardiac complications, arrhythmias. They have a large QT interval, and any episode of tachycardia can lead to a cardiac arrest kind of a situation. So all these bronchio-otorhinal syndrome, all these patients have different complications associated because of the systemic syndromes. So you have to be involving your the physician into the workup to get clearance of any systemic implication of your cochlear implantation, anything which required to be taken care of particularly, or any special precautions to be taken. So these are the syndrome wherein still implant is indicated. Implant for any given situation of sensorineural hearing loss, if your basic functioning unit is there, implant is going to work. It may be a complicated situation surgically, but still the implant will work.
Would you recommend pre-operative assessment like 2D echo and other things that ultrasound abdomen in all the cases?
Yes. 2D echo now we are getting in all prelingual children, because you never know if they have some abnormality.
Protocol now.
Yes, it's part of the protocol.
Dr. Satish, can I make a comment?
Yes, boss.
Yes. Many a times families come where they don't have adequate funds and they cannot get all the investigation. So they get the audiometric evaluation, the OE and the BERA, and they are not ready for the implant. They don't have the money. The child is about 6 months or 8 months, and the audiologists try and fit them with a hearing aid. So my word of caution is, please do get an MRI at least first to see the nerve, because sometimes you might just fit with kids with hearing aids costing about 30,000, 40 or 50,000, and you have an absent cochlear nerve which you don't check up before you give them hearing aids. So if they are short of money, at least get an MRI done, counsel them, and sometimes MRI getting in a 6-month-old child will require a sedation, and it is best to get both CT and MRI. They might not be ready, they might come back to you after a year, but at least your audiologist can fit them with a good amplification device, and they can start therapy. The parents can start therapy at home. So the presence of a cochlear nerve at least helps you that he will get some auditory stimulation with the hearing aids.
So you recommend hearing aid trial in all the cases of CI?
How
long?
Our protocol is to recommend all for few months.
What age we get the patient. But of course, as I say, that hearing aids don't help the child, but actually prepares the child to wear something on the behind the ear. That mental stability, that acceptance of the child. Trust me, we have seen kids who have thrown their processors for the initial 5 to 10 days, and we tell them that, and the parents say that we are wasting money. So what we do at our center, we have few used hearing aids which are being donated or which are being pooled. So if the parents plan for a cochlear implant within a month, we don't charge them for the hearing aids. So they return it back to us, and because see, all of these kids, all of these profound deaf require high power BT hearing aids. Okay, and it is nothing rocket science that we are giving them different channels or different programmings in that. We just need an auditory stimulation. So if they convert in a month's time, we don't we get this hearing aid back from them, and we do the cochlear implant surgery.
Rajiv, there are 3 reasons for doing the hearing aid trial. One is documentation, that look, we are doing the cochlear implant because the hearing aid didn't help. In this day and age, I think it's better to have that documentation. Second is conditioning. The child learns that it has to sit with that implant. It learns to work with that therapist. Otherwise, the child just comes in and starts crying. And third, as he said, certain children may have behavioral problems. They may take it out, break it. So they need a little counseling, and they get used to wearing it. Otherwise, you give a beautiful processor to a child after an implant and the child breaks it. It's disaster. So these 3 things really important. I have patients who are told by some people, why was an implant done? You never required hearing aid, would have done the job. It's documented that no, we've gone through a hearing aid trial, so nobody can say afterwards that it was not necessary. So in this day and age, I think that little documentation is also important.
Are you getting any picture, sir?
Yeah,
beautiful picture, yes.
Yeah.
So now we are ready with the surgical part, and this is microscopic picture.
Yeah.
How is the picture?
Dalmia has also joined us.
Pardon?
Deepak Dalmia is with us.
Hi, Deepak.
Devang Gupta is with us. Devang Gupta is with us right now.
Hi, Deepak, Devang. Good to see you. Deepak is always, involved, and he comes up with good questions which are very, very relevant, practical.
No, so, Deepak is a very experienced cochlear implant surgeon. He's also
all-rounder.
People now.
All-rounder.
Yeah, he is maintained.
So, how is the picture, boss?
Perfect.
Yeah, very good. Perfect.
वो करूँगे white balance करना. White balance. Just a minute. हाँ करो. Ata.
One thing is left, correlation between IQ and the cochlear implant, means method of assessing IQ at the time of implantation. How valuable is at what level, means if IQ level you will start, you will say that this patient is not fit for the implant, sir.
IQ.
Yeah,
that's why I mentioned in the slide the language, cognitive part, psychologist evaluation, family conditioning, family involvement. See, that's why these children need to be counseled along with parents for so many sessions. I have seen Ranju taking almost 20 sessions per child, sometimes hours and hours of conditioning, and that gives you ample of opportunity to assess not only the child but the parents as well.
Yes.
If you don't have a committed patient for the committed parents for the child, the implant program may not work well. The particular implantation you do is not going to work well. So this picture is on the right side, and the first important thing starts with the incision. And mine is a very simple incision. This is a simple retroauricular incision, Yes. Below, I don't need to go much. That is not our area of interest. Superiorly, I make a little bit lazy S, kind of an incision. We have already infiltrated with 1:2 lakhs. And this is my initial incision. The incision is not very big. And this incision, this initial part is very important in implantation to avoid infection related issues. Flap necrosis and infection, this is what this important part is. This incision.
Satish,
yes?
Do you like to mark the templates before you give the incision, or you have
I can mark later on also. Yes, that is. If you want, I can mark it right now. Here we are. This is an important point from Sumit because this is what the patient going to wear. And what we need to do when we implant, we put our processor here, the BT processor, this thing, it should not overcome the implant. So this is how the processor patient is going to win.
What about pre-operative preparation, like hair shaving and etc.?
Yeah, a little bit, 2 inches shaving, not entire hand. We do little extra shaving than our regular otology procedure.
You do in OT only, this shaving?
Yeah, just half an hour before.
Okay.
Secondly, we don't use too high concentration of adrenaline. We prefer to wait for half an hour or so, 20 minutes or so for the effect to come. Third is minimal use of cautery. Here the tissue respect is very important, and respecting the vascularity of the ear is important. This incision is very well acceptable from vascularity point of view. This part of the ear is supplied anteriorly through the superficial temporal artery branches, which gives the parietal and the occipital branch, and this area is supplied with a combination of the occipital branch and the posterior auricular artery. And this superficial skin incision doesn't go across any of the vessels, number one. Number two, this part of the pinna below is supplied by the occipital artery branches, and which are very well preserved. So this is a very acceptable incision. Second thing, the depth. Since I am going to secure my implant underneath the flaps, I will raise the periosteum flap separately, and this is the skin incision. And in order to prevent the exposure of the implant, the best policy is to prevent the incision falling on each other. The incision lines are falling on each other can easily give way in case some infection happen to occur, and then can result into exposure of the implant. Infectious complications are most frustrating, not only to the patient but the surgeon as well. And this is something where even the implant company is not going to help you. In case the infection is severe and warrant explantation, that is something not going to be helped by implant company for the next implant. So you have to be very, very careful. Respect the tissue. Don't use too much of adrenaline. Minimal cautery and no tension suturing. We'll see all these factors as we go further. And second is no loss of tissues, so that the tension suturing is not required. So what I'm doing, majority of the time, most of the work I'm doing with a knife. You have seen me operating with cautery every time in these webinars. Everywhere I'm fond of cautery in the head and neck. But here this...
Hello?
Hello?
Satish boss?
Yes.
Is it advisable to use bipolar only rather than monopolar whenever the user we need to control?
No, it's not like that.
Okay.
Monopolar is even safe, no issues. Though the company recommends not to use monopolar once you open the implant.
Yes.
Though so many studies have been done rejecting any complication from the use of monopolar cautery by to the implant array, electrode or anything, nothing happens. But you have to follow the company instructions.
Guidelines.
Why to fall into problems?
Yes, sir.
So what I am making, this is a simple incision. I am making this superficial flap, and I will go all the way to the level of the extraordinary canal. And here we are not supposed to expose the extraordinary canal. That is the advantage of this approach, that you don't communicate to the region when there are already bacterias, the regular bacterias in the canal, and that's why you are not supposed to open. In case by mistake sometime happen to open the canal, you can immediately suture that. Okay, that is the anterior limit, you can see.
Yes.
Now I have to make a superiorly based flap here to cover my implant completely, and for that the periosteal flap, musculoperiosteal flap, I am doing this undermining. This is the again the simplest of the flap you can think of. Very simple, superiorly based, so that I can cover my implant to prevent exposure. Now my inferior limit is the mastoid tip. Here is the mastoid tip. And what I can do, this is my anterior limit, you see? This is my anterior limit. See, I am staying on the cortical bone. Bang down the bone, right till the bone, towards the tip. See, everything with a knife. I may get little bit of the oozing, which I will control, but I want to preserve the tissue. The cautery results into tissue loss. It may invite infection as well. So I am using more and more knife only. See this?
What are different flaps available, and what are the advantages?
You can do inferiorly based flap, superiorly based flap, even the palva flap, anteriorly based palva flap, whatever. But this we have been doing, and this is something good in terms of coverage of the implant safely. See this? Now this is my inferior part. This is a random flap, and superiorly as I go, I will keep on broadening the flap to prevent flap necrosis. See this?
Broadening the base.
Pardon?
Yeah, base, right.
See?
Satish?
Yes?
What is your antibiotic protocol?
Yeah, at the time of induction, just before that, we give a cephalosporin sulbactam.
Okay.
That's it. One, third generation cephalosporin we give. See, this is the flap.
Yeah, very good.
See, now if I leave everything, my flap incisions are there, here and there. Can you see?
Yeah.
Yes.
And my skin incision is here. So the incision lines are not falling upon each other. Got my point?
That is the advantage of this.
That is the advantage. Number two, I did not use cautery anywhere, resulting in tissue loss. So when I approximate in the end, it should not fall short. Though I will do some additional undermining in the beginning, because once you retract tissues, it falls short by default.
Yes.
At the end of the surgery, when I close, I don't want tissue falling short at all. I don't want any, tension suturing. That is detrimental to the viability of the flap suction.
And what about Dr. Kusum Patida is asking meningitis? Suppose one child develops meningitis, what are the protocol when you ask for the surgery, or what suppose patient is not affording medically or financially, and what are your
Okay. Okay, the patient develop meningitis and need to be implanted, you mean to say?
Yeah. Suppose he is not, patient is not fit for surgery or financially not available.
Okay, then I will recommend Madam Kusum Patida, we must go and see a publication from Dr. Milind Kirtane.
Yes, sir. Technique.
Where he advised lumen keeper. You know what is lumen keeper?
Yeah, put some.
A child who develop meningitis where the ossification is imminent, the cochlear ossification, which may have started by fibrosis, anything, and patient is arranging for the funds. By or any other reason, if you are postponing your surgery, if you don't implant, the cochlea will get ossified, and then you'll lose the opportunity of implantation. So what all you can do? you can acquire from the company a dummy implant. Go and put a dummy implant inside to keep the lumen. So the lumen remain intact and you can do a future implantation any time when the funds are arranged. So this is what something is very important.
What about your vaccination protocol nowadays?
Yeah, vaccination protocol is same like recommended by the CDC guidelines. Our pediatrician is taking care of, but by and large I can tell you, all pediatric patients, we give them first 13-valent conjugate pneumococcal vaccine. If it is below 2 years, 2 or 3 shots now, and then a 23-valent, polysaccharide vaccine. For all adults, 1 shot 13-valent, and then afterward 1 shot 23-valent. Is the picture good there? Yes, pneumococcal. Okay. Pneumococcal. In very young children, along with pneumococcal, H influenza B as well. Now, hope the picture is good.
Yeah, okay.
This is my flap. Now I will get some additional exposure by means of cutting this further anteriorly. See, as I am going up, I am going more anterior, more widening the flap from the base, so that this doesn't get necrose. Because I need to make a well which is completely hidden and away from the area exposed, so my implant remains completely secure inside. I need to go up. I don't want to retract too much of tissues, so I can make this additional incision. And see, that's why I made this, this little bit of the exposure, additional exposure superiorly. And that makes your life so easy. There will be hardly any traction on the tissues. Later on you will see. See this? You have ample of exposure. Go there.
Yes.
And for my implant now there are many techniques for, fixation of the implant. Fixation of the implant is a very important issue. Implant migration is a disaster. You need to fix implant at all levels thoroughly. Here for the processor, for the implant here, we will fix with the tie down holes. There are many ways to do the same thing, to achieve the same thing. You can use the periosteal pocket technique. You can use the periosteal suture technique as well. But what we find the most secure is the tie down holes, which I am going to show you. And some of the papers have compared the 3 techniques and found the tie down holes suture to be the most secure, because some of the patient may require even the MRI in the future. Though we take all MRI precautions, but still these tie down holes give the most secure fixation of the implant. See now, this undermining of the tissue, and this when I put my implant, this everything will cover. So this superiorly based flap completely covers the implant. Completely. That's why this is the best. Now before going further, when I close this flap back, when I close this, I may find little bit of the retraction of the tissues, a little bit of the tension suturing. So what I will do right away here some undermining. Not at the end of the surgery, because in the end of the surgery, this undermining may give little bit of that tissue bleeding. End of the surgery, when you fix the implant, you are not supposed to use too much of cautery.
Yes.
So better you do right now. It will take a minute or 2. See this, this is my... This is very, very important, because this, undermining will give me a good suturing at the end without tension. So I do in the beginning, because many a time it leads to little bit of the oozing. I can use my... Yes. See this? This additional undermining I am doing.
That is to avoid tension.
Yeah, see now how easily it will come in approximation. See this?
Perfect.
You can be rest assured of any tension suturing by this small maneuver.
And that I will do all around to give absolutely tensionless suturing in the end. See this? Almost you know, the centimeter of the undermining. Inferiorly you can do lot of no issues. See this?
That is between the periosteum and subq, right?
Yeah, yeah. I am doing everywhere, all around. Anteriorly you get little bit, you know. You don't get much tissue anteriorly for the undermining.
No, that is the second layer after the skin and the subcutaneous. You have the muscle and the periosteum, which he is doing.
Yeah.
You have the muscle and the periosteum, so he is just creating a
between muscle and periosteum.
Yeah. So the muscle and the periosteum is one flap. The skin and the subcutaneous is the second flap.
Yes.
So the muscle and the periosteum will cover the entire implant, and that will form the first barrier. The second one, suture count for the skin and the subcutaneous.
Yes, exactly, Smith. See, exactly. Yeah. Everywhere I am releasing this tissue, so that I will not have.
I'll just add, Dr. Satish is doing wonderfully. Your muscle and the periosteum should be a very good flap, because that is your lifesaver. If your muscle and periosteum gives 100% good covering, you know, you will avoid so many complications in future.
Yeah. See this? Everywhere I have full undermining. See now, when I repair at the end of the surgery, I have good undermining of the tissue all around. See this? Now put a suture.
Satish boss.
Yes.
Now coming to the antibiotic protocol, is it advisable to give intravenous antibiotic when the tissue is exposed while doing surgery?
Yeah. So that's why the first intravenous shot is hour before surgery. And then you can continue for a day or two according to your situation. This is all prophylactic, you know.
Yes.
This is absolutely otherwise a clean surgery.
Yes.
This is not clean contaminated like you do CSOM and other surgeries. It's pure clean surgery.
Right.
So now this is the exposure and fixation of the flap. No, periosteum. Now we go into the mastoid cortex.
Yeah.
See this? So the bottom line is, in this particular surgery, you have to, you know, spend little extra time to respect the tissue to prevent post-operative infectious complications. Ischemia, infection, all these things can push you in deep problem. एक लगा इधर और एक वो ला. Now, first is I will put this another stage suture anteriorly. See this? So that we don't use any retractors throughout the procedure. Retractor even are sometimes detrimental to the tissues, you know.
Yes, that is true.
So we'll not use any retractor also.
Very often we get emissary vein bleeding very big. So what
yeah,
we just
suture. Yeah, emissary vein you may find here, immediately behind the mastoid cortex. And if it is, you have to control it with some bone wax or bipolar.
Dr. Satish, one more thing, can I add?
Yes, yes.
Since we don't need a very big cortical mastoidectomy for a cochlear implant, avoid dissecting too much of the muscle below the mastoid tip. You know, if you just stay at the level of the mastoid tip, or maybe just a little bit away.
That should be the limit.
Lot of dissection of the muscle and very less bleeding there.
Yeah. Yeah, that's a good idea. Keithness sir, you have been doing differently, you know.
No, I have been using a not superiorly but a posterior superiorly based flap, very similar to what you showed.
Okay, but I have seen you differently earlier, different things.
Yeah, we keep on changing as time goes, no?
I have seen you earlier doing the periosteal pocket also.
Yeah.
Are you still doing?
Periosteal pocket for the implant, right?
Yeah,
posterior superior. Yeah, that you have to. And then we make a well which is tight fitting.
Yeah.
I suture periosteum to periosteum. I don't make bone.
Yeah, that is periosteum suturing, yes.
Yes, I do
So
that.
one is periosteum pocket, another is periosteal suturing.
We do both.
Both, yeah.
But we also drill a well so that the implant gets fixed inside.
Yes.
And then you take the sutures over that.
So this is my exposure now without the retractors. This is without the retractors now.
Yeah.
And now, drill. Our mastoid cortex is exposed here. This is our canal wall, canal flap, and we'll do a sort of cortical mastoidectomy to access down to the round window level, to the cochlea. So the cortical mastoidectomy is used as an access. Like Sumit said, we are not doing a classical cortical mastoidectomy. Rather, we do a, something like irregular margin cortical mastoidectomies to keep our, cable in place. Pardon?
Oh, there's somebody's microphone is on. There's some child talking.
Okay.
One very young ENT surgeon.
Somebody is following you from a very young age.
Yeah, he's junior medic, I think.
No, not from my side.
He's my son, Raju boss.
Okay.
By mistake, sorry.
So this is my cortical mastoidectomy going on. Deepak, you had some, you were mentioning some question at that time when we talked. Anything in your mind?
Deepak, something is wrong with this microphone, I think.
We want you to contribute.
Satish, while he is responding, I just wanted to know that any of the panelists using Varia technique, there's a lot of discussion on that. We do not do that, but any one of...
Sir,
Sir, I'm too junior for that. Hello?
I tell you one.
Hello?
Whatever technique you use. Hello?
Yes, sir.
Yes, please.
Sir, we are at BJ using it. Ahmedabad.
Yeah. So, anybody using whatever technique, my submission is, when it comes to implantation, your implant should go in proper scala tympani without damaging other structures. So, your technique should be able to ensure that your implant goes in a proper scala tympani tunnel without damaging osseous spiral lamella, without damaging modulus, basilar membrane. It should not go across the basilar membrane or osseous spiral lamella into other compartments. And for that, to ensure that, it should be under vision implantation, and this is what I am going to tell you. Now, if you can do this under vision implantation by various any other technique, it's fine. But the thing is, it should not be blind, because it is very important to preserve intracochlear structure, not for the hearing preservation. Whatever hearing patient may not be having good hearing, preservation of the hearing is one aspect, but at the same time preventing other complications. Because more you damage the intracochlear structures inside, more will be reactionary fibrosis, ossification, and ultimately more chances of complication, infection, ascending infection. Yes. So it's not about varia or posterior tympanotomy or anything. That's not a point of discussion. Whatever you do, your conscious, your technique should be able to ensure that the implant should go under vision to the area required, and that is scala tympani. Exercise body. It's not about opening the round window, pushing like pushing in a bag. That can never work. And that's why in a lot of retrospective studies done, many of the implants are lying in the scala vestibuli. And that can never give optimum hearing. The patient will still hear. At least some, sensation stimulation will always be there. That will not take away the complete hearing. But that is not optimized stimulation. In this era, we should take maximum out of our implantation for the benefit of the patient, and we should be able to preserve the intracochlear structures. The whole goal of improving the surgical technique is to protect the intracochlear structure, and what we believe in our experience, and that's how worldwide, and I'm going to demonstrate that, how you can see yourself that your implant is right going in the scala tympani tunnel. It's a 3-dimensional tunnel. It's not 2-dimensional opening of the round window. It's not 2-dimensional cochleostomy. It's a bloody 3-dimensional tunnel. And then under vision, if you pass your implant, it is going to give minimal intracochlear damage.
You using cutting bar right now?
Yeah, cutting. I use most of the time cutting, but yes, very, not using any pressure over the burr. With a gentle hand, you can say.
Satish, very important. You are demonstrating that your posterior canal wall should be absolutely straight, 90 degrees. It should not be oblique. If that is oblique, then your vision becomes oblique you will have difficulty doing the posterior tympanotomy. Many surgeons, they drill at an angle. I always believe that you should drill at almost perpendicular, and in fact you can push little bit the posterior canal wall forward, if not backward. Then it will help you in giving a very good access to the posterior tympanotomy, especially if you have a difficult round window.
Yeah. So now I will corroborate to you what I said during radiology about the posterior tympanotomy.
Yes.
I told you the posterior tympanotomy is the space between the facial and the around the chorda tympani, and through that space between these two nerves, we should be able to see the round window. So first of all, our approach involves positive identification of the facial nerve. See this, the landmark which I believe, which works very well for us, short process of the incus. Can you see?
Yeah, very clear.
This is lateral semicircular canal. This incus is always like mother's lap covering the facial nerve. Yeah. The long process covering the horizontal segment, the short process covering here the genu. So if I stay in the line of the short process and work here, my facial nerve will remain medial to it.
Yes.
Let's see what I am trying to say. See, I am working parallel to the short process. See my angulation in the depth of the canal?
Yeah.
And then I will keep on reducing the bone below, behind, until I see the facial nerve. See my level of short process. Still I am using the cutting burr. Diamond burr is sometimes more dangerous,
Dr. Dubey is seeing your surgery right now. He is saying hi to you. He says, I use Dr. Kirtner's detector a lot, and my tissue trauma is very less because of this detector. Dr. S.P. Dubey.
What is his comment?
He's saying that he used Dr. Kirtner's detector, which is very good for the retraction of the muscle, and it prevents the trauma of the...
Oh, Kirtner's retractor. That's great. See now.
Yes.
I am in the line of the short process. Line of the short process, and I can see some structures coming in the view. Let me tell you. Now I will change to diamond. So patli dena cutting bar. I can see the glimpse of the facial now, and I can see the glimpse of the chorda tympani. If you see closely.
Yeah, we can see.
Yeah,
what we can see.
Thoda bada de.
What about the Herald cells we get sometimes over here?
As I go deeper, I will keep changing the burr point to the smaller size.
This,
yeah.
Means how many when we can see the Herald cell over here?
What?
How often you see Herald cells? That before the posterior tympanotomy, some cell is there.
Yeah, this is the cell. This is the cell.
Yeah.
Now see what I am trying to show you with the diamond under high magnification. The glimpse of the facial now.
Yeah.
Can you see?
Yeah.
Below. Now see my landmark. See my landmark, the short process of the incus.
Yes,
how deep the facial now. That is such a reliable landmark. If you follow the line of the short process of the incus, you are far lateral to the facial now. That is what I was trying to say. Now see the another
size
now laterally.
Of diamond bar?
Yeah, now diamond.
No, size.
Yeah. This diamond bar is 2.5.
Okay.
Now see the chorda tympani coming laterally. Can you see?
Yeah, very clearly.
Yes.
See the facial nerve below and chorda tympani. Both the nerves are visible.
Yes.
I hope it is visible there on screen.
Yeah, very
Yes,
clearly.
yes.
Hear me now? Can you hear me? Hello.
So it is a chordofacial angle, right, sir?
Here,
Yeah, that's
down.
the most important landmark.
I showed you on CT scan how the chorda was originating down, and we followed the chorda to the level of the superiorly along the canal wall. See, this is facial. If I follow this medially, you can see the origin of the chorda tympani.
You expose facial line all the cases or just for demonstration?
This here going down for demonstration here.
Okay.
See, this is the chordofacial angle. Once
Yeah,
Devang mentioned the point, see this. Now, this is my fossa incutis, here. I want to leave this little bit of the thin bone at the level of fossa incutis. And see, this was the cell you were mentioning, boss.
Herald cell.
What's the name?
Herald cell, something.
Oh, I don't know.
It is sentinel cell.
Herald cell, sentinel cell.
See now my size of the drill.
Yeah.
Yeah.
Radiologically, he knew it's 3.18 or something.
Yes.
3.1.
Now,
3.1, yeah.
see both the lines, what I was referring.
Yeah. Wonderful.
My one line is the anterior border of the facial nerve, lateral border of the facial nerve. Another line is the annulus, posterior canal wall. Both the things are in view. And this chorda is referring to the medial edge of the posterior canal wall. And see in between these two, what is there in the depth?
We can see the jugular bulb window.
Round window.
Round window, come on.
We can see the round window.
Yes, you're right. We can see the jugular bulb also immediately underneath.
Yeah.
Immediately below. Immediately
can see the
below
round
is the
window.
jugular bulb
Yeah,
also.
the round window is and the jugular bulb that you said is pretty close. Not very high, but it is high.
Yeah, this was high. I told you the distance was less than 2 millimeter.
Yes, yes.
और छोटा दे एक साइड छोटा. So now see the visibility.
Yeah, very good.
How you can make out by radiology? So simple. There are hundreds of lines and angles described, unnecessarily complicating your life. See both the landmarks which you are going to see surgically and go between them. Simple. See एक size बढ़ा देना.
Deepak?
Can you hear me now?
Yeah, I can hear you. Now we can hear you.
Okay. Actually, Satish,
Yes.
section, but 2-3 points, like the way you are now using the mastoid tip area. This
Yeah.
is you can achieve when you drill out these mastoid tip area air cells.
Yeah.
This is instrumentation for instrumentation.
Yeah.
This is again a very important point for the juniors that
Yes.
drill
Now
out the
see
mastoid tip
how
air
big the
cells.
space is. How big the space is.
Yeah, you can do 2 implants. No problem.
Yeah. See, huge. And see, what I am doing is anterior thinning of the facial nerve. I am working anterior to facial nerve.
Yes.
My facial nerve is going here. And I am working anterior to it to enlarge my opening, to enlarge my axis. And inferiorly, I can see my jugular bulb coming in the view. Now, for the...
Important is Dr. Satish, how you are using the burr to enlarge the facial
Yes,
recess.
Thank
It is superior to inferior you are coming. You are not doing anterior posterior.
Yes.
So there is, this is the right way to enlarge it.
And I have adequate, of the opening. And this is my, like Ashish pointed out, this is jugular bulb below. See this? This is jugular bulb.
Yeah,
Yes.
nicely.
Yes, we
In
can see.
few of the patients, if time permits, I'll show you a video where the jugular bulb was high riding, going above the level of the round window. In that patient, what I had to do was, I did an extended posterior tympanotomy, going to the hypotympanum, sacrificing the chorda, had a good exposure all around, removed the papery thin bone limit which was left around the jugular bulb, and pushed the jugular bulb down with a Surgicel and bone wax, to push it down and fix it as well, same time. And that is the technique you can expose it atraumatically. Now see, this is your round window which is hidden under the bony niche. See this? This bony niche, again I forgot to tell you on CT scan. See now this view. You can see the round window membrane proper. Can you?
Perfect.
Now this bony overhang of the round window, again you can pick up from the radiology. I can measure that I have a 0.8 millimeter bony overhang, so that you are prepared to deal with that. You are prepared to look at that. You are going to find the overhang, not the round window, easily. And now I will see now my burr size. Every time reducing to one size smaller. And see, these are special burrs. Can you see this? Long tapering burrs. Can you see the burr point?
Yes, yes.
So that my shaft doesn't injure the facial now. So we have variety of burr points here. Variety of burr points here. As we go down, long tapering, narrow pointing. So that your visualization is maintained as you go in the depth. See now, one size smaller again.
Yes.
Again, long tapering burr, and see what I am removing is this overhang. I am not concerned with this jugular bulb. This is little lower down.
How you manage, suppose high jugular bulb cases, suppose this case had a high jugular bulb, then what?
You just now, I would remove the bone over it, whatever left. See, higher the jugular bulb, less the bone will be over it, and more likely it will be decent.
Yes, yes.
So you remove the whatever the remaining bone and push it. Yes, yes.
You can also do a cochleostomy, you know, if it is covering the round window, but if the promontory is fine, you can also plan a cochleostomy until unless it is so big that it is completely, you know, reaching up till the
yeah. According to the situation. According to the situation. Now see more and more round window coming into exposure. See this?
Yes.
Yes.
And see
how you decide that now this is the limit, upper limit of drilling this round window niche.
Yeah, I will remove this overhang to expose the, you know, round window membrane completely. See, I am removing only membrane. I am exposing only membrane.
Yes,
only all this part which is posteriorly and overhanging this round window I am removing. See how big is the exposure of the round window now?
Yes. Then this posterior lip and the posterior superior lip drilling is...
There is no equivalent of an annular ligament, no? To the round window?
No. This is a thin membrane. This is permeable as well. That is the basis of so many drug therapy. And my scala tympani, you know, this anatomy is very important here. First of all, give me the pic. See this. I mentioned in the cadaver again and again that day. Just a minute. Yes. This round window is the end of the scala tympani here. So what we are going through is the backdoor entry into the scala tympani. This cochlear duct is beginning just superior to the round window here, just superior to here. This is the blind pouch where the scala tympani ends, and just anterior, inferior to it, from the floor of the oval window, floor of the vestibule, is the scala vestibuli starting parallel to it. So scala vestibuli there, scala tympani here, and it runs inferiorly and anteriorly in this direction. And as you go inferiorly, it turns anteriorly and then superiorly like this. So my direction of implant insertion would be such that my implant should go underneath the osseous spiral lamella and basilar membrane. I showed that day, if you remember.
Yes.
How the cochlear lumen is divided by partition of osseous spiral lamella and basilar membrane. Pen or paper.
We remember the cadaveric dissection very well.
I will show it brief for people who were not there that day. Just in brief.
Dr. Satish?
Yes, sir.
Yes. This part which you are doing on the roundwood English, normally we leave it after the bed and all, so that you don't suppose.
Yeah, I am not opening, sir.
Okay.
I'll expose it, do the part of the bed and then open the inner ear. Why I expose it here right now? To assess my situation, that I am able to do it without changing my approach.
Okay.
I have seen it many times in difficult situation or anything warranting changing your approach. You can decide right over there before drilling the bed and all. And number two, exposing the complete round window, I will leave a steroid soaked gel foam on the round window. Meantime, I do the drilling.
Yeah, makes sense.
No adrenaline?
No, pure Dexona.
Okay.
Wash, give me a wash.
There are many questions regarding how you manage the contracted mastoid, like low-lying dura, forward-lying planus.
Boss, like anybody, you major in the CSOM surgery. But here I mention one thing. For any given difficult situation, if you want to come over and not coming over, do a subtotal petrojectomy and blind sac closure. Because this surgery doesn't involve the middle ear system at all in the future.
Yes.
And that has an additional advantage, not only giving good exposure, it prevents the possibility of infection. Probably next week or so, we'll keep a case of subtotal petrojectomy with blind sac closure in a CSOM patient along with cochlear implantation. Cholesteatoma patient, same stage.
Today we have petrosectomy for revision CSOM case.
Yeah, today we have a subtotal petrojectomy for a patient who has been operated 4 times, mastoidectomy, with a profound hearing loss. Nahi, wo dekh, steroid. Now see, my area is clear. And here now I am gel foam, they be okay. I will leave a steroid soak, gel foam over here. Dena. So I will go antero-inferiorly from here later on. I will show that. This is the steroid soaked gel foam. Ek aur de.
This facial nerve, this little bit exposed. Will you cover it later on or just?
No, it is covered by the thin bone. It is not exposed. This is not exposed. There is a thin bone over it.
Okay, we can.
I have not exposed the facial nerve at all.
Satish, which implant area are you using?
I am using advanced bionics.
But advanced bionics, 1J, okay.
Though they have now come out with different implants, Ultra 3D now, they are launching in India.
Which they want to introduce through the round window to minimize the drilling from also.
So Ultra 3D, which they are launching, is going to be compatible with the 3 Tesla MRI.
Yeah.
3 Tesla. Yes.
Until now, it is the synchrony of the medal, which is compatible with the 3 Tesla.
Medal
synchrony, 1121 or what. But now the 3, Ultra 3D will be compatible. And this 1J implant.
They have a magnet which changes polarities, therefore the MRI doesn't affect it.
It's a rotatable magnet, sir.
Magnet, yeah. It can change the polarity.
So, they took the advantage of the MRI, how MRI pulls the magnet, how it affects. MRI can depolarize, demagnetize, pull the magnet. So what they did, in a pocket, they have kept multiple rotatable magnets. So the magnet will be rotated without affecting the implant at all. So that is
there are 4 magnets.
Dubey sir, good evening.
How are you? I am
Good
watching
to see
your
you.
nice surgery and it was very excellent dissection. I think if I have made you my mentor, then I have need not to shift myself towards area.
Arey sir, you are champion. You are champion. You have been mentored to so many places.
It's really a treat to watch. Very good dissection. First time I seen chorda tympani very clearly, facial, and the way you showed. It's really excellent. Excellent dissection.
So now we have a question.
In the presence of our giants like Professor Kirtane, He is a motivating force to all of us. I was just writing about his retractor. It is also very tissue preserving. If you want to retract, though we are using suture nowadays, but that retractor is also very atraumatic retractor, which Dr. has devised.
So now I think I have to steal that one retractor from sir.
Only has attractors, no retractors and detractors.
I have to steal one retractor now, sir. Be careful.
Gifted. July 24th. In fact, is coming on, sir. You can gift it to him on his birthday, July 24th.
So now before I go further.
Sir, good evening.
Dr. Dubey, in fact, if you have the latest one of Dr. Kirtane, it has got a suction and a light cable which can be attached.
Yes,
so, so you know, that is...
To what? To what?
It not only preserves, but also suctions the bone dust.
Oh, really?
Yes, so it has got a... It has got a, attachment for a fiber optic cable as well.
Oh. Now, before I move on, we have a question here from Dr.
No
Kusum.
cochlear implant set is complete without that.
We have a question here from Dr. Kusum Patidar, reminding me about what to do if the round window is not favorable at this point of time. That's a good question. So if round window, suppose with this exposure is not visible, I have many maneuvers to do. Number one, what I can do, keeping this flap intact, I can mobilize this tympanomeatal flap anteriorly. Keeping this flap intact, I can remove this, drill away this posterior canal wall. And then I will have a full exposure all the way. And then after implanting, I can put a piece of cartilage to reconstruct the canal. Number one. Number two, without even doing that, making two vertical incisions through the bone, one above, one below. Keeping the flap intact, I can drill through the thickness of the wall and push it anteriorly. Push it anteriorly, and then you get a good exposure to see the displaced round window, which is posterior-medial. Then you'll have a good angulation, and after implanting, you can reposit it back. What we do in the end of the, after this canal we reposit, we supplement with a flap from behind, that is a vascularized flap from the middle temporal artery, and cover this with the implant and this posterior canal wall with the flap. Third is, you can change to other technique if you know, like canal techniques, varia, suprameatal, other things, if you are not comfortable. And overall, as I mentioned, in most difficult situation when you don't know what to do, is subtotal petrojectomy implantation. So in all those difficult situations, you can overcome those by different ways at this point of time.
Satish, there is one more option.
Yeah, sir.
There is one more option.
Sir.
And that is you elevate the posterior canal wall skin completely intact.
Yeah.
Lift up the tympanomeatal flap. And from the fossa incudis area, widen that and just put the implant like you do for the varia technique.
Yes, sir. Yes.
Into view from
and you can remove the incus. You can remove the incus as well.
You can remove the incus also if you want.
Yeah.
And put
Yes.
the
Yes.
from
Yeah. Yes, sir. Yes, sir. Got it.
I think that is the Bombay technique which sir has.
That is for people who do varia, they can do it actually under vision. So, Rubeji.
See now what I am doing. I am just marking my site of this processor, you know. See this? So that my implant will remain behind it. Now, Uthavi. Now my next part is fixation of the implant. Implant migration is a disaster, as I told you, for various regions. We will fix the implant at various places, not only here, but the cable in the mastoid as well. Because in children, you know, this mastoid expands till puberty, till adulthood, and this expansion of the mastoid result in pulling the implant array as well. So that's why we keep some extra length of the array in the mastoid, coiled in the mastoid, so it expands without mobilizing the implant inside. Sometimes the adhesion may form with the expansion of the mastoid, and it may pull the implant out of the cochlea. So what we do, and this is why we are doing that, I tell you, a lot of studies have proven this implant, which may mobilize from here and everywhere, but the distance, distance between the cochlear opening and the level of the fossa incudis remains constant. This never changes. Okay. So what we do, we fix our array, implant array additionally at the fossa incutis at the end of the surgery. So even if there is a pull in the mastoid where the array is expanding, the pull is not going to be transmitted beyond the fossa incutis to the cochlea. It will not pull the implant out of the cochlea. That is one beside this fixation. Okay?
I think remember sir used to do same thing when he started surgery. Kirti 99 used to do, put a stitch around that fossa incutis that time.
Yeah, little bit of the fixation is required. Now, bone dust.
And you seal the cochleostomy site also?
Pardon?
You seal the cochleostomy site also, or the round window site also?
Yeah, that will seal with the periosteum.
Okay.
Periosteum is a tough tissue and it survives well, it heals up well. Now see what I am acquiring. This is my limit behind which I have to stay. I am collecting some bone dust over here.
But Dr. Satish,
yeah,
I think except Dr. Vishwakarma, now more and more our senior surgeon who are the pioneer of cochlear implant is nowadays not putting any tie sutures. They are making just, tight periosteal pocket.
Periosteal, I have already mentioned, sir. I have already mentioned there are three techniques, which are good. Periosteal fixation, periosteal pocket, tight periosteal pocket, periosteal suture.
Right.
And the third one is this fixation. And why we are, I am little biased towards this fixation is because these patients in any given situation, out of all the three techniques, this is the most stable one. They may be good, but this is most stable. This gives the only thing it went to, why people are searching for the other techniques once this was a standard one, because the material you were using for the fixation sometimes can give problem. So you have to be careful. I'll tell you how I will use my sutures. Secondly, this making the well may expose the dural complications, CSF leaks. It can happen, so you have to stay extra careful. That is the only thing you need to do. Otherwise, there is no harm in doing this. This gives more stable fixation.
How far this anterior edge of this well from the posterior canal wall?
This
overlap will not occur. The speech processor.
What will not occur?
No, Deepak, he already put a template there and saw. He put a template, then he marked with a bone burr that
I am
he has
behind
to
that
remain
level.
behind that area.
Okay.
Even after opening, after doing the mastoid, he put a template in place so that he's sure that the well will not overlie the area where the...
Now, this is my template for this.
Sir, yes. Sir, why I was asking this question, something like that 3.5 centimeters from the posterior canal wall?
Or 4 centimeters.
Okay.
But that, how does it carry any value in centimeters or so?
Because best is to use the template.
See now, this is the unnecessary additional exercise I am doing here to get security of my fixation of the implant.
Yes,
now, some companies have the implant where it is a cakewalk. You can just put 2 titanium screws and come out. We have done couple of those Neurelec implants as well.
Now it is called Oticon.
Yeah.
And then the Oticon came up with a new implant which is called Neuro. The SP is now obsolete. And Neuro is a good. It has got a very good magnet, MRI compatible 3 Tesla. And they are approved by the DGCA, Government of India Drug and Control.
Okay, Oticon.
Oticon.
Yeah.
See now, what I'm trying to do.
Remember, it was.
What I'm trying to do, I don't want to expose my implant above the surface. So what I will do here, I will make the island of the bone.
You will drill out the periphery.
Yes, so I'll make the island free and I can press it with the implant.
Suppose at this level we get CSF leak, then we just what?
Be careful with the cutting bar.
As you are putting tie down suture, Satish, it is how important to make a punched out hole, which is everywhere recommended.
Yeah,
It
yeah, I
should
will
have
show
a
that.
punched out hole so that it.
I will show that. That only I will show.
Then also you need to put a tie down suture for double safety.
Yes.
Dr. Dubey, we now suture, but we don't put it in the bone. We have the periosteum margin on either side, so we suture from periosteum to periosteum, so it holds the implant down, just like a bone suture would be.
And you take the advantage of the slope of the head. You take the advantage of the slope of the head so it doesn't slip back. Okay. Because the implant is going towards a, a sort of trough you create so that it remains fixed there, it doesn't fall back. In the periosteal suture technique.
Because periosteum seems to be easy for new surgeon, because I request you, Dr. Satish, kindly show us the right technique to make a tie down hole, because sometimes people are scared of doing it because it can rupture a dura, especially in young children.
Suppose while doing this drilling of this well, if you damage the dura, then what? How you manage that?
Just put a little connective tissue. If you're making the well, just put a connective tissue on it. It just stays there. Put thick fascia on it, yeah.
And sometimes what happens, sir, when we send out this periphery, the central part of the bony island comes out.
Then put it back. Doesn't matter. You can put it back. It will heal.
It works good as a free bone as well.
Yeah.
In all open neurosurgical approaches, they make so many bone flaps free.
Intrusion of the implant?
Your pardon?
No.
Sir, what happened, Kirtan sir, if you keep right on dura, your implant, if no bone is there?
I don't think anything will happen. It's just that you have that additional thing of not directly contracting between the medial surface of the implant and. But in the past, sometimes when the bone has come out or whatever it is, even if you put it directly on the dura, I don't think there is any issue.
Any experience, Satish? We are seeing your surgical demonstration. You are advising some material which was like a bone. If you can put that there.
Yeah, bone wax. Oh, bone, bone
some
cement.
Chemical structure was
there. Yes. In cranioplasty, we are using every other day. In our open skull-base approaches, I've been using quite extensively.
And it works very well on dura.
Very well. If you suppose if I have a defect to cover, I will use my bone cement and it will flush with this whatever this defect is immediately.
Right.
And in 5 minutes time, it will become hard. That like can be removed later on by drilling only, like bone. So now my last part is, after this, we will just make the entry into the scala and push our implant after fixing this.
Dubey sir. Hello.
Yeah. Dimang.
Dubey sir, when we put a tie down hole na, the direction is oblique slant, so it doesn't expose the dura.
You will show us.
Sometime even if you have a leak or something, you can manage it like any other CSF leak.
Something is wrong with it.
See, there are some dural vessels.
Right.
Still, little drilling is required. Dr. Prakash Mukha, Dr. Madhu, Dr. Ramesh Noewal, all are mesmerized with surgery right now. They are just on. All are on.
Sir is always there to encourage us.
Yes, yes. Dr. Madhusudan Rao is also there.
Madhu, great.
So Rajiv, this is what Dr. Dubey mentioned about it being punched out. It's like the margins are not sloping, they are straight vertical.
Yes, yes.
And the implant stays inside.
I want to make it befitting, you know.
Yeah,
that's why. For a large opening, I could have done by now.
I want an exact fit.
Yes.
Sometimes even if it becomes a little larger, and if it's punched out.
Anyway, you are going to fix it.
Yeah,
but that movement, something is not good.
And even if you are putting a tie suture, then it will literally sinks into it.
You see, the implant will not rise above the surface of the bone now. It's completely submerged.
Yeah.
And sir, how important that the excess electrode area should be drilled very deep so that it can also sinks there.
The lead wire, you mean, as it comes out?
Yes,
Pardon, what is the question?
He's saying the lead wire should also be drilled quite deep inside so it's not above the surface.
Yeah. Yeah, we will do that. We will communicate that.
Right.
This
That has to be at the level of the device.
Like a fenestra of a stapedotomy, can you put, if this well that you're making is little wider, can you put the bone cement around to fix it?
Why to was unnecessarily bringing anything?
Not required, na sir? It is not required.
And he's already collected a little bone dust, so he can put that
So
if you
this gap that you see around
makes no difference.
No
But you can put a little bone dust if you want.
Yeah, I will show you once I fix this.
Sir, at one place
this is almost done. This is almost done.
Dr. Satish, at one place we always say that after bony work you should remove all the drapes to clear up the bone dust. And on other place we are advocating that whatever bone defect is there, we are put that bone dust there.
Yeah.
Because bone dust is supposed to cause, increased chances of infection.
Yeah, we will wash away, completely wash away. We'll do that. Now see my implant.
Yes.
Yeah.
Completely submerged.
Yeah, perfect.
It should not project over the surface, you know. See this.
Right.
Now I will make the tie down holes. First of all, drill there. Yeah, first I will make this gutter to communicate the cable. See, this implant has various parts. The outside processor has a microphone that collects the sound, then transferred to the processor, which, you know, filters, digitalizes and converts into coding, and that is transferred through the cable to this, through the magnet to the implant. So all that is external, and then this implant converts into electrical signals through the cable to the electrodes and then to the spiral ganglion cells, where we place it close to the modulus in the scala tympani. That is how the implant works.
Satish boss.
Yes,
Hello.
boss. Yes.
Can you please tell us what size of the burr you are using when you are making a valve for the electrodes for the beginner?
For this burr?
Yeah, size of this burr.
This burr is 4 mm.
4 mm, okay.
I generally prefer cutting burr everywhere possible.
Yeah.
You have to be a little careful not to use pressure, and the largest size.
Yeah.
See now, it will not project now.
Yes.
And here I'll make a little bit of the, you know, overhang. Create this in case required. I will tug my, you know, bone over here, this cable over here. See this?
Yes.
That's a deliberate overhang.
You want to keep some bridge sort of thing to manage that
Yeah,
over here?
you can do that. What he is saying is, I could have kept a bridge intact and could have drilled below that and passed my cable below that. That you can do. Yeah, you can do that. Hold there. Now my most important thing is for the tie down holes. And sometimes it is very frustrating as well. Now the kind of hole I am going to make it, I will show you. I will take the advantage keeping my periosteum here. Or I can little bit here. And I will put a figure of 8 suturing, or patla de. What I do? Section. See this, my periosteum is there to protect.
Yes.
पानी इधर डाल यार.
But I think you are not going through and through now.
Through and through.
You will go till your periosteum elevated?
Yes. See that my periosteum is protecting.
Okay.
See that? I have gone.
Okay.
And now, from here as well.
But if you make it a bit oblique, then you think the suture feeding will be easier?
Yeah.
Little oblique, yes, sir. I am keeping little oblique. My catching the suture will be easier. So this periosteum is working as a guard.
You are using your left hand?
Yes.
Excellent. Look at that control with the left hand.
Okay. See this section? Yeah. See the dura?
Yes.
Okay. Now just opposite this, we'll make another. That will be just.
This side can we suture with the periosteum?
No. I will do this. Fixation, no compromise. 1 minute extra, that's it.
You can tell he's had a patient whose implant has migrated.
So people say that a lot of fibrosis is there within 1 or 2 weeks of post-implantation, and tissue will grab this implant. It will not let that implant go anywhere. But still, people saying that micro movements are there. To prevent that micro movement, they are making it doubly sure that we should tie it down with the suture.
Yes. And like Satish was saying that when we are doing MRI, though the magnets, magnets are MRI compatible, but still there should not be any movement.
Yeah, MRI, you have to take all precaution, See, all implants are 1.5 Tesla compatible, except these two. Advanced Bionics Ultra 3D and the Medal Synchrony. All are 1.5 Tesla compatible. So what you do, additionally to protect, you can use a tight head bandage.
Yes.
And under that bandage, you have to insert something, interpose something to counteract the magnet action of the MRI. So 2 things you can use. One is the, the hearing aid material, that acrylic, that material. You can cover the implant with that and then put a tight head bandage. So the magnet effect will not go to the implant. Or simple, you can put a playing card, the plastic playing card.
Yes.
Pan ka ikka.
Hukum ka.
The plastic card that will, protect from the magnetic effect going to the implant.
You are showing your dextroversity.
Pardon?
You are showing your dextroversity, working from both the hands.
But I think various people have this advantage because the transfer channel which they are making is always left hand.
Now this part is done. The suture de dekh. I will leave the sutures over here. And before going to the cochlea now, I'll do few things. First, leave the sutures over here so that when I implant, open the implant, I can directly fix it. I will harvest some periosteum. I will ensure hemostasis and then go to the cochlea to open it and directly fix the implant. This particular implant has a inserter, you know,
yes,
to guide us, and I like this inserter. I have done many of such implants with this inserter. Electrodes, we must discuss. There are variety of electrodes available, you know, variety of electrode choices for different situations. Now,
you are putting proline.
Like Subirender sir mentioned in the beginning about the perimodular electrode, you know.
Yes.
Perimodular electrode was they came out with a good idea. So that is a, you know, pre-curved electrode that is passed through an inserter. And it, once you release, when you pull the inserter, this goes around the modulus and hugs it. So it remains closest to the spiral ganglion cell population. I mentioned in the, I showed in the dissection, temporal bone dissection, the spiral canal of Rosenthal is in the periphery of the modulus. And just out of that is the scala tympani. Just immediately out of that. So that way those implants stay immediately close to the modulus. It looks so fascinating, you know. Once they came in the market, it was like a boom. What a thing. Yes, forceps. So, what happened later on? What happens if you see technically to the perimodular electrodes in the beginning? First of all, technically, what you need to do is, you have to take the inserter along straight in the cochlea until 180 degree ahead, where the cochlea turns superiorly, and then keep releasing the inserter.
Oh.
Believe me, it is such an important move. Move means you have to push the implant, you have to angulate, give angulation also to the implant, both things together. So one has to be expert in pulling the inserter and pushing the implant. So implant keep coiling, taking the angle around the modulus and going inside. Both the things same time, angulation and depth. Now that is such an important move that you have to practice, number one. And a human being may not always be perfect. Though I have seen Keatney sir many a times doing so perfectly, and he had shown us, you know, the X-rays after that. We have done a couple. The second most important thing about those implants, and they have almost gone to disrepute now, is the electrode contacts. Once you are doing a perimodular modulus hugging, the electrode contact should be hugging the modulus. So once you insert the implant up to 180 degree, if your implant rotates a little bit, your contact will be opposite the modulus and the purpose will be defeated. So that has to be perfect. Number three, the thickness of the array. Because of the, you know, the stiffness of the perimodular electrodes, because of the stiffener in it, they were thick electrodes. So the overall trauma was much more. When you go straight to the 180 degree, and if you have to touch the endosteum of the, you know, inside of the cochlea, that is the trauma to the spiral ligament. Fourth is, in case you need to explant sometime, because this implant is not a lifetime phenomena, you may have to change some. That explant faster. It gives the highest level of trauma to the modulus once you pull it out. The advantage was that you keep it close to the modulus so that the stimulation is more focused to the spiral ganglion cell. That's what you want. It minimizes the cross-channel interaction between the two channels, and it is focused on certain spiral ganglion population very close to it. and it hugs so that it remains close to modulus spiral ganglion cells, so that for the stimulation of the spiral ganglion, the minimal current is required. That is the advantage. Third advantage is, like in autosclerosis or any situation, trauma and all, when the current may leak outside the cochlea because of the hypodense bone, these are remaining being close to the modulus. You need less current, so current leakage and facial stimulation, all those are less. But the thick implant, explantation, implantation, overall implant related trauma is maximum with the perimodular, and that's how they have gone to disrepute. The lateral wall electrodes are much better, and nowadays the best of all, if you ask me, is the mid-scala implants, electrodes from the advanced bionics. Mid-scala are electrodes which are designed to float in the middle of the scala, neither on the medial wall nor on the lateral wall. They are pre-curved. You can insert through inserter, you can insert free without inserter, you can use a tool to insert, whatever you can use, up to you. And ultimately they float in the middle of the scala with minimal intracochlear damage. And the electrode length is also designed to be minimal, to give, not to penetrate deep, to give more implant. The implant, the working electrode length is 15 millimeter only as compared to the other electrodes. So, as far as I know, the most sophisticated, giving minimal trauma is the advanced bionic mid-scala. Kitne sir is more experienced, will have his comments as well.
The electrodes which are coming in more and more into the market now, even with Cochlear, the slim straight, they are designed, they're thinner, more flexible. The electrodes are all on the inside. So the newer designs are all aimed at minimizing the trauma to the cochlea.
Yes.
That depends upon how you insert it. It's not just the electrode that does the trick.
Yes.
It depends upon how the surgeon inserts.
Yeah. The surgical insertion, that dexterity is also important. The direction, if you go and damage the osseous spiral lamella, what will the electrode do? So surgical technique is equally important. Yes, sir.
They haven't made a foolproof implant which anybody can put in without considering trauma. I mean, abhi tak to nahi bana hai.
Yes, sir.
Any fool can put us.
Out of the best available resources we are talking about.
Yeah.
And I think regarding perimodular hugging, people have given papers that long-term hugging can also lead to ischemia.
That's right.
Yeah, it can lead to CSF leak.
Mid-scalar is not hugging the modulus directly, but
boss, it can even lead to CSF leak, because that wall of the modulus with the scala tympani has a lot of pores for the exchange of ions and other things, and this implant tightly compressing the modulus can even lead to CSF leak.
Okay.
Right.
So perimodular I would use only if I am doing autosclerosis. That's it. If mid-scala is available, you don't need to do all this.
Okay. It is proline. Now you are using proline. Ethibond is, I think, we are using ethibond. It is, I think, better one.
Pardon?
We are using proline for the tie-dye sutures.
Yeah, proline. And I will invert the proline. The final knot of the proline, I will invert inside this.
Yes.
This knot projecting to the skin has even leads to complication. It has been reported. Yes. The knot poking onto the skin led to the implant exposure, and everything ruined. So I have taken the periosteum, wash. I will wash away all the dust. I will ensure hemostasis.
Dr. Satish, your experience regarding implant in autosclerosis in which current has dissipated to the facial, or you have to switch off some electrode, your and Dr. Keaton's experience, kindly share.
Yes. So, it is expected in the autosclerosis situation that the bone is hypodense and current may leak when you raise the current particularly. So, first of all, the implant insertion is difficult in autosclerosis. Sometimes, if there is a lot of, the autosclerotic foci, it is difficult to find the lumen itself. Or there are a lot of autosclerotic cavities in the cochlea in the advanced autosclerosis. You may go in the false cavity, false lumen. So first of all, the insertion is important. Number two, if this stimulation happens to occur, facial stimulation. That is not in all patients. In certain percentage of patients, when the facial nerve is very close, and that part of the facial nerve is the ascending basal segment. You know, I demonstrated in the dissection, the labyrinthine portion of the facial nerve and its close proximity to the cochlea, that ascending basal segment, that is at risk. So, in that situation, if it happens to occur, first of all, reduce the current, particularly those electrodes in the basal segment. Reducing the current may, you know, stop this phenomena of stimulation of the facial nerve, first of all. Number two, if it still continues, what you can do, you can switch off those electrodes. See the round window completely?
Right. Very, very well seen.
I have a good exposure of the round window. Now what I want here, that is what I always emphasize. So let me complete that autosclerosis. So if the switching off is okay and this stimulation stops, nothing is required to be done. Otherwise, if the patient is frustrated with the stimulation and still it is there in spite of switching few electrodes, if you switch more electrodes, it is ineffective. Then you may have to explant even. So that is the whole game behind it. Now here the most important thing is making a three-dimensional entry into the scala tympani. How come? I had shown, pen, jaldi, pen, paper. Ready tha na? Give me a glove first. Hold rakhna. Glove. Extra glove. I will show you here in 1 minute and then we'll finish it off. So my aim is to direct my implant electrode in the scala tympani. So what I will do, see this, yeah, see on this paper, see, this is my round window. Can you see this like?
Yes, yes.
And this is my scala going, turn, like this, okay? Now, here is the beginning of the scala, just close to the posterior border of the round window. And here is the important, where the, you know, the spiral, osseous spiral lamella ascends, the basilar membrane ascends. The lateral most part, this is the modulus, suppose in the medial side. From modulus to the lateral wall, the osseous spiral lamella comes, and just before the lateral wall, it ends, and this gap is bridged by the basilar membrane. That is the last part, very small area with the basilar membrane. Now the part of the scala below this is the scala tympani, above this is scala vestibuli. And on the scala vestibuli side, there is another membrane from the outer wall to the osseous spiral lamella, to the end of the osseous spiral lamella, completing this triangular, a very small space, that is scala media. Okay? So here is the scala media, where the organ of Corti is. What is that? The outer hair cell, 4 or 5, and the inner hair cell. The fiber of the inner hair cell goes through the fissure in the osseous spiral lamella and goes inside the modulus. This is modulus inside. So the inner hair cell fiber goes through the osseous spiral lamella, canal in the osseous spiral lamella, goes to the modulus, and in the periphery of the modulus, like this, all these fibers, here are the cell bodies of the spiral ganglion. So throughout the length, in the adult, there are around 36,000 spiral ganglion cell bodies like this. Throughout the length of the cochlea, that is around 30 to 35 millimeter. And all these cell bodies, they have the peripheral process here going to the hair cell and the central process going into the modulus, like this. Okay?
Right.
I hope it is clear.
Yeah.
So in the our area, here is the scala tympani, here our implant will go. This will be closest to the spiral ganglion cell population. Now if I implant on the other way sound up, My implant, if you push the implant, if it happens to damage the osseous spiral lamella, happens to damage the basilar membrane, Reisner's membrane, go in the scala vestibuli, that is highest level of damage to the intracochlear structures. The paralymph, endolymph will mix, endocochlear potential will not form, and there will be highest grade of trauma. And this implant going in the scala vestibuli now will be much far from the spiral ganglion cell population. Much far. So in order to stimulate these cells, you need to use high current, very high current. Your battery will run out so quickly. The patient who is, got the implantation done will go for battery every other day.
And he will feel tired also.
Yes, and ultimately they become non-user, And many of the, particularly when the implant is done free in the government scheme, patients many a time they have become, non-users because of the batteries only. So now, not go in the scala vestibuli, you should go in the inferior tunnel below the osseous spiral lamella and the basilar membrane and staying lateral to the modulus here in this area. Now this is one thing. Now see, these are 3 tons. See, I am showing the cochlea from above. This is just like that. This is the apical ton, suppose. This is the middle ton and this is the basal ton. You assume this. Okay? Hello?
Yes.
Now fibers from the spiral ganglion, they go to the modulus like this. From the basal ton, they go horizontally into the modulus. As you go to the middle ton, they go down in the modulus. See this, like this.
Yes.
And for the apical ton, they go steep down like this.
Okay.
In the modulus. So now your spiral ganglion cell, spiral ganglion, this is spiral ganglion all the way. This is organ of Corti all the way to the outer wall. See, in the outer wall is the organ of Corti. So the length of the outer wall will be much more than the length of the inner wall. Can you see this?
Yes.
If you see the periphery, the entire length of the spiral ganglion and the outer wall basilar membrane, cochlear duct. This cochlear duct is 30 to 35 millimeter. But the spiral ganglion is less than 15 millimeter in length.
Yes.
So, in implantation, you are not supposed to implant in the 35 millimeter length cochlea. It's a disaster. So if you are measuring the length of the cochlea 35 millimeter and using the 35 millimeter implant, it is like more giving trauma by means of inserting the implant in the narrow distal areas of the cochlea. The middle ton and the apical ton are very narrow areas. So what we need to do, we have to implant in the basal ton, like I am starting from here, 0. I have to do this 360 degree and then some more like 450 degree till here.
That's all.
This will cover all the spiral ganglion cell population coming from the middle and the apical ton as well, because they are coming from above down.
Right.
They are coming steep down. Even if your implant is going up to the middle of the basal ton, it will stimulate everything.
1.5 ton.
So yes, that is good enough. So implantation, you are not supposed to go beyond 24 millimeter maximum. That is otherwise
important point,
creating more trauma than giving a benefit. Got my point?
Yes.
So now, in order to go in the scala tympani, now my aim is to go in the scala tympani. Now see under magnification. Now my first concern is if I open this round window now and insert my implant like this,
Focus, please.
Yeah. See now, if I open my round window and push my implant like this in this direction, the first structure will go and hit in the modulus inside, in the center. What I need to do, my implant should go like this inferiorly in the lumen. Okay?
Yes.
Not only inferiorly, medially as well. Inferiorly and medially. Medially means down. Here towards the medial wall, so that it remains away from the osseous spiral lamella and basilar membrane above. And inferiorly directed like this, it will remain away from the osseous spiral lamella. and it will go in the straight scala tympani tunnel all the way. If you can ensure by any technique, you can implant by Varia technique, you can implant by suprameatal technique, you can implant by middle fossa technique, by XYZ technique. If you are able to ensure that your implant goes under vision in the scala tympani, then it is a good technique. Otherwise, it's a disaster. It's not that opening the round window and pushing something inside the bag. This is never implantation. Now what I will do, I will remove little bit of the bone inferior to it. Can you see this?
Focus, I think you are zooming.
Yeah.
Focus on
Yeah,
the
I will
possibility,
focus.
yeah. Yeah, now it's better. Yeah.
Good?
Yes, it's good.
So I don't want to go like this. I want to go inferiorly like this, and inferiorly this bone which is limiting me. That bone is limiting me, that I have to remove.
Yes.
That this bone is the crista. Yeah. This is known as crista of the round window. And if I remove the crista, I'll have an inferior entry into the scala tympani. Patla dekh size. Now see here what is there. What is there? This is high jugular bulb. See the obstacle to go inferiorly. So I'm using a little
smaller.
Yes.
On table, how can we assess that we have damaged the basilar membrane or lamina? Any?
Yeah, you have to stay inferiorly. I will show you.
This boss?
Yeah.
Yes.
Do you use injection methylprednisolone before opening the scala?
We have given already IV.
At what time actually you start giving?
Yeah, when I was making the well now.
Okay.
When I placed my this thing gel foam soaked in that, the same time we have given yesterday also. We started day before.
Dexona.
Okay. No, methylprednisolone.
We give Dexona, and we continue the steroid for next 2 days as well.
Okay. Which one you give? Methylprednisolone or Dexona?
Dexona we give. You can give methylprednisolone. Steroid according to their potency. You can calculate the doses.
Yeah.
Point all. See, I am removing this inferior bone, staying away from the jugular bulb at the same time.
Yeah.
Now here I want to tell you one thing. Just give me the pick. You are not supposed to drill the medial wall of the cochlea, scala tympani, right?
Yes.
You know why? Just immediately close to the crista in the medial wall are two openings, two important structures. Within a millimeter.
Can you magnify, zoom in, Satish, a bit?
Yeah. See what I want to say here. See, inferiorly means this is superior, this is inferior. Okay?
Yes.
This is round window. I am drilling inferior to it. What's my point?
Yes.
I am not drilling medial to it. If I drill medial, just immediately within a millimeter from round window is the opening of cochlear aqueduct, is the opening for the inferior cochlear vein canal. That's the canal for inferior cochlear vein. Cortigno described as the Cortigno's canal. But when I drill the inferior wall, now I am removing the round window. Can you see my tunnel?
So you always use a round window insertion, boss?
No, I just remove the cresta.
It is extended round window.
There is no the question of round window or cochleosphere or anything. I have to make a tunnel.
Yes.
Now see the three-dimensional entry into the scala. Can you see that?
Yes.
See the 3D. That's a full tunnel. I showed this tunnel through the silo-endoscope in the temporal bone dissection.
Yes.
See this is my, where is my that matter? Give me the right angle. My modulus is medially. See, my direction is inferiorly. Try to see what I am trying to say. Right angle. This is now inferiorly directed tunnel and I am in the middle of the tunnel. This is 3D. This is not a 2D opening. See, my modulus is here medially. where I am pointing through my instrument. See this? And this is going inferiorly. Now, if I happen to drill this medial wall where I am pointing, see this? Then I can damage the, the corticulus canal and the chorda tympani. If only I drill medially. So, those people who have a question that I am drilling inferiorly doesn't mean that I am drilling in the medial wall. Steroid.
Dr. Satish.
See the 3D canal. I will wash it here a little bit with the steroid. This is Dexona.
When, sir, yes. What are you saying, sir?
Yeah, Satish, you have removed the round window membrane. Is it
yes.
Is it necessary? You can just slate it and then you can use like that or no? I mean, you can lift the
Pardon?
You could have
removed the round window membrane?
Yeah, I removed the round window membrane and just area inferior to it to give me this big opening. Had I not removed this inferior bone, crista, my direction would be towards the modulus. The moment I remove the crista, my direction has gone inferior. See, now I am in the middle of the tunnel, and for this sake, I sterilized my styloendoscope earlier. I thought I may have to show that. So I will show through my styloendoscope now. Steroid. See this full tunnel, 3-dimensional tunnel.
Yes, very well.
And where is my modulus, where is my osseous spiral lamella, where is the membrane? Now I am going to show you. See above, superiorly. See that reflection of the bone.
Yeah.
Upar dena hai, curved angle. Right angle. See now.
What is the purpose of flushing this with the Dexona?
See this superiorly here is the osseous spiral lamella. Medially there is the modulus and I am in the inferior tract.
All right.
Steroid is good. I have opened the vestibule. Little bit of the fluid exchange has happened. Section. So for the protection I am using steroid.
To avoid friction while insertion of electrode?
No, not for that. A lot of people
you
use
tried Hylage while putting this.
A lot of people use Hylage. I have never used. Sir, probably you were using earlier. Sir, you were using earlier Hylage?
The Hylase was not so much for lubrication.
Yes.
The Hylase you put in so that when you drill the crista,
bone dust will not go.
The bone dust would float on top and it was easy to
Yeah.
People are using viscoelastic substance for making it frictionless.
See, the idea is not to damage the osseous spiral lamella, not to damage the modulus, and to ensure that your implant remains in the scala tympani. That is the way to prevent, trauma. The grading of trauma you go, this is so delicate a bone, osseous spiral lamella. I am going to show you with the styloendoscope. The moment your implant buckles a little bit, it will damage it. So what happens? Suppose I had not gone inferiorly and I go with this trajectory through the round window directly. The moment my implant goes and touch the modulus, it will buckle. It will curl wherever it will go. It can easily damage the osseous spiral lamella, easily damage the basal lamella. You have no control. It can damage anywhere. And that is what you are supposed to prevent.
Any care we take when we flush this scala tympani with steroid?
No issues. It is very safe, boss. We are very, very gentle. I am right in the lumen. I am not flushing anything, but in the lumen only.
Not pushing with pressure, just instilling.
Yes, they know. क्या दिया? वो कहाँ है? Scope.
That's why I am asking this question, because what we say, the insertion of electrodes is slow, otherwise the eddies in the perilymph will occur and that may cause micro tear in the basilar membrane. This is the theory behind that slow insertion.
See, can you see?
Yeah.
Yes.
Yeah. Let me, just a minute.
What is this? Endoscope.
Yes.
Endoscope, yeah.
Now see inside the scala.
Yeah, yeah.
See the lumen. See this whitish bone above. This whitish bone. This whitish bone is osseous spiral lamella.
Yeah, yeah. Beautiful.
Below that whitish bone, that reddish pinkish area is the modulus.
Yeah, yeah.
And see above the basilar membrane where this whitish bone is ending. So see, my scala is open. See now the scala.
Beautiful, beautiful.
Yeah, beautiful.
This is osseous spiral lamella whitish. This is such a delicate bone. And below that medially is the pinkish from where this osseous spiral lamella is arising. That is the modulus. And laterally where it is going to the lateral wall, just immediately before the lateral wall is the basilar membrane. So I have a tunnel now. See all the way. I have a tunnel now and now my implant will go straight away in the tunnel. Now it is a child's play. You just have to go there and push your implant. That's it. It is not going to hit anywhere.
Yeah.
Now, but there are certain things still which are not in your control. The dimension of the scala, the anatomy of the dimension of the scala inside. You know, as you go further in the scala, there is a lot of narrowing and dilatation in the scala. Right from the, scala vestibuli, tympani, there are a lot of narrowing, dilatation at 180 degree, 225 degree, 400 degree. There is various narrowing and dilatation. So, if that is unequal, that you don't know, it is not in your control, that may lead to little bit of, trauma. That for that you have to be very, very careful with the slow insertion. I hope it is clear.
Yes.
Steroid wala wo, gel foam. Now I will fix my implant, and until then I'll leave a gel foam soaked in steroid over there. See, the idea is you have to create this tunnel. See, this is a tunnel. See that three-dimensional tunnel. It's not a two-dimensional opening like round window opening. It's not a two-dimensional opening like cochleostomy. It is a cochlear tunnel. Inferior cochlear tunnel. Steroid.
Background music.
This is again a steroid until I fix my implant. Now give me implant and it is done. Our next case is induced, and that is a cholesteatoma. And after that we'll have a subtotal petrosectomy for a multiple times operated CSOM, mastectomy with profound loss. And a bad cavity. Patient wants a dry ear now.
After how many days you advise switch on?
That will leave upon Ranju.
Usually nowadays 10 days, 12 days.
Deepak, I told you my job is 10% mechanical. Patient, all questions, answer all to Ranju to eat her head all the time. She refers me when the patient is ready for implantation, I implant. That's it, and refer back to her. We discuss, of course, the need of implantation. And now, otherwise in my practice, I am doing very less these children. More and more implant I am doing adults, post-CSOM, post-skull-based surgery, because we are not doing government schemes. So all children are going, majority of them are going to the government schemes. Very few we are doing.
Sir, do we switch off the cautery unit before implant?
Already.
Yeah.
Already switched off. We have checked hemostasis. We have harvested periosteum.
Satish, can you reduce the magnification?
Zoom,
Yeah.
Zoom
I will now. I will now.
Dr. Nadeem is asking have you ever used Marceline tape to fix the,
Doctor?
Nadeem from Bangalore.
Yeah.
Have you ever used Marceline tape to fix the implant like we are doing this?
Yeah, a lot of people use that. Even sometimes the implant companies provide that.
They used to, they don't anymore.
Now they don't, yes.
See now, experience and result.
See now, this is the super fixation. See now.
Yeah.
See this, it cannot be mobilized.
Yeah, very secure.
If these patients even, undergo 3 Tesla MRI with a, the playing card in between interposed with a tight head bandage, it doesn't, bother at all. And we will invert this. So this exercise takes half an hour extra, but this is very useful to the patient.
Worth it.
It took you 5 minutes extra, not half an hour, Satish.
He's talking about us.
Yes, invert. Yes,
when I was in Hinduja,
see now, I have inverted it, and I'll here invite some fibrosis to keep it in place by pushing a little bit of the surgical over it. That's it. So this will not bother anymore. Okay?
Yes. What
now,
are your means the
pardon?
Post-lingual cases you operated? Have you operated that pressed by cases? Profound loss or drug-induced?
Yeah, drug-induced, yes. And believe me, those are the best candidates.
Yes.
If you have cases like ototoxicity, post-Meniere's disease, those are the best patients. You have unchanged spiral ganglion population. The results are amazing. The worst are post-infectious complications, Those are worst.
Yes.
Like post-meningitis, they are worst. Worst for many reasons. First of all, electrode insertion is difficult. How many electrodes you may insert, you never know. Even the meningitis gives changes in the central nervous system also, right up to there. You cannot expect good, and spiral ganglion cell population is affected in that. Steroid.
Yes.
So the worst are the patients who are, post-infectious. Post-ototoxicity, most welcome. Those are most rewarding. And nowadays we are doing a lot of implants post-lateral skull-base surgery also. Even the patient, we have done same time. Now see, our site is ready. This is my implant. This is 17 millimeter implant. The active distance is 17 millimeter. See this 16 electrode contacts. Switch off. बंद करो.
Suppose the drug-induced hearing loss is there. Is there any role of interval also in that case? Suppose patient comes or arranges fund.
How much time should be there?
When you are asking when? In what situation?
Drug-induced.
Drug-induced you can do any time. That is post-lingual.
After 1 year of implant.
Yeah, it will work. See, once the patient has had auditory experience. See now, I have loaded the implant in the inserter. Can you see this?
Yeah.
I have directed this inserter opening towards the modulus. See that?
Okay.
Yeah.
खींचना मत. Now, steroid दे दे एक बार. And I will show you the final insertion, and that will be a cakewalk, I tell you. See my tunnel?
Yes.
Yeah.
See this?
Yeah.
And I am releasing now. Slowly. See, my direction is antero-inferiorly.
Yes. And sometimes
how much time should be the duration of insertion? Like if somebody says it should be 1 minute, 2 minutes.
So it's the experience, you can feel it. I cannot tell in terms of,
Sometimes this metallic just sheath snugly fits on that cochleostomy site.
Yes, that's it. And again, all these commercial implants, their speech processor are designed to stimulate certain frequency range. All commercial, all companies, they cannot stimulate like the Greenwood frequency range from 0 to 20,000. They are not going to stimulate the entire range. They stimulate from 70 hertz to 11,500 or 750 range. That means the distal 5 millimeter is useless. Proximal 3 millimeter or 4 millimeter from round window is useless. Even if you leave your electrode contacts there, they are not going to stimulate anything. They are not going to give any auditory sensation. That middle, from 4 millimeter to 21, that is the area which is going to be stimulated. Yes. See this? It went off so well, without any pressure. Now give me, I have to, fix this. Earlier people used to create a smaller opening, but here we prefer to create a bigger opening so I can seal it better. This is a very, very important step because this is something which is going to prevent ascending infection in future.
What's your experience about, even I want to ask Kirtane sir that about hybrid, what would we say, autoacoustic?
Yeah, I have not had the occasion to use. I have not done it. Yeah.
Electroacoustic.
Yeah, but there your insertion technique would have to be different. Then you can't, like washing with hydrocot, etc. All that you can't do. Ideally, you should do a round window insertion if you can. Because then, and that is where your slow insertion comes in.
Not beyond.
That is where the slow insertion of taking 3 minutes to put your thing, so you don't damage the hair cell population there at all.
Now see, it is fixed. Can you see now?
Yes.
It is circumferentially around it. And in that electroacoustic, since you are supposed to preserve the hearing, low frequency, you are not supposed to, go beyond 18 millimeter or so.
Yes.
And that is the best candidate, if you ask me, are people with high frequency loss. Even in the press by cases.
Clarity of speech is gone for them. Clarity.
Poor speech discrimination.
So your lower frequency.
For bilateral implants now, how often you advise for the bilateral advance?
Ideal. My first advice is bilateral to all patients. That is ideal.
Yeah.
See now, after fixation, I am leaving 1 or 2 gel foam there.
You put some bone dust also over here?
Yes, now. Yes, at the edge of the, this thing. Lade. Because this distance from here to the round window, this doesn't change with the age, even with the mastoid expands. And it has been proven.
This ground electrode we are seeing on this advanced bionics, it will touch bone somewhere?
Yeah, that tunnel is made, no?
In this, there is no ground electrode.
Yeah, there is a ground electrode.
This is ground electrode is here.
You can see it there on the array.
Ground. Sir, in this particular model, there is no ground electrode. Sir.
No, this is a ground electrode. You can see right in front of us, Satish.
Okay, this one?
Yeah, that's the ground electrode.
And that is inside the sheath.
Yeah, but that's the ground, yeah.
But you don't need to insert a separate ground electrode.
There is no separate wire or separate array.
Yes, that's right. That's what I was saying.
That's true with the metal sonata also.
Yes.
You are not going to check the stapedial reflex?
Elevator. Pardon? Yeah, you can check stapedial reflex also.
Yes.
Yeah, with a high magnification under microscope, when you do NRT with a loud sound, you can check you can see the stapedius moving. Kirtane sir, can I ask one thing? Kirtane sir, any experience of electrocochleography anywhere?
No. I mean, as you are inserting.
During insertion to see cochlear trauma. In workup also, pre-operative workup also.
No, I think
no more.
I don't think electrocochleography is done so much as You do autoacoustic emissions and then you do BERA, so you don't need to do electrocochleography. They are using as you insert, and that is in the hearing preservation cases.
Yes, sir, the new tool which Cochlear company has provided, in which you can see the graphical representation of your electrode is going inside, whether that can predict something?
Predict what?
See now, my electrode has been fixed.
Of your electrode.
Hello?
Or not.
Hello?
Yes.
My electrode has been fixed. On the implant is fixed laterally. Electrode array has been fixed with this thing. See, this is a bone cement. This is bone dust. And this array is coiled and lying underneath this ledge. See the ledge I created.
Satish.
See this? Yes, sir.
Satish, the ground electrode should touch bone.
Hello. This is no echo in the air.
Sir, in this particular model, see this. There is no separate ground electrode.
No, better. What you're seeing, that thing on the array, push it under the bone. That is much better.
This one here. No?
This right on top, right in front here. No. There. It's going under the bone.
This is silicone covering, sir. This is silicone.
There. That one.
This one.
That little steel cylinder you see there. That one. Yeah, that should touch the bone. So then your grounding is much better. You can put a little bone dust there or something to hold it in that position. Yeah.
Maybe rotate the device a little bit. Maybe rotate the device a little bit.
I think it's fine now.
Bone dust there. But I don't want to put bone dust here. No.
Hello, Satish.
Yeah.
If you coiled your implant the other way, it would automatically go there. If you can take out the wire and coil it exactly the other way.
Now it will come in contact.
Because sometimes when ground electrode is not in bone contact, we have a lot of problem when we do NRT. We have to put a saline there, massage.
Yeah, you have to wet it thoroughly.
Yes.
Otherwise, the NRT may not come.
Yes, sir.
Bada dejal form.
Satish, what sir is telling now, that if you turn it round, it will rest on the sigmoid sinus area.
If you take out the coil and put the coil the other way.
I got your point. I don't want to disturb inside, sir.
अच्छा इससे जेल फॉर्म से दबाना चाहते हैं. तो यहाँ bone dust रखने में क्या प्रॉब्लम है सतीश भाई?
No, because this will not allow the, coil to expand with the expansion of mastoid. Now it is okay. It will work.
Right.
So let's do NRT now. Okay. Yeah. Now at this point of time, what we want to know, whether our electrodes are working, they are good, they are not any sort of device failure, there is no open circuit or closed circuit. And secondly, with this neural response telemetry, when we give the sound stimulation, will record the brainstem, response. So this way, that will tell you the integrity of the implant and how it stimulates and get the brainstem response. Though, in these situations, very good. Can somebody bring the external camera? मैं wash करूँ. तू बंद कर देना. See, I will show through the external camera. Now, the impedance is very good. दिखाओ impedance. Can you show? इधर लाओ. Impedance is very important. Impedance shows the integrity of the electrodes, functioning of the electrodes. If the impedance is not good, then it's something you must always keep a backup device. So in case there is some fault in the device, you can use another backup device. Yeah, इधर लाओ. ये दिखाओ. एक मिनट रुको, ये खोलना मेरे. My God, PP. इसको करो, इसको करो, इसको फोकस करो.
Sir, we can't
पास आ जाओ,
switch
पास आ
external
जाओ.
camera.
कह रहा हूँ ना पास आ जाओ. अच्छा, अच्छा.
Manish, just switch external camera.
कैमरा तो चेंज करो यार. Yeah, are you getting the picture?
Yes. Now we're getting. Yeah.
Now see the NRT going on. Give me some pointer. Let me tell you. See, this is electrode 1 done. This is electrode 5 going on. And see the stimulation response. This is very good. Can you see?
Excellent, excellent response. Very robust.
Amazing response, robust response. And that too we got at 150. At a minimum.
Yes, very good.
Yeah, at a minimal threshold, we are getting, see, such amazing response here. All electrodes had good impedance. This NRT gives you a sense of relief that your electrode is stimulating the spiral ganglion cells and you are getting brainstem response. But it is not everything. Many a times, because of the changed environment in the cochlea with bone dust, sometime air bubble, some blood, or some whatever change in the environment, in the electronic environment in the cochlea, you may not get NRT at all. Or sometime, that once you don't get NRT, you can do a later, a day after, or if everything is fine in the cochlea, whether your implant is in cochlea, it will come back. But sometime you get NRT, yet your implant is not in cochlea. That is a disaster. You can't rely on it so much. Suppose this implant goes, and that happens mostly when you are doing round window. This is the point against round window. When you go through the round window straight, your implant may curl up. It may go in the vestibule. It may go in semicircular canal. And then once in NRT, what you get? You stimulate the vestibular end organ receptor. You get NRT because of stimulation of the vestibular nuclei. You get NRT, but it is a disaster. So you can't rely on NRT like anything.
Or do an X-ray.
Yes, radiology is the answer. You get X-ray done, you get cochlear view done, we get cochlear view X-ray done. That is simpler. And for what you do need to do, turn your patient head towards you, 60 degree, and turn table down 15 degree. And then come from below. You have to, their X-ray will come from below towards the roof, and it will give you the pure transmodular view. And you can see exactly how much your implant is turning around, how much degree it is inserted. This implant I am expecting 420 degree. That's it. And I don't want to go beyond that. So X-ray is final. Suppose I am getting an RT. If my X-ray shows implant is in position, nothing is required to be done. Even if I don't get an RT, I will not bother about it. I am happy with my insertion, and X-ray is okay. Yes, you can see the impedance again. So NRT we have got, impedance we have got. In some difficult situation, like I am implanting a malformed cochlea, I can take the help of C-arm. Band kar do. I can take the help of C-arm. And in that situation, you can see the real time. Your implant going real time inside. You can see on the screen how it is curling inside. That is required only for difficult situation, not for all implants. That is not for all.
IP3 and common cavity.
Yes, common cavity, yes, sir.
And IP3.
Yeah, sometime intraoperative X-ray saves you from problem. We have happened with us once. The implant had some resistance. We brought it out. Next time we put, there was no resistance. We came out, got the X-ray done, there was a tip fold over. See how X-ray can save you from problems. So NRT will not change the decision, whether it is coming or not. X-ray is decision making. If you have a facility, you can get intra-op cone beam CT scan as well. Cone beam is the ideal modality to give you exact picture of the electrode gone in the cochlea. You can count the number of electrodes gone in the cochlea. You can count at what level the electrodes have gone up to 16 millimeter, 18 millimeter, 20 millimeter. And you can see exact scalar localization in the cochlea with cone beam. We get many a times cone beam CT scan done for our purpose, and it will show you that the implant has gone all the way in the scala tympani. It has not crossed the scala at all. And that is the biggest thing we want from implantation.
Satish.
Yes, sir.
Do you do sometimes stapedies reflex?
Yes, yes, sir.
I mean, normally,
yeah, just
in
for,
this case, of course, it's a separate
just for academic purpose, that's it. If somebody had asked me, I had shown, I pegged with the bone dust, I didn't remove that.
Yeah, because in those cases where NRT is not good and your we have seen SRT is good.
Yes.
So that sort of, satisfies you even more.
But sir, again,
that shows
is,
you that it's getting stimulated. So,
yes.
Yeah.
Yeah, but Satish, compliments to you. Fantastic demonstration. Thank you very much.
Sorry, sir. It is nothing, hardly anything for you.
It
you
was
have
really
been
interesting. Very good.
Have you installed cone beam CT at your radiology department?
Pardon?
Have you installed cone beam CT in your radiology department?
Yes. We have a tie-up nearby.
Okay. I think CT PNS also we can do
yes.
with cone beam CT.
PNS and temporal bone, the best is cone beam. You know, the best thing is, here in the cochlear implant, I am telling for the post-op purpose, cone beam is the best because it avoids the artifacts.
Right.
Even if you have the best multi-slice CT scan, it cannot beat the cone beam. It cannot match. Cone beam has no artifacts.
How much it is costing?
It's the cheapest one. Is 30-35 lakhs you can get a good cone beam.
And how much area it will require, and whether we have to put those thick walled
just 1 meter by 1 meter in a corner in your OPD. That's it.
Okay.
And patient get the scan done in sitting position. That's it. You don't have to lie down like for, for PNS, for axial section, you have to lie prone and all that. Just sitting position. The radiation is so less, you can do even, I advocate even for the pregnant ladies. Then the CT is so fast. In 10 seconds time, you acquire the entire data because there is no tube above it. In the multi-slice CT, there is a tube which rotates. How many slices per second, 4 slice, 16 slice, 64 slice. There is no tube. There is no recurring cost of the tube.
And need for technician? Reporting?
Nothing. You can train anybody. There is no recurring cost. And you can get the slice thickness of 0.05 millimeter.
Okay. I think to any ENT surgeon who has got OPD of 40 above, he can install that cone beam CT. It will be a cost-effective tool.
So you are installing, I think, now.
Yeah, I'm just asking you.
So anybody has any question before we move on to the next case, that is a cholesteatoma?
It's a really fantastic demonstration, and it was really an eye-opener for all of us.
Satish?
In the presence
yes, boss.
Yes, John, few clips are there. I think few things we can share with all the audience that they should not do such mistakes in CI.
Yes, please.
These are real-time recording. So I think just starting this thing, just see. I think you have studied how to manage, how to handle the electrodes. A few points are there. Just you should avoid to hold the electrode by any instruments. Like this was doing, it was doing. You should not hold the electrode by any way. Make a proper size cochleostomy, because if you make a small cochleostomy, then you may have to struggle while inserting in, and you will try to put more pressure over there, or you will try to take it out, and that will lead to this over there. Be gentle while electrode insertion. Otherwise, what happens? We try to push with pressure, and just because your cochleostomy size is not very good, so you are struggling over here.
This is too narrow.
That could lead to the I think it is not acceptable.
This can damage the electrode itself.
Just see that coil, the kinking over there. That kinking could be very dangerous. And suppose in post-op case you find out this kinking, then what you will do at this level? Hello. Can you see the picture over there?
Yes.
Yeah, suppose you find this kinking in post-op X-ray, then what will be your protocol? You will take the patient again, or you will wait for some time?
Because Satish, I have seen so many surgeons who tend to king the implant, especially when they are using cochlear REST.
Really?
What is sir, is that what you will do in this case at this level?
So, what was the post-op NRT?
NRT perfect, NRT, no issue.
NRT was perfect with this much of kinking. And this is extra cochlear. This kinking is outside the cochlea.
You can say kinking just outside the cochlea. But in future it can be risky for the electrode.
Yes.
So sometimes we get
yes.
microfracture over there.
If I put this question in Rajiv in another way, intraoperative, if you see on C-arm this kinking, then
you have to bring it out. See, the biggest mistake in this committed is the size of the cochleostomy. Number one.
That's a second, but make a proper size cochlea. It was a
number two.
Small.
Number two, I make it very clear. There should be no discussion about cochleostomy, round window, peri-round window. You have to take a call whether you are able to insert in the long axis of the scala tympani through the round window, through cochleostomy, or by any means. So the best is when you go through the round window, the biggest advantage is you don't make any mistake going extra cochlear. Sometimes you make a cochleostomy and you happen to open an infracochlear cell, and then your implant remains extra cochlear. So best is go along the round window, but remove the inferior bone, that crista.
Absolutely.
So that will orient you. That will never allow you to leave the lumen of the cochlea. Here, this is extra cochleostomy. I don't know where the implant is going.
That's also the advantage of a transmastoid approach, which is a straight approach rather than the other ones which come from above and then down. They may have when you are manipulating with instruments, the electrode can get damaged and a little more kinking is possible there.
So what did you do, boss, in that case, where?
No, I said that's why this transmastoid approach is the best.
Yes.
If something like this happens, then you have to just, if it is in the middle ear, then you just try. Otherwise, the damage is already done. You try to straighten it more, possibly the damage will be even more.
Just take it out and then put it again. That was the best solution.
Correct.
And the other thing, don't try to push hard.
That's why.
The moment you find resistance, you have to pull it.
That's why I kept 3 points over there. Best ideal cochleostomy. Don't put any pressure over there, and never try to hold the electrode with an instrument with a normal forceps.
What did you do in the last case after that? After the kinking?
Just there's one more. And then last case, I took it out and then put it again over there. It was a normal thing. I captured that image for the discussion.
Okay. At the same time, intra-op or later?
3 hours after surgery. 2 hours after.
Okay. You opened again.
Yeah, it took only 20 minutes only.
Okay.
So Satish told just to take a proper posterior. Do not play with the cord at a facial angle and just respect both the things, chorda and facial. Otherwise, if you try to play with the.
Can you see the chorda there?
Yeah.
Can you see the facial?
Facial.
Absolutely.
And otherwise, if suppose the facial is exposed, then better to put some graft over there and then keep the electrode separate from that place. So I think you should respect the angle. And as Dr. Devang discussed in afternoon.
Satish, have you ever faced this, that this posterior tympanotomy is very narrow and you have to mobilize the chorda tympani, something like that? Have you ever faced?
A couple of times. I mentioned just before, I transected the chorda for the extended approach in a high jugular bulb. Few times we have.
We have a long discussion today regarding how to secure the implant. So I think there are so many ways, like you can put a switcher like he put over there, and screws are there. You can make some tunnel over there. That's why the security of that wire cable should be there properly. And like he did today, that he put some bone dust over. That is one more way to secure your electrodes.
Yes, yes.
There's so many ways. And I think this is not allowed. This one is because, as sir has told so many times, I think we can, no wax should be used in the, you remember this case, Dr. Satish?
Pardon?
Remember this case, bone wax
Bone
around
wax? No, we try to avoid.
Yeah, it is just the same case. I think we should not use bone wax in and around the cochlear implant. And the one video is also going on, never do suction in and around the cochleostomy side. And when you drill that, the bone dust should be never, it should not go inside your cochlea. That we should all take care. Regarding this part, I think this is the one more thing. This is not allowed. Suppose we are putting inserting electrode, and suppose that time bleeding to occur, then I think this should not have, blood should not go inside your cochlea. That is one more take-home message.
Yeah, that is detrimental.
Detrimental, and I think it should be avoided in all our cases.
See, all these things, all such trauma will invite fibrosis and ossification inside. And that will have an impact on the present, output as well, overall output of the implant. At the same time, in future, if you happen to revise it, it will be much more difficult. So, minimal trauma, that is the goal, and the best thing is your osseous spiral lamella and basilar membrane should remain intact. That's it. Then you, whatever you flush, you do anything inside, nothing will happen, because your spiral ganglion cells are intact. Anything which damages the spiral ganglion cell population will have the impact on the overall outcome. We have 36,000 spiral ganglion cells in each year. Even if we have a 10,000 cell, the implant will work optimum. So anything which has a detrimental effect on the number of spiral ganglion cell, the population, will have a negative impact. That's why I said the ototoxicity, Meniere's disease, those are a good situation where only the outer hair cell and that part of the cochlea is affected. Spiral ganglion cells are intact. In infections, ossifications, that is disaster.
Yes, yes. And one more thing about that, if you do the bilateral cochlear implantation, you must take extra care about the cauda tympani nerve.
Yes, both sides should not be injured.
Because besides only loss of taste sensations, the patient or the child will develop zero stomy.
Yes,
yeah, that is
just before doing any drilling for the, take a proper shape this thing, because sometimes you do with your experience and sometimes make a big this thing. That was a surgeon's mistake, you can see over there. So use proper that was few points I want to discuss with you. So take a proper hemostasis before going for any insert in electrode insertion inside. Otherwise, it will be detrimental for you. Okay.
There's a question here again. We got. Can I go ahead?
Yeah,
yes,
sure.
Yes, boss.
The question here again from Madam Dr. Kushum Patidar. What to do if the implant gets infected post-operatively? See, infectious complications are disaster. Anyway, they may range from a minor infection to a major infection warranting explantation. The issue is, if the area where the implant is placed and the infection happens to occur in soft tissues, first of all, you have to handle it vigorously, because the foreign body being in place, the biofilms may form and then they are resistant to any antibiotics, whatever you give. Number one. So, the first thing, you have to do local debridement, local cleaning, whatever betadine, whatever antibiotics you use, topical antibiotics are better. And then you start injectable antibiotics. We start clarithromycin on all those patients which prevent biofilm formation immediately in those situations. And many a times we have got cases where the biofilm formed already, the implant exposed, not responding to antibiotics. And we have now done a couple of almost 15, more than 15 cases. We use the Manuka honey to remove the biofilm and wash the implant and place Manuka honey in the bed all around. That is one of the strongest biofilm, anti-biofilm agent. And it works so well, we could salvage many of the implants, otherwise all would have been explanted. So, implant-related infection is something which can be a disaster if it doesn't come under control, because you have already opened
the avenue in the inner ear for the infection to ascend in the inner ear and then in the subarachnoid space. So infection you cannot take lightly. Even the slightest of the concern of the infection, you have to be vigilant.
Satish, is there any role for superficial temporal artery TP flap?
Yes.
As a preventive measure?
So once we salvage, we have done couple of such with the TP flap only. Like suppose I am removing the biofilm, I am exploring. The biofilm envelops the entire foreign body like a jelly which envelops everywhere around the foreign body. So you have to remove it, wash the bed completely, drill away the bad bone, completely infected bone, and then bring in a new blood supply to cover the implant. And that is in the vicinity, the best one is TP flap. You cover with the TP flap, bring in for any infection to make the antibiotics penetrable, bring in new vascularity. That will allow the antibiotics to penetrate now. And the new vascularity is a boom to take care of such situation.
Satish?
Yes, sir.
If you do not have Manokahani, then vancomycin is a good choice. You know, you can
vancomycin?
Wash it there and then you can put it there. Yeah.
Yeah, a lot of people are trying different things. I went through an article from Dr. Shalab in Delhi. He used the tea tree oil. And he published that tea tree oil. He washed the implant and put in the bed and it worked very well. So, there are so many anti-biofilm agents. The important thing is you have to remove the anti-biofilm radically, thoroughly, without leaving a trace of it. Because if foreign body is there, it is going to grow again. And then with a new vascularity and good injectable antibiotics and anti-biofilm agent like clarithromycin, it may work and you can save the implant.
Have you ever faced device failure?
Yes, that's why I mentioned in the during session also surgical that you need to have a backup device. And these failures are of two types. Hard failure, that is the manufacturing defect in the device. Like suppose here, when we do NRT, there is multiple open circuit or short circuit. You may have to change the device from beginning. Or you are using device and now suddenly the performance compromise on NRT, on mapping, you have multiple short circuits, open circuits. Then you may have to ask company, the company will do in situ integrity testing. And on in situ integrity testing, if there is a fault in the device, company will replace it. That is hard failure. Another is soft failure. Soft failure is no definition. The patient was having good response and all of a sudden deteriorating, not responding, is getting non-auditory stimulations, some other sensations, and started disliking the device because of funny feeling and all those. And then again, in spite of all in situ integrity testing, the device is passing, you may have to change the device. That is soft failure. It happens.
Next case, CT scan is ready.
Pardon?
Next case.
Sir, Kitne sir, your comment on the device failure. Sir, you have to unmute.
Just one comment that with the advanced bionics implant, you can check the integrity of the array before you open the implant. You know that? They have a test that they can do to show the integrity of the implant before you open it. So if you have the advanced bionic guy there with you, you can ask him how it's done.
Okay,
on the table, before you open the implant, you can check that there is no electrode defect over
How do they check?
They put the coil on it and they run a test on it. So before you open the implant, you can check the integrity.
In the closed box? They do
in the closed box. In the closed box, yes.
Oh, it's funny.
I think that medal also does it.
Yeah. That an integrity test before they open it.
They open it.
Any more question or do we move on to the next part? Our next case is a cholesteatoma. Cholesteatoma is one of the most fascinating surgery, you all know, and there is a lot of debates always going on what technique to go in for. Intake canal, canal down. There's so many n number of techniques described by different people. And ultimately for a novice surgeon, if he goes through all the techniques, he may get ultimately confused. So, connection na laptop. So I am connecting to my laptop regarding this case and about the basics of the cholesteatoma surgery and decision making. Hello, madam.
Good evening, sir.
Good evening.
Fantastic demonstrations. Wonderful. Mind-blowing.
Thank you. कोई किसने बंद कर दिया है?
Kapila was Dr. Rajiv Kapila was asking. In that case, we did the inferior cochleostomy. Was there need to remove the round window, or we could have we could make a extension of the anterior cochleostomy like that?
No, there was not a separate cochleostomy. That is not warranted. I just removed the inferior wall of the round window attachment to go in a different trajectory antero-inferiorly in the cochlear tunnel. That's it. Yeah. So now something about the cholesteatoma. Are you getting the slide? Boss, are you getting the slide?
Getting, no boss.
Okay. So there are a lot of controversies in the cholesteatoma in terms of decision making. स्लो कैसे हो गया यार? Why this is not? Yes. Yeah. So this is about decision making in cholesteatoma surgery. So there are few concepts which we have over the period of years found, going to the literature, talking to the experienced people, experiencing ourselves, and in our series and our follow-ups which made us reaching to this level. So the most important thing in middle ear surgery, for anything like we discussed during tympanoplasty that time as well, the concept of middle ear cleft and the aeration. And this work is most extensively studied by none other than Jacob Sade, who is the father of Eustachian tube surgery, Eustachian tube physiology. Silent karo.
Raju, can you unmute everybody so that background noise should not
दिनेश
come?
सोता रहता है क्या? दिनेश को फोन करना, म्यूट करे. म्यूट करे. हेलो. हो गया. प्रॉब्लम है. Yes, yes. Coming. Hello, can you hear me, sir?
It's okay, now it's okay.
Yes.
Okay. So this is Jacob Sade's work, which has done a lot of work on the Eustachian tube physiology. So according to him, this middle ear cleft is like a lung and tracheobronchoid system. In the sense, the middle ear is like a gas pocket where the gas comes in from the Eustachian tube by intermittent opening of the Eustachian tube, and from the middle ear the gas is absorbed continuously by the mucosa and its blood supply into the blood system. So the constant absorption of the air leads to negative pressure, and which leads to
intermittent opening of the eustachian tube to neutralize that negative pressure. That's how the physiology runs. So, coming to the cholesteatoma, as I mentioned, there are a number of procedures described which are good enough to confuse everybody. Take canal mastectomy, canal down mastectomy, then intake canal mastectomy with obliteration, canal wall down mastectomy with canal reconstruction, canal down mastectomy with cavity obliteration, epitympanoplasty with obliteration. Whatever you can name, you can. And number of these are very few. Now the question is, what technique is the best? And mainly there is always a, discussion in the conferences. I don't know why. Intake canal is best or canal down is best. To me, this terminology has to be renamed for the reasons I am telling you. Number one. And number two, intake canal and canal down, both techniques are best. Issue is, they are executed properly and they are done properly for the proper indication. If the intake canal is done for a wrong indication, it cannot work. And then people will blame the intake canal. You see the literature, people will mention, I had been doing intake canal for 10 years, then looking at the recurrences, failures, I changed to canal down solely. Then you will find literature, people quoting, had been doing canal 1 for years, but because of the continuous discharge, repeated cleaning required, hearing issues, swimming issues, I have totally changed to intake canal. It is not the intake canal or canal wall which is to blame. The thing is to properly execute the procedure and to properly execute for proper indication. That is more important. So our terminology for them is interiorization and exteriorization. Why so? Interiorization means what you call intake canal mastectomy, wherein you reconstruct the physiology of the middle ear cleft again, wherein the aeration comes through the intact eustachian tube and there is mucosa inside for the gas exchange to maintain the middle ear pressure. That is how the normal physiology works. That is interiorization. Provided, it can be done? Provided the eustachian tube function is normal and the adequate mucosa is left in the middle ear cleft after the surgery. This is important. Then only interiorization can work. Got my point? Suppose your eustachian tube is intact and during the mastectomy and entire disease removal, you happen to remove the entire mucosa of the middle ear cleft. And now you reconstruct interiorization intake canal. What is going to happen? This will be akin to blowing the air in the bony trumpet. It is not going to work. Even if your eustachian tube is delivering air, where the air is going to go? There should be mucosa for the gas exchange to happen. And in that situation, interiorization will not work. So when interiorization is planned, you have to be sure about the good eustachian tube function. At the same time, reasonably good amount of mucosa preserved. That is one.
Is there something as a good amount of mucosa? Is there something
that's what I am coming to. Yes, Ashish, your important point. Good amount of mucosa means the mucosa on the promontory in the middle ear and in the atic floor, which is most importantly used for the gas exchange. Number two, now there are so many techniques named here. Intake canal mastectomy or a canal down mastectomy with canal reconstruction. What is it? You have done a canal down and you reconstructed the canal and again did a interiorization. Though it was canal down, but it is interiorization because again you are reconstructing the cavity on the basis of eustachian tube function and the mucosa for the gas exchange and reconstructing the physiology. So anywhere you are reconstructing the physiology, whatsoever you are doing, canal down mastectomy with soft wall reconstruction, anything, this comes under the category of interiorization. Other thing, when your eustachian tube function is at question, when you at the end of the surgery you have not left with adequate mucosa to give interiorization, then the best is to exteriorize. But once you exteriorize, mind it, you don't have Eustachian and tube to deliver air for your mucosa to function well. In that situation, you have to excentrate all possible mucosa to prevent mucoseals and discharge. So, once you are doing exteriorization, you have to excentrate all dependent cells. Once you are doing interiorization, you are not supposed to excentrate all cells. You just remove your disease, preserve your mucosa and reconstruct. That is the basic difference. So, both the techniques are good in the sense, if they are executed properly. If I am doing intact canal, I will be very sure on the table that my Eustachian tube function is good and I have preserved adequate mucosa for the gas section, then only I will commit. At any point of time, I find this is not good for interiorization and I am lacking the mucosa or Eustachian tube. There is a lot of adhesive otitis media and all that. The Eustachian tube may not be good. I will not do, and then execute properly a exteriorization. So all these examples are exteriorization. Epitympanoplasty with obliteration. Intact canal mastoidectomy with obliteration. All these are exteriorization. You are eliminating the mastoid, you are exteriorizing, you are not making it, keeping it dependent for the Eustachian tube aeration. Now, why is this question came? The canal wall up and canal wall down. The reason is, by and large, there are certain advantages of canal wall up which make us biased to do a canal wall, because it reconstructs the normal physiology of the ear, normal contour of the ear canal. Contour is maintained, you can use a hearing aid better, your hearing outcomes are better as you have a good adequate middle ear space, and overall quality of life is good, which is not in the canal wall down. In canal wall down, you end up leaving an ugly ear cavity, you cannot swim, you cannot recommend patient to swim, hearing aid is difficult, hearing outcomes are overall poor because you end up leaving a shallow middle ear cavity and overall quality of life is poor. So that is the basic difference. Now, other differences if you look at, which make us biased towards intact canal or canal down. Let's go to enumerate them. So, what is it? Why people are moving towards a canal wall down? Why do people say canal wall down is better? One of the reasons is access to the difficult areas of middle ear. They believe that they can access entire temporal bone areas, important areas with a canal down, with good access. Believe me, any area of the temporal bone I can access through the intact canal. First of all, number one. Number two, if I am not able to access to the intact canal, I will bring the canal down and reconstruct it again. But that procedure will remain interiorization. That's my point. Provided it fulfills the basic criteria of Eustachian tube function and mucosa. So, there is no question of access to the difficult areas through the intact canal, by means of thinning the canal, by means of temporary removal of the canal, by means of making window in the canal temporary, you can access all areas. So this point is not very well taken. Second is, one of the biggest drawback of the canal wall, what people who used to do earlier and now they have given up, is the recurrence, the possibility of the recurrence. Because you cover everything, you never know, even if you have left a trace of cholesteatoma behind, it is bound to come back, and that is a disaster. So, for all those patients, when you are recommending intact canal, it should be a part of informed consent that they may have to undergo a second look procedure. Then only one should do an intact canal procedure. This is mandatory for those who are doing intact canal to recommend their patients, because you are giving them a good quality of life, but at the cost of need of a second look, a close follow-up. That's why those people who are not able to come for a close follow-up, like from distances, from villages, who are not committed for the lifetime follow-up, it is not better to do an intact canal procedure. It is better to do a canal down, execute good canal down. I tell you, if you execute a good canal down surgery, it is wonderful, it gives amazing results. It is the fault in the surgical techniques once you do a canal down which leads to problem. So when there is a possibility of a revision disease, it is always remain in the canal down. That's why canal up. That's why a possibility of the second look is always should be in the consent process. Then revision surgery required. Yes. These are the advantages of, canal wall up that water exposure limit. There is no limit, no vertigo. It takes, the cavity heals very fast. Frequent follow-ups is not required, unlike canal down, because the cavity problems are there. So why people are, try to get away from canal down, why people look for the canal wall up is only for the cavity problems. So if you tackle it both ways, one is, if you don't leave a big cavity to give cavity problem, yet you can do a canal wall down and one-time procedure to avoid a second look. At the same time, if you execute even a good cavity, properly, marsupialized cavity, properly epithelialized cavity with a good vascularized tissue, you can avoid cavity problems. So it is not, my point is, it is not a question that which technique is better or which technique is worse. Both techniques are good. They have their advantage and disadvantage. That's why people are switching from one to other technique, considering that this technique is not good. So what is our protocol? It is never a pre-operative decision what technique is to be chosen. Number one, you cannot commit to the patient what technique you are going to do. This should always be an intraoperative decision, except some, exceptions, which I am going to tell you. Like, for example, we did that day, CSOM with facial palsy case on Thursday. We were biased from the beginning to do a exteriorization. The only reason was, it was a small cavity. On CT scan, we saw the area where the mastoid was hyponeumatized, very small mastoid. So in that situation, we are biased to do a canal down because we can avoid all cavity problems. And at the same time, we can get away with a single procedure to prevent the need of future surgeries, which is required in a, second look in a intake canal procedure. So there are certain things which makes you biased towards the intact or, canal down. And one of them is size of the mastoid, which is certainly, I always want to do a canal down, if you ask me. Except, I will do intact canal only intraoperatively when I find a good eustachian tube function likely and a good mucosa left at the end of the removal of the disease. Only these two will make me do intact canal, otherwise all canal down. Exteriorization. Except again some situations, like for example pediatric patients. Pediatric with a pneumatized mastoid, you are not supposed to give bigger cavities. You have to reconstruct the hearing as well. Pediatrics are more demanding. They are not going to follow the rigorous cavity care and all that. And you have to be biased towards intact canal procedures or interiorization. Right from the beginning. Now in those situations, intraoperatively if you find, even if you are biased preoperatively, that you have not left the adequate mucosa and eustachian tube function, it has question because of the nasal issues, other eustachian tube issues, better to do a canal down. So preoperatively, biasness should not follow strongly intraoperatively. It is finally the intraoperative decision, which is the finally decision. And the third procedure we do, we have the case next to it today, is the subtotal petrosectomy in blind sac closure. That is ablation, complete ablation of the middle ear system. That means that is required for only those situations where the reconstruction of the middle ear is not possible for the hearing. And patient at least can be given a dry ear for the future problem, to prevent future problems. Then is the final solution is the subtotal petrosectomy and blind sac closure, wherein the entire air cell tracts of the temporal bone are removed, preserving the labyrinth. Close the eustachian tube, close the outer external canal, remove all mucosa and epithelium from everything, and in that cavity you obliterate with the fat or something to give a sterile environment to prevent future infection. At least you can give a dry ear to the patient.
to prevent the need of future coming to hospital for discharge or anything. But only those patients wherein there is no question of reconstruction of the hearing left behind. In those patients still, the possibility of cochlear implant in future remains intact. If somebody wants to get implant done, it can be done at the same stage or even in the future. Suppose the patient has not done the cochlear implant yet, you have done a good subtotal pterygoectomy obliteration. Patient wants to get done after a year or so. You can take the patient, open, remove the fat, open, lift the fat, see the cochlear implant and push the fat back. You can additionally put some fat more. So that remains, that option always remains viable in subtotal pterygoectomy and implantation. So for interiorization again, these are the three prerequisites. One should go in for interiorization only when these three things are fulfilled. And that too intraoperatively as a final decision. Functioning Eustachian tube, mucosal preservation and counseling for the second look. Now what happens sometimes, preoperatively you get biased. Like this patient, I am preoperatively biased for the interiorization, you know. This is an atic cholesteatoma with good intact mesotympanum, air-filled cavity of the mesotympanum. This gives me a good indication that the Eustachian tube is good functioning. And I'm biased towards interiorization. We counsel the patient with this technique. You may have to be in long-term follow-up, more than 10 years even. And then the final decision again will be taken intraoperatively. When I remove the cholesteatoma, preserving the mucosa intact, then only I'll commit to this technique of interiorization. And here my entire goal, because I am biased towards interiorization because of the good Eustachian tube function. Had this cavity been having a patient been having a plastered middle ear mucosa, I would have been biased toward exteriorization, looking at the faulty Eustachian tube function. But here I am biased towards a good Eustachian tube function. So now I am going to remove the cholesteatoma with utmost care, preserving the mucosa, maximum mucosa intact. And if I am happen to do that, I will do an interiorization. This is the goal today. So this is the indication for interiorization. Then there are certain maneuvers, you know, intraoperatively, by means of which you can improve your outcomes of interiorization. To facilitate mucosalization, to facilitate aeration, like suppose in the process of removal of the disease, you happen to remove a part of canal wall. Suppose a lot of people criticize that this technique is not good for a extensive cholesteatoma. If in order to remove the extensive cholesteatoma, I happen to remove the part of the canal wall, I will not mind it. At the end of the surgery, if I have happened to preserve the mucosa well, if my Eustachian tube function is well, I will reconstruct the canal wall. So there are certain procedures, adjuvant things which can improve your outcome, like repair the bony defects of the canal wall. There are certain mucosal defects. To improve that epithelialization, I can use silastic or nowadays, you know, gel film. In certain areas where the removal of the mucosa is difficult, you know, and you cannot leave it, you can take the help of laser. Like around the ossicle, over the oval window in certain areas, and you can take the help of laser without, you know, destabilizing anything. You can take the help of endoscope to make sure that nothing is left behind. If you have a doubtful question of ventilation, in spite of a good aeration, if you still have a doubt in mind, you can use the ventilation tube at the same time to prevent ventilation issues coming. And second look is most important. That is something you need to counsel the patient. So in follow-up, what is required? A second look. Now in this present era, we have more weapons except the second look, so that we can avoid second look sometimes. Like we can use the endoscope to see inside. You can use angle endoscope to look into the corners. I can, with a small incision, I can put my endoscope behind in the mastoid cavity and see if there is any cholesteatoma coming. Okay? This way you can, many of the times, you can avoid a formal second look procedure. Secondly, with the advancement in the imaging, and particularly this non-ecoplanar diffusion weighted MRI, you can, to certain extent, I mean up to 95% sensitivity, you can diagnose the cholesteatoma. I will show that In this next case, we got the diffusion weighted MRI done, and you can diagnose the cholesteatoma without the need of second look or an endoscopy even. So, after the interiorization, these are all the weapons in your basket for the follow-up. In case second look you want to avoid, you can take the help of either endoscope or non-ecoplanar MRI.
Sorry, Satish, bringing in my atresia again. This is what you had advised me for cholesteatoma in atresia patients.
Yeah.
To rule out the same non-planar diffusion weighted MRI, correct?
Yes, yes, sir. For any cavity. Like this subtotal petrosectomy obliteration we'll do today, this should be followed with diffusion weighted MRI only.
Yeah.
In a slightest indication of developing cholesteatoma, you are picking up with that, you can take a call to explore. Otherwise, you can keep following that up. That is quite sensitive, and I will show that on my DVD. We have next patient's, picture. So
in atresia patients, you make sure that there is no cholesteatoma preoperatively when they present.
Yeah, you can use that diffusion weighted
MRI.
MRI.
That is the imaging study to be done.
Yes.
Yeah, thanks.
So now, coming to the exteriorization, why this exteriorization technique is blamed to be a worse technique than intact canal? It's not worse. It's amazing technique. The fault lies in the surgical steps, and if the surgical execution is good, this is equally good. It's equally amazing technique, and these are the reasons, possible reasons for persistent discharging cavity. Like incomplete exenteration. You see the cavity in these pictures, these two pictures on the right side. This is the kind of condition of the cavity, and then you blame the procedure is something never acceptable. The next case, subtotal petrosectomy we are taking, has been operated 4 times. And you see the state of the cavity after 4 surgeries. That so poor execution of the surgical procedure, you can't blame the technique. So here, there are many reasons in the canal down, incomplete exenteration. Ashish, is Ashim there? Ashish?
He's not there.
Okay. So like inadequate meatoplasty, all these reasons we all know for the failure of the mastoid cavity. Inadequate lowering the facial reason, and you will find in that next case all these reasons there in spite of 4 surgeries. All these reasons mentioned are there to give a persistent discharging cavity. So this is the third technique which we follow. Problem cavities, multiple surgeries. When the patient has because of the previous surgery, large tegment defect leading to brain herniation, we have to obliterate the cavity for prevention of future infections, future meningitis. If you have happened to expose the critical structures like dura, sinus, carotid artery, better to obliterate for future, provided there is no possibility of hearing reconstruction in future. Then only, because after multiple procedures for such cavities, after multiple surgery, their hearing level goes down. They develop sensory neural loss also, and they have even full conductive loss with no possibility of reconstruction also. And we have number of indications. This is one of the favorite procedures in our practice. We get a lot of revisions, subtotal petrosectomy, and this gives patient a big relief for a permanent cure to the ear discharge. And it keeps the possibility viable for reconstruction of the hearing by means of cochlear implantation in the future. By means of Baha, if it is a conductive component, you can still put a Baha any time in the future. So this doesn't, take away that possibility. And then petrous bone cholesteatoma, deep petrous bone cholesteatoma, we'll be keeping in the coming webinar some of the cases of deeply invaded petrous bone cholesteatoma, and that is where you need to obliterate the cavities for the future infections, for prevention of future infections. So, how to decide? We discussed so much of things, still the confusion remains in what patient what to do. So these are certain factors which you need to take into consideration before taking a final call on interiorization or exteriorization. In between them, there are certain good techniques. Like I tell you, one of the techniques is soft wall reconstruction. People have given different name to the some of the variation of the technique. And one of the soft wall reconstruction, we had a demonstration last time by, Sudeep Munjal from Sirsa, who demonstrated soft wall reconstruction. And that is a technique propagated by our own Dr. Suri Prabhu.
So what he does, that's a very interesting. Suppose you have exteriorized the cavity. You cannot excentrate each and every cell in the labyrinthine region around the semicircular canal. What you can do? You can include that area in the middle ear cavity and rest of the cavity behind you can obliterate. Got my point? So you can include that by means of reconstructing a soft wall over that. Rather than a rigid wall, you can reconstruct and cover that with the cartilage and include in the middle ear cavity, so that the aeration remains to the remaining cells in that region which you cannot remove otherwise. And that is what soft wall reconstruction. So there are in between so many techniques which are good and people are taking into consideration for those particular situations. But we cannot be biased towards one technique. So these are the decision making factors that you need to take into consideration, that what technique to be chosen in what situation. For example, the number one thing which is prevailing worldwide, you know, is what? Surgeon's preference. I do intact canal. I love intact canal. Intact canal is best. It is all surgeon's preference by different means, you know, and this is something which is prevailing over the world, overall in the world, not the science. You have to be out of the dogmatic approach. Anybody who is sticking to some particular technique, no other technique is bad. All techniques are good. We have to be able to choose according to the situation. So like, for example, final decision is intraoperatively, but there are certain situations it makes you biased and you can take a call accordingly. Like patients in whom regular follow-up for the mastoid wall cannot be assured, you get biased towards a canal down, so that you don't need a second look operation. Or patients who don't want to go repeated surgery. Some patients tell you, do in one time, I will not come back for I don't want any operation in my life. You know, the patient preference is the final thing. And then you better go ahead and do a canal wall down or exteriorization, but execute it properly. Like in the cholesteatoma, in the facial palsy case we discussed, if there is a cavity, don't leave the raw areas. You cover with the vascularized tissue to promote epithelialization. If you leave a lot of raw areas, that will invite osteitis, discharge, and such cavities many a time become lifetime draining cavities. So a poor execution is something to be avoided, to avoid blaming the technique. Hearing is a factor sometimes. If you are operating on a only hearing ear, you're always, biased towards something, a final solution for that particular. In the sense, for a solution that will not require surgery again and again. Because every ear surgery, every time you do ear surgery, has a potential to give sensorineural hearing loss. So in only hearing ear situation, you're always looking for a technique which doesn't require a revision, and that is what the canal down is. Because every time in a intact canal, you may have to revise the procedure, you may have to go for a second look, and any inadvertent ossicular movement, drilling, anything can lead to sensorineural hearing loss. So better is to do a once for all canal down. This is a very strong bias towards a canal down in only hearing ear. But now it is changing in the present era. I remember the question in the last year, when Kirtne sir organized a panel in Jaipur on stapes surgery, and he asked Ashish Bhumkar, in only hearing ear, would you do stapes surgery? He said, yes. If it was a dead ear, so what? We'll do implant. So now, the time is changing. Because that incidence of giving a dead ear in the only hearing ear by an experienced person is 1 in 100. So he said, I will do one implant free if I get 100 patients of only hearing aid stapes surgery. Still, I am happy about it. So the time is changing because you can restore the hearing by means of a available technique of cochlear implantation. So in the only hearing ear only, even in that situation with the advancement in the radiology, with the extent of disease, advancement in the surgical technique, advancement in the cochlear implant and all, a lot of people are changing even to a good reconstruction if the eustachian tube function and mucosa is available, to an intact canal technique. Otherwise, there is a strong bias towards a canal down technique. Use taken tube function, nasal issues, slightest doubt, canal down. Don't take a chance for a revision. You don't want revision, but once you are thinking that it leads to a possibility of a revision, why to take a chance unnecessarily? So that is something, again, gives you a bias. Small sclerotic mastoid, like we did on Thursday. Like we did on Thursday, we were biased towards a canal down because ultimately we know we are not going to give a cavity problem as the cavity is being very small. Pediatric, elderly, high risk, you have to take call accordingly. See, these are the factors you need to see where your patient is falling into. Pediatric, I said we are in a bias of interiorization to give them hearing and prevent the cavity issues, because they are not going to follow rigorously the cavity cleaning and all that. Elderly, we are biased towards once for all, canal down, that's it. Because they may not be fit for surgery again and again in their lifetime. So do once and get away. So there are certain biases we need to. High risk patient, just one surgery, canal down. So you may not get a chance to revise it. You may not get the patient fitness again. Sometimes cholesteatoma is going in the eustachian tube. That is a situation where you can't think of any kind of reconstruction, because that may not give you opportunity, may lead to eustachian tube fibrosis and all that closure. So there are certain situations like hidden areas, aggressive disease, exposure of vital structures, I told you, it keeps you biased towards exteriorization, or if the hearing is gone, towards the subtotal petrojectomy. Labyrinthine fistula is most interesting. You know, still it is a debate what to do. So you have to take into consideration many factors. If you are finally committed to a interiorization and there is a labyrinthine fistula, come to the fistula in the end after completing everything and take a call. If it is a small fistula and you can peel off the skin, fine. If your procedure is curative in one stage, what you have done, intake canal, you remove it, fistula, gently and close it, preserving the hearing. If it is a big fistula, then you have to take a call for a second stage. Until then, the epithelial pulp will form and you will be in position to better remove it. If you are committed to an exteriorization, leave the epithelium over it and be a part of the cavity. Then it is so simple. So fistulas are again complex to take a call. You know, it is your intraoperative decision what to do. Pre-operative imaging has changed the scenario now. Because now you get a lot of information pre-op for the decision making. You get information of the labyrinthine fistula pre-op, you get information of the status of the tagman, status of the exposure of the vital structures, status of the labyrinthine fistula, everything you get to know pre-op. So now the decision making has become more easier, you are more biased, you are more prepared pre-op, what to do it down or up by means of imaging, because imaging has totally revolutionized. And recurrent disease and complication again makes you biased for a canal down. Like suppose you have done a canal up earlier, interiorization, and the patient eustachian tube function ultimately didn't do well, and patient is coming back after a year or two with the same retraction, you know, cholesteatoma, then there is you don't have to think twice to exteriorize it. But if somebody else has done and you find intraoperatively that the earlier procedure was not properly executed and still a possibility to, you know, reconstruct it, you can take a chance. Taking the patient into counseling, into confidence, then you can take a call even for the interiorization. So these are the various factors, decision-making factors. Each and every is important and you have to take into consideration thoroughly before taking a call, and that too intraoperatively for a final call of interiorization or exteriorization. It cannot work that I've been doing for 10 years exteriorization and I am good at it and I'll do that only, intake canal is bad. Or I am doing intake canal for years. That is a pure dogmatic approach. That is pure non-scientific approach. And there is no place in science for such approach. Pediatric, I mentioned already, pediatric are, you know, pediatric are different pathology. In pediatric, you have to take a, you have to be, or you are biased towards the interiorization, but not 100%. It is the final decision on the table what to do. So finally, what would I say? Both are good techniques. Technique is never to blame. Choosing the right technique is most important. And once you choose the right technique, execution of the right technique, surgical procedure is more important. And for every patient, it is an individualized decision, and that too on the table. This is my submission before we move on to the case. We can take questions or your opinion. Surendra sir, your opinion?
Yeah, Satish, I think I would, in certain situations, I will have my preferences. For example, as you correctly said, when there is a grade 4 atelectasis according to SARDE classification, or grade 5 for that matter, then it is not compatible with intact canal wall. You have to bring down the canal wall. That is my concept. Then profession. Suppose someone is a swimmer. Then possibly intact canal wall approach will be a better option, or canal wall up technique. Also, the kind of cholesteatoma that you have. Certain cholesteatomas, they grow in, like, they still have a very well-defined sac. So when I open the mastoid and I see it's a very well-defined sac, and I can deliver it nicely through the editus and down, and then combine it with the anterior approach, then I will be inclined to continue with the canal wall up technique. One point I want to ask you, how would you, suppose there is a dura exposure?
Yes, sir.
Significant dura exposure someone is doing. In that case, would you be better placed in keeping the canal wall up, or you would like to bring the canal wall down to avoid future infections?
Yeah. So first of all, I will take the same things in consideration. Eustachian and tube function. Eustachian and tube function, availability of the mucosa. If that gives me relief that I can reconstruct,
yes,
I will certainly interiorize, and why to expose that exposed dura and everything to the exterior. But yes, if there is a slightest of doubt in, the existence of the reconstruction, I will not think twice, do exteriorization and cover those areas, exposed areas like dura or sinus with the vascularized flap to prevent infection.
Okay.
Any questions? Meantime, we can take, before I take you to the radiology of this patient.
Radiology, because we are waiting for the radiology.
Any questions, boss?
No, I think it's almost been covered. They wanted to ask about the pediatric, which is the earliest age you would recommend for the canal wall down, or you can exteriorize him. What is the earliest age?
To me, this question doesn't exist. It is always an intraoperative decision.
Yes, yes.
You cannot be biased.
All the things been covered so far.
So, there is always an unnecessary discussion going on, which technique is good and which technique is bad. This question doesn't exist to me. All techniques are good, provided how you execute it and for right indication or not.
But I think Satish Pachauri is asking at what age you will take patient for surgery, minimum age.
If cholesteatoma is there, then age is no bar.
Okay.
See, we have removed cholesteatoma in 4-year-old child. How can you ignore cholesteatoma? Age is no bar. It is not central perforation or something tubotympanic you can wait for.
Any queries about the tube function, how you assess the functioning of the Eustachian tube? I think we told many times.
Yes. Eustachian tube, like in this patient, I will show you the picture. That itself shows that Eustachian tube is good. Otherwise, particularly in pediatric patient, the incidence of otitis media, incidence of Eustachian tube issues, incidence of nasal problems are high. And you always have to keep an eye on the nose of the patient. Even post-operative, even if you operate, you have to keep an eye on the nose of the patient to prevent allergy, infection, sinusitis, adenoids, ruining what you have done. So in pediatric patient, this is most important. Rather, before taking up the patient for surgery, you have to thoroughly see the nose
and fix the nose first before coming onto the ear. That is the right dictum, 100-year-old dictum. And it works well in the pediatric patient because pediatrics have a high incidence of, adenoids and other issues, resulting into malfunction of the eustachian tube. And if we ignore that, you cannot ensure a good, reconstruction of the ear.
Satish?
Yes, sir.
Hello, Satish sir.
Yes.
Hello.
हाँ जी, madam.
Sir, concomitant pathology in the nose and throat is there. So first you would like to deal those problems, and then you will go for the cholestoma surgery. Or
Yeah. If it is something need to be treated. If nose is significant, nose is having something significant, need to be treated, which has an impact on the eustachian tube function, that has to be addressed first.
so if patient is a huge adenoid, then first you have to remove the adenoid.
Yes, you have to. They may be having associated allergy also. Allergy is a big factor. Allergy, adenoids, otitis media with diffusion, eustachian tube, they are all interrelated issues. So you have to break that cycle. You have to address the adenoids, allergy, and improve the function of the eustachian tube before directly impinging on the ear.
Satish?
Yes, sir.
But you cannot, see, your classification is really excellent. It simplifies a lot of misconceptions. Regarding the children, adenoid is a very straightaway correctable thing.
Yes.
There are many nasal conditions in children which possibly after adenoidectomy might improve. But there are certain conditions which will not improve, like allergy. They are always catarrhal children. In those cases, I think the treatment should go parallel and cholestoma still has to be addressed.
Cholestoma cannot ignore.
Yes.
You cannot ignore for long.
Sometimes we do give extra significance to deviated septums. I don't think deviated septums, unless they are causing sinusitis, they by itself can cause eustachian tube dysfunctions.
Yeah.
And you should not try to just keep doing surgery for doing septoplasty, and then later on by that time the patient is already fed up by nasal treatment, and then he just goes away.
Yes, absolutely.
So that has to be very judicious judgment.
But there are certain group of patients where again we are biased, like cleft palate patients.
Yes.
Cleft palate patients have inherent eustachian tube malfunction majority of the times.
Absolutely.
Because of the muscles, dealing with the eustachian tube, controlling the eustachian tubes are affected. And in those patients, you have to be careful. Doing interiorization in those patients can be troublesome sometime because of the question mark eustachian tube function. So again, those are the conditions which makes you biased towards exteriorization for one-time procedure.
Yes.
Always tube closer, extrusive block means closer. Like your student Nitesh Ore is asking, a situation where the cholestoma is in a contracted mastoid, the exposure of the posterior fossa dura and tegmen is eroded, and the tube is congenitally blocked because of bony defect. How would you proceed in this case?
Subtotal petrosectomy. That's it. It itself answers. You have a contracted mastoid, you have a tegmen exposed, dura exposed, eustachian tube, no function of eustachian tube, no question of hearing reconstruction by any means. And your structures are exposed to give complications already. Give him one-time solution of preventing discharge and preventing complications for future. And you can give him a BAHA if a conductive hearing loss is, or if it is sensory neural, you can give other things, and that is all the options are viable. Because once hearing reconstruction is not possible, you have to ablate it. That's it. At least give him a dry ear and prevent complications for future.
Yes.
Satish bhai, if patient is having very good dry hair, good healed cavity, and he comes 6 monthly for removal of wax, and when we do the suction, he is having very severe vertigo that he is afraid of. For those patients, for this vertigo, we can do anything?
Yes, you can. First of all, you can reconstruct the cavity better by putting some soft tissue bone dust and reconstruct the mastoid. Simply reconstruction of little bit of the mastoid can save you from big problem. And secondly, if nothing works, I told you, there is a final answer for everything. You can obliterate the mastoid if you have a, good epithelialized mastoid, good exteriorization and saucerization of the cells done. Elevate the epithelium and obliterate the mastoid completely and reconstruct the posterior canal wall. If it is a good functioning middle ear, you can reconstruct the posterior canal wall and obliterate the mastoid. So there are so many procedures in between, to save from such problems. And if nothing is reconstructible, subtotal peterochectomy, obliteration.
One good point by Dr. Grease from Bhilai. Can we do adenoid with the cholesteatoma or CSOM or septoplasty with CSOM in same sitting?
Yes, adenoidectomy you can do for same sitting. Secondly, the septoplasty doesn't have a direct relationship with the outcome. Having a septal deviation is not an indication for surgery always, and it has no direct impact on the outcome of the ear surgery at all. Adenoidectomy can have, because it has an effect on the overall mucociliary clearance. It can precipitate towards, eustachian tube dysfunction. It can precipitate towards sinusitis, and it can affect the overall mucociliary activity. That is something justifiable, but not septoplasty. And that you can do same sitting.
Two people asked, one was septoplasty with mastoid, he asked about adenoid and mastoid. I just combined together.
Pardon?
One person asked about the septoplasty and CSOM, and he asked about adenoid with septoplasty with CSOM. So I just combined both the questions.
Yeah.
We can do some. We should not do septoplasty, but we can go for adenoid with.
Yes.
CSOM.
Yes. Absolutely.
Finish radiology now.
Pardon?
Radiology now.
Okay. So we have discussed the CT scan of the temporal bone radiology in perspective of otosclerosis and stapes surgery. We have discussed in reference to cochlear implantation. Now this is different perspective. What all need to be seen on radiology in perspective of chronic suppurative otitis media surgery. This is altogether different what we are going to look at now. So CT scan has to be seen differently for different pathologies. Here, like we discussed so many factors, we will touch upon only those issues which have the impact on the surgical outcome, which have the impact on decision making, which have the impact on choosing the particular surgical technique, and which can make your surgery difficult or which can lead to complications. All these factors, all these things to be seen now differently in this CT scan. Now, first of all, coming from above down. First important thing I would always point out here, to see the pneumatization of the mastoid. See this, overall temporal bone. This has a significant impact, and this pneumatization has to be gauged by three ways. There is a clear-cut way of ascertaining whether this temporal bone is hyperpneumatized, hyponeumatized or not. So, to me, this temporal bone is hyperpneumatized. See this, extensive pneumatization. There are three parameters. Number one, this is the sigmoid sinus. Can you see? This is the sigmoid sinus. This pneumatization, which is extending up to the anterior wall of the sigmoid, up to the posterior wall of the sigmoid, or even beyond the posterior wall of the sigmoid. See, it is going beyond the posterior wall of the sigmoid. See how extensively it is pneumatized, number one. Second parameter of pneumatization is come from above. See, this is superior canal. This is the petrous bone going towards the clivus. Here is the superior semicircular canal labyrinth. And see how much of the pneumatization is there anterior to it. It is pneumatized, and that is significant pneumatization of the petrous apex as well. And third definition is, it has a significant impact. Third is, pneumatization you need to see in the coronal plane. See this. What is there? See the cochlea and the vestibule. See, this is cochlear vestibule, this is intra-auditory meatus. And you see deep to this anteriorly. This is extensively pneumatized on both sides. So what it has an impact? how it is important. In case you are doing an exteriorization, you need to extensively drill away all these cellularity. Otherwise, it will remain a permanent discharging ear if you leave that much of mucosa behind. And what does it mean? It means such an ear, we are biased towards interiorization. Just remove the disease and make sure the rest of the cells are, ventilated down the eustachian tube for the good function.
Point.
Yeah. So now we are looking at the CT scan differently. So number one is pneumatization. Number two, like sir mentioned, how is your Tagman plate, how is your sinus plate, whether they are affected by the disease, exposed, or disease going beyond that, or anything like that. Sometimes we get asymptomatic, perisinus abscess, extradural abscess, so many things. So this is your sinus. This is your sinus, sigmoid sinus, all the way, all the way, all the way, right from up, right from up, right from up till, see this, up to down completely. This is jugular bulb. So this plate is completely intact all the way, you can see. Can you see?
Yeah.
Now how to see the Tagman? We didn't see all these Tagman and all in autosclerosis, in CI and all. That has hardly any relevance. But here it is. So now here a lot of things to be seen in the Tagman. I'll give you a classical example of this. Why it is so important. See, this is Tagman plate all the way. This is your mastoid and this is the Tagman antri and this is Tagman tympani. Why so? At this level, see, I am going from anterior to posterior. This is coronal section. Here at the level of the cochlea, this is all lateral to medial. What is this? Tagman tympani. Okay? Yeah. Now, if I go behind, at the level of, these are semicircular canal, see this. If I go behind, at the level of semicircular canal, what you see, this is lateral, this is medial. What is this? Tagman antri. This curvature of the Tagman from lateral to medial has a significant bearing.
Yes.
I remember one of the patient, a surgeon, not knowing the importance of the Tagman curvature, ultimately led to facial palsy. And that was a disaster. We revised that. How come? This Tagman laterally, see, many of the patients, this is not too much of curvature. If laterally, this is lateral, this is medial, at the level of the semicircular canal. If this lateral Tagman is quite low, got my point? And medially Tagman many times you see high up. That means when you start drilling laterally, your Tagman is quite low. That pushes your direction of drilling below. Got my point? And that doctor, by mistake, that was doing an antrostomy to look for the antrum, was biased by this Tagman which was directed, which was quite below, laterally. Kept on following the Tagman below and ultimately damaged the facial nerve. The actually antrum was medially quite up because the Tagman curvature was taking the antrum high up. So we need to see in every case the curvature of the Tagman, that is very important. If laterally the Tagman is low or medially Tagman is low, medially is high, laterally low, all these things have to be kept in mind once you start drilling for the mastoid. Got my point? To prevent complications, number one. Number two, how much your Tagman is low or high. How do you ascertain? See in the coronal picture. This is my lateral semicircular canal. Can you see?
Yes.
And this is Tagman. You can see through this how much is the difference height above that. See, almost 5 to 6 millimeter. So my Tagman is 5 to 6 millimeter above the lateral canal. It is not low-lying Tagman. Got my point? Yeah. My Tagman curvature, height of the mastoid, height of the Tagman, And if there is anywhere tegment deficient, see it is all the way intact. If there is anything like brain tissue prolapsing or anything, how much the size of the defect you can see on this coronal section. So this is something important in the CSOM case. I am just taking to the radiology in perspective of CSOM. Not as a whole, I am showing, discussing the CT scan of the temporal bone. So that is one important thing. Again, after the tegment, sinus, third important thing is the facial nerve. See, in CSOM surgery, in cholesteatoma, particularly here in the cholesteatoma in the attic, you have to be concerned about the exposure of the facial nerve, because the facial nerve may be exposed, may be compressed, may be dehiscent, or may be intact. Knowing the state of the facial nerve make your surgical course much simpler, much better. It can, make you suspicious of a probable facial nerve dehiscent. You have to be careful about that. So here, see this again. That is the intra-auditory meatus. That is the facial nerve going here. Can you see?
Yes. Yes.
And the same thing, this side. See on the disease side. This is interesting. See, this is the facial nerve. This is the geniculate ganglion. Let me change the contrast to show you better. See the geniculate ganglion?
Yes.
And see the facial nerve. See, my cursor is on facial nerve. This is the second genu of the facial nerve. Can you see?
Yes.
This is the second genu of the facial nerve. See I am keeping an eye on the facial nerve. See my cursor, where is?
Yeah.
That is the facial nerve. That is how you have to look at the facial nerve. And see here in the mastoid, there is a lot of thick bone over the face. This is lateral. The thick bone lateral to the facial nerve. That is ample of height of the facial ridge. The bone of the posterior canal is not deficient. Facial nerve is deep in the place. And here, following this, but in the tympanic segment. See, now I am going towards the tympanic segment here. Here the facial nerve is probably dehiscent here. Can you see this?
Yeah.
This opacity, you cannot differentiate whether it is a granulation, cholesteatoma, fluid, mucosa on CT scan. You can differentiate on MRI findings, on the basis of MRI findings. But on CT scan, you cannot differentiate the opacity. But what all you can see here is the facial nerve is dehiscent in the tympanic segment. Can you see this?
Yeah.
Very clear. In contrast, whenever you have a doubt, go to the opposite side, normal side, and see. See the facial nerve here? See the facial nerve here? See the facial nerve? Can you see very clear? See the facial nerve all the way. Such a good facial nerve. No disease, no dehiscence, and this is normal facial nerve. See this bony covering of the facial nerve all the time. See this bony covering of the tympanic segment completely. Yes. And here on this side, it is completely, at places, it looks dehiscent. See this is dehiscent. So third important thing is the facial nerve. Now next, obviously we have to see at the labyrinth if there is any fistula.
Lateral canal fistula just
In extensive, pardon?
Lateral canal fistula just show
Yes.
exactly where we...
Yes. So you have to see.
What was the complaints of the patient?
Complaint of the patient is a hearing loss and
Patient
recurrent
have
discharge.
vertigo or
Not really. Hearing loss and discharge. Hearing
no
loss,
vertigo.
no vertigo. Now see, next thing is we need to see the labyrinth if it is eroded by cholesteatoma. Cholesteatoma has a property to erode the bone. For bone destruction by enzymatic and by contact, by pressure, so many things. So we need to see if the cholesteatoma has destroyed any part of the inner ear. We are looking at the CT scan, I am telling again and again, in perspective of the CSOM only. So here, what part of the labyrinth? We need to see the cochlea, number one. See, completely intact.
Yeah.
See the lateral wall, this is promontory. Completely intact, normal. Now see the vestibule, completely intact. And for the semicircular canal, see this lateral canal, follow this. See this? Completely intact. Yes. See on, Compare with the opposite side. See the lateral canal. See this. Follow this dynamically. It's an intact bone everywhere. See this. Similar cochlea. For the best view of the semicircular canal, we have to go to the sagittal. I have shown you earlier as well. And here it is important to rule out, the semicircular canal fistula, inner ear fistula. Now see here, one by one. This is your vestibule. This is your superior canal. See this? Intact?
Yes.
This is your lateral canal. See this lateral canal. See this lateral canal all the way intact. All the way, complete circumference. There's a thick bone all the way around. And similarly, if you go behind, this is the posterior canal. And see, it is joining the superior canal to form crus commune. And it is completely intact. So there is no labyrinthine fistula, you can say. We have seen Tagman, we have seen dura, we have seen pneumatization, we have seen facial now, and we have seen the labyrinthine fistulas. Now the next thing is, though it is not important here, that is important in on MRI, if the cholesteatoma is extending anywhere beyond the middle ear cleft, because here you cannot differentiate between the cholesteatoma and the opacity. Now, the dehiscence of the surrounding structure, jugular bulb, see this, jugular bulb absolutely intact here, carotid artery absolutely intact. In the deep petrous bone cholesteatomas, these structures many a times you will find dehiscent. I told you we are going to keep very soon a case of petrous bone cholesteatoma where you will find all the entire petrous bone is invaded by the cholesteatoma and making all these structures at risk. And you can evaluate that on the CT scan. Now, another important thing is the status of the ossicles. How can you see? See, first of all, go to the opposite side. Can you see the malleus and the incus?
Yeah.
Malleus, incus, and see how it is coming to the stapes here. See, this is stapes, this is vestibule. This is vestibule, this is foot plate. This is foot plate, this is suprastructure. This is long process of the incus. Could you see that?
Yes.
Malleus, this is malleus head, this is incus body, long process, and this is stapes. Intact. Now look at this side. Look at this side. This is the level of the ossicular chain. What you see, some part of the malleus head, can you see?
Yes.
Some part of the incus body, can you see? But no communication beyond that. No communication beyond that towards the suprastructure. I see some faint structure looking like suprastructure, but I don't see any communication with the incus. See here.
Yeah. Yes, yes.
Not very sure. And this is all completely opacified.
Yeah.
So the status of the ossicles, status of the middle ear, and next important thing is the sinus tympani. See, how can you see sinus tympani? See this. Go to the opposite side first. This is facial now. This is cochlea, round window. See, this is round window. This is facial now, and medial to the facial now, this air space is sinus tympani. Can you see? The same thing if you go here. This is your, see, facial now.
Yes.
Going up, going up, going up, facial now, facial now, facial now, facial now. This is your sinus tympani. Can you see the opacity?
Yes, yes.
This is the round window, this is sinus tympani, and this is, facial now, and this is opacity. Now, you cannot differentiate whether it is cholesteatoma or granulation, secretion, hypertrophic mucosa or whatever.
Yeah.
You cannot differentiate. So, in CSOM disease, these are the important points that need to be seen in every patient before you going for cholesteatoma surgery. These are not required. It is not essentially required in, central perforations. But in cholesteatoma, if you have a CT scan, it gives you a lot of anatomical details, lot of factors important in decision making. And if you ask me, I always recommend a CT scan for cholesteatoma. It is always good to have. It is not something like guidelines. It is mandatory but it is something definitely which has a huge impact on the decision making.
Satish, one point I wanted to make here is that you should also mention the degree of petrous apex pneumatization.
I have already mentioned, boss. I have already mentioned.
Because that will be very, very important for deciding what sort of cavity you want to give during the surgery.
Yes.
Yeah.
See this, I mentioned in the beginning, I think you were not there that time. This is the level of the petrous apex, that's the level of the superior canal, and see the pneumatization medial to it.
Absolutely.
Secondly, the infracochlear pneumatization. I mentioned that. See this infracochlear pneumatization, because if you are doing exteriorization, you have to look at this first, whether you will be able to do. See, this is cochlea. This is cochlea.
Yes.
This is, the intra-auditory meatus. And see this huge pneumatization going anteriorly towards the petrous apex. This is petrous apex.
Yeah.
This is apex of the petrous bone, and see the huge pneumatization extending to this.
No, the clinical implication would be when you need to do a reconstruction, a partial reconstruction to aerate that area down the station.
Yes. So here I am biased towards performing an interiorization.
Exactly.
Because if I exteriorize, I need to excentrate every possible cell, and which is so difficult in such extensively pneumatized, petrous apex. It is, next to impossible if you try to do that. And in that situation, if you are not able to do and do an exteriorization, it may become a permanently discharging cavity. So this concept of pneumatization ascertaining is very, very important. Now, I mentioned in the beginning, these are different cuts. If you want to see in this particular patient, see the facial now.
Beautiful.
This side. See, this is the superior canal view, and this is the facial now on this side. See, in spite of that much disease here, this is the vertical segment completely intact, genuine, and the tympanic segment here is showing dehiscence. That's what I was predicting. Yes. See that? So that's how you can reconstruct. Now the most important thing in cholesteatoma, in such diffuse middle ear opacification on CT scan, what is the differential diagnosis? It could be a hypertrophic mucosa granulation. It could be, empyema, fluid. It could be cholesteatoma. It could be cholesterol granuloma. It could be some tumor. How to differentiate? There are certain sequences of MRI by means of which you can differentiate them all. What are those? See this. T2. First, I will take you to the most important T2 sequence. Here. This is T2 drive sequence, 3D. What you see here? Everywhere bright appearance. See that? All secretion, cholesteatoma, everything appear bright. Now, how can you differentiate whether it is cholesteatoma or granulation? Or could be cholesterol granuloma? How you can differentiate? At the same time, I will bring in, at the same level, another sequence. See this. T1 weighted. Now, if something which is hyper intense on T2 and which is hyper intense, suppose this is not hyper intense. If it is hyper intense on T1 also, then it is surely cholesterol granuloma. Got my point?
Yes.
If something is hyper intense on T1 and hyper intense on T2 also, it is cholesterol granuloma, which is not here. This is not hyper intense on T1 also. This is hyper intense on T2 only. See this? Now, if something is hyper intense on T2 and enhances on contrast, what will be that? Either inflammation or tumor. Tumor also, see this. Here, this is the contrast. Now see, it is hyper intense on T2 and hyper intense on contrast also, because the inflammation also takes some contrast because of high vascularity. But this rules out empyema. Had this been empyema secretion fluid, it will not enhance. I am showing how to do differential diagnosis on MRI.
Yes, yes.
Now, this could be hyperintense mucosa secretions, cholesteatoma, but the cholesteatoma will not enhance. Now see, that is important. At this point of time, you have to answer. See this. This is enhancing, this is secretion. This is the area of the cholesteatoma, what I mean to say here, which is not enhancing. Can you see this dark? Completely dark. That is not something which is not enhancing, that could be cholesteatoma. How can you differentiate 100%? Now I will bring in diffusion weighted. Diffusion weighted will make plus or minus everything clear, crystal clear. Let me bring in. Yes. See this. On diffusion weighted, the cholesteatoma will appear hyperintense. Can you see this? Can you see this?
Yes, yes.
This is the level where it is hyperintense, and that is cholesteatoma. See in this is the mastoid level. At the same level, whatever appearing hyperintense on diffusion is cholesteatoma, and if I get the diffusion coefficient, it will be dark, and that is classical of cholesteatoma. See, on diffusion weighted MRI, I am not going in here in detail. If you want, I can tell you this is cholesteatoma. Cholesteatoma is a cellularity. It gives restriction on diffusion. So on ADC mapping, it will appear dark, and that is characteristic of cholesteatoma. It will not enhance. It will have diffusion restriction. It will not be T1 hyperintense. It cannot be anything else than cholesteatoma. As simple as that. So by taking into consideration all these sequence, you can do a differential diagnosis of all possible lesions inside the temporal bone. That's why MRI is the choice for soft tissues. Bone, for the bones, CT scan is the investigation of choice. For soft tissues, MRI is the investigation of choice because of the versatility of the MRI, because of giving so many sequences. That is how you can diagnose. So before we move on to the case, any questions?
Perfect.
Very nice.
So we have already discussed the decision making, and in this patient we are biased towards interiorization for the reasons I told you, for the pneumatization of the temporal bone, for the status of the eustachian tube. Both are making me biased towards interiorization. Out of all these factors, two most important factors which are making me biased towards interiorization. I will do interiorization only now, finally, on the table decision, if I am able to preserve good amount of mucosa for the diffusion, gaseous diffusion. If I happen to remove all mucosa while removing the disease, there is no point in interiorization. Even if the eustachian tube is intact, even if you do intact canal, the air is coming through the eustachian tube, but no mucosa in the middle mastoid. Where will the gas exchange take place? That will lead to negative pressure, and that the whatever operation you do is going to be a certain failure. And then we blame the intact canal as a procedure is a bad procedure. It is not a bad procedure. If you are committing to the intact canal, you have to preserve the mucosa. So whatever gas coming to the eustachian tube will get exchanged at the mucosal level and keep the middle ear healthy. So, do we move on to the surgical part?
Yes, yes. People are waiting for that.
Subhirender sir, anything you want to add on?
Yes, absolutely. Very nice.
Very often we get cases with the necrotic cholesteatoma with the post-oral sinus or fistula, and with the foul smelling. Any different protocol for those cases? You go for any preoperative other investigation, culture sensitivity, and how you reconstruct everything that those cases. Do you do reconstruction of those cases because they have a very large cavity?
bigger, I mean the post-oral fistulas, extensive cholesteatomas and all that.
Yeah.
See, the final decision, there are certain things, extensive disease and all this makes you biased towards exteriorization.
Yeah, open camp.
But intraoperative is the final decision. If after the removal of the disease, if you find still the eustachian tube function looks nice, good middle ear, status of the middle ear mucosa is good, and you have left the ample of mucosa, you can reconstruct. Even if you have removed the canal destroyed earlier, whatever happened to the canal doesn't make any difference. The procedure is going to be interiorization. You can reconstruct it. There is hardly anything in reconstruction of the canal in any given situation, provided that your gaseous exchange should take place down the eustachian tube post-operatively, then only you reconstruct. Otherwise, do exteriorization. So all procedures will be exteriorization, except in the situation when eustachian tube function and a good mucosa warrants interiorization, otherwise all exteriorization. Now you choose, you assess in your practice how much you can interiorize, how much you can exteriorize. That depends. For every patient, decision is individualized.
Microscopic picture.
Doing it under general anesthesia or local anesthesia?
We do all ear surgeries under local anesthesia, regional anesthesia with sedation. Maybe it's a child or adult, all ear surgeries. All nasal surgeries under general anesthesia, irrespective of anything, because of the airway.
Yes.
And ear surgeries, when you do under local anesthesia, there is a distinct advantage.
Many.
I think Satish's take-home message is that each surgery should be customized to the individual situation, not necessarily because it's a large cholesteatoma or a huge cavity or what.
Yes.
Say, for example, you have a very large cavity, you have an extremely pneumatized tip. The idea would be then to remove the tip and obliterate that part. While simultaneously, if there is an extensive pneumatization of the petrous apex, you would kind of ventilate it down the eustachian tube. So you have both an obliteration and a reconstruction. But certain principles are always to be followed, that you should never have exposed bone. It has to always be covered. As we saw in the surgery last week on Thursday, that coverage of the bone is essential in all cases.
Yeah.
And another thing is that while we are doing the cholesteatoma surgery, what we generally recommend is hydraulic dissection of the epithelium of the
mucosa
matrix of the mucosa, for the simple reason that you want to preserve the mucosa.
That is the key thing.
Particularly because you want to aerate.
Entire decision of a exteriorization or interiorization depends upon the mucosa.
Because the entity of chronic middle ear fibrosis is an iatrogenic entity. It does not exist in nature. Chronic middle ear fibrosis, what we have all read about, is due to extensive scraping of the mucosa.
Yes.
And then trying to reconstruct.
Nice. So are you getting the picture?
Excellent.
So here I am going postural. Like I said in the, we did in the last case, facial palsy, our approach is same. We always raise the posterior, musculoperiosteal tissue based on the occipital artery inferiorly. Whether it is used or not, if it is used, well and good, like last time we used. If it is not used, we will replace it back.
very robust, and the vascularity comes from deep.
Yes.
So chance of injury to the pedicles is less.
Less.
Suppose we get a cholesteatoma with mestoid abscess, and you have to take out the mestoid abscess, then you will do the surgery in same sitting, or how much how much time you'll wait for the proper surgery?
No, same sitting.
Same sitting.
I don't know what Satish. Satish, what about you?
Last time we used.
Yeah, you can do same sitting. Why not?
Culture we should send for first we send culture sensitivity.
Yeah, of course.
See, when there is an abscess, anywhere is the abscess, culture you have to take, but the moment you remove the abscess, it's a great relief. Antibiotics will work only once they are able to penetrate. For any abscess you relieve.
In chronic ears disease, there are only two bugs that you have to be worried about. One is Pseudomonas, second one is staph, and that also MRSA staph.
Most dreaded is Pseudomonas.
Worst is Pseudomonas.
Dr. Vishal Arora from Surat, any experience of recurrent seroma after cavity obliteration in the roof of the obliterated cavity? How to manage that?
Yeah, you have to be careful before taking a decision of obliteration by means of excentrating all cells below it. If you leave the cells,
not 100% sure of every bit of mucosa and
don't
epithelium, then you should not obliterate.
See now, this is the regular one, or if you are operating for the eticoantral disease, I am undermining this to raise a little broader flap. All this musculoperiosteal tissue. In case required, if I do an exteriorization, this will be like diamond.
Yes.
This is a vascularized tissue
Center, please.
which I can use to line and partially obliterate my cavity.
Viren sir, can you hear me?
Yes.
Yes, sir. Dr. Rajan Bhargav from Kanpur.
Yes, boss.
His regards for you. And he's just asking, sir, ask me, you some presented, you have a publication on reconstruction resulted in the retraction pathology. So just comment on that.
Yeah, this is this is a study I had with one of my residents here. This is on long-term and short-term follow-up after cartilage reconstruction. So that is what we have highlighted. It is something which is not something very new, but we just studied it a little more scientifically. That's all.
What was the result, sir?
Result is there is a definite absorption in long-term. So unless you have crossed 2 years or 2.5 years, till that time you are not sure how much resorption will be there, but it's not very high. So it is still worth doing it.
Satish, can you centralize, please?
Yes, boss. Thank you.
Thank you.
See how much thick tissue.
A male patient?
Yeah, male patient. This tissue is so vital. Sometimes you get accessory, emissary veins and all that.
You can see the horizontal cut of the flap is way higher than the level of the external auditory canal. The idea is that you will need a long length to close it. So see how he's done that.
Yeah. If I don't use this, I will replace it back.
Absolutely.
Without any morbidity. Imagine at the end of the end of the exteriorization, if you need tissue, how vital it would be.
Wonderful. Is Dr. Asim sir and Dr. Satish, what is the experience of the post, you can say, cavity canal stenosis, or you can say metaplasty stenosis?
What is that?
Metaplasty stenosis after post-op after a few months.
Yeah,
What
so,
are the,
so what is the question?
what are the incidents of metaplasty stenosis in post-op cases?
Very, very low actually, because a couple of points that cause stenosis is that the reason you get stenosis, there's not adequate removal of the conchal cartilage. And the second part is that you've not stitched back the skin flap. So once you do these, then the chances of stenosis is less.
That's a very important point to remove at least a triangle of that cartilage. That makes a lot of difference.
Fluorospiral. That is the triangle also.
Metaplasty is one of the most important steps.
In fact, we can discuss a lot on this topic because with so many videos.
One of the most important, prominent cause of persistent discharging cavity or failure of the exteriorization process in an inadequate metaplasty.
And we have seen if you have a nice metaplasty, even your cavity shrinkage is maximum.
That is the.
That's the size dictum. The larger the cavity, the smaller the cavity.
Yeah.
See now how big the flap it is. Robust. The vascularity is coming from deep, and this is entire mastoid tissue, which I have elevated. Entire. See the full length of the flap. So in case I do a exteriorization, I need to bring this flap inside to line the cavity, and this is amazing flap. If not, I will resuture it. In case this need to be taken inside, I have to remove the mastoid tick to facilitate this going inside.
Yes.
That is the simple thing behind it. And since the vascularity to this flap comes from depth, occipital artery, say this, the pedicle of this flap is from the depth. So you cannot damage this. Even if I give extra length by means of, removing some superficial part to it, it can give extra length in case I need. The pedicle is coming from below. So that way it is a very, very safe flap, you can say. Isko suture kar de.
We can see exactly how big is the okay now.
Yes, see how big the flap is, and this is amazing flap. So now suture kar de. Suture. The moment I show you the condition of the middle ear, you will get to know the status of the Eustachian tube on your own. Suction look. Suction.
How we manage the post-operative cavity problems like granulosens, recurrent discharge, and suppose if it happens?
See, that will happen only if you leave raw areas or you leave the cells behind. You have to address the primary region behind it. Why it should happen? Once you have reconstructed the cavity, the most common cause is leaving the raw areas, inadequate cavity clearance. Cavity requires a lot of things, saucerization, exenteration of the cell. A canal down or mastectomy or exteriorization calls for a lot of efforts from the surgeon. Most of the reasons for the failure is the poor execution of the technique.
Two principles that need to be followed are that skin can only grow from skin and mucosa can only grow from mucosa. So if you are going to do a reconstruction and you don't leave adequate mucosa which can regenerate, that reconstruction is going to fail. Similarly, if you leave raw bare bone, that will be another problem for your mastoid cavity. Finally, one of the biggest problems that we see is excessive drilling without use of adequate irrigation will cause localized osteitis that causes recurrent infection and drainage. Of course, as Satish said, the proper saucerization, proper exenteration of all cells, so on and so forth, of course, that's a given, absolute given. And each and every bit of skin of the external auditory canal is pure gold.
Diamond, platinum.
Diamond, agreed. It cannot be sacrificed as far as possible.
So this is the exposure part and our flap.
Super.
Asim boss?
Yes, boss?
Can we discuss apart from otology, one word?
Yeah.
What is the use of using respirator mask with 3M with P100 filter apart from N95 mask in this COVID era?
P100 is very good. It's a P100 stands for 100% of particulate mass.
Yeah.
Therefore, you are clearing particles up to 2 microns.
Yes.
So, I mean, that's what I use, frankly.
During surgery or during OPD as well?
During OPD and surgery.
Okay. In OPD, it is a bit difficult because, it's difficult to converse.
That is true, especially when we're dealing with deaf patients and I'm having that as a problem.
Yes.
At the end of every OPD, I get laryngitis, that's for sure.
Yeah.
But safety first, my friend.
Yes, of course, sir.
One of our colleagues from AIMS had devised some kind of a microphone, which you can keep it under the mask and then that amplifies you. So that's especially for the clinic.
Sir, I tried using exactly what Satish is using to communicate with us today, and with a little portable amplifier outside, but somehow it didn't work too well.
Yeah.
Within 1 or 2 months, we will develop vocal cord module because we have
Give more work to Satish to take care of.
Hello.
Yes.
Yeah. So now I am going to show you the inside picture. Yes, I am.
focus.
Yeah. Can you see this is left ear?
Yes.
Yeah.
See in the attic? Can you see something?
Yeah,
Cholesteatoma.
Full of cholesteatoma.
Yeah.
Ideal case for the demonstration.
And see the mesotympanum.
Looks good.
Absolutely intact. See this?
No, when you saw the pneumatization of the mastoid, we come to the conclusion that the eustachian tube is good.
Yes. And that too, with this kind of aeration behind the tympanic membrane, that thing is over. Now, I am already biased towards interiorization for two reasons. One is the use-taken tube.
Yeah.
Another is pneumatization. So what to do? What I will do here in aortic cholesteatoma, our technique is, I'll tell you the simplest way. Let me, I'll make a central perforation out of it. My area of, what I mean to say, my area of interest is aortic above and probably the mastoid behind, okay?
Yeah.
I have nothing to do with the middle ear. Middle ear is good, pars tensa is good. So what I am doing, if I go anterior and posterior to this aortic perforation and elevate it, and elevate everything inferiorly, leaving the disease up, I can handle the disease much better. Let me tell you what I am trying to say. My canal incisions, my entire focus will be on the aortic and antrum and behind. So this is my inferior incision on the canal wall flap. And now, since I have to go anterior to the aortic perforation, see this aortic perforation?
Yeah.
And I am going anterior to it. See how I am in 5 minutes time going to make it this thing, central perforation. That is the simplest way of carrying out. Just a minute, you will understand. See this, the suture overhang.
The best way to preserve the skin.
Yes, I am keeping this skin away by and large.
Yes.
From my area of interest. See this prominent suture.
Yeah.
So prominent. I will drill away this later. That's a very interesting case. And here the onus is on mucosal preservation. In such a favorable situation, if I am not able to preserve the mucosa, will be a disaster. See this? This is the superior part of the flap I have elevated.
Yeah.
And similarly, inferiorly, where I made the incision. Cotton ball. See now, keeping this inside, I see this bone is, and this bone is impeding my access.
Yes.
Chota de. Yeah. Now I will give me the small burr. I will little bit reduce these overhangs to give you a better view inside. I have aortic perforation. I will go on both sides of this and make it as a central perforation and elevate along with the pars tensa. See. See, this is too much of overhang. This is tympanosquamous suture.
Yeah.
Yep.
Use. See how big it was. But it's a choti diamond. It compromised my access to the canal inside. This is such a clean-cut case. And next you will see what a case. See the suture line. Such a prominent suture. Unbelievable.
Yes, yes.
For everyone, once I am able to preserve the mucosa with favorable situation of Eustachian tube function, where I am committing towards the interiorization, even if I have to remove the canal partly to remove my disease, I will reconstruct it. Knife. See, now the canal has widened.
Yeah.
Earlier was not able to see inside properly. I hope the picture is good.
Yeah, quite clear.
इसको इधर करो.
Yeah, very good.
Focus. See now, this is my flap.
Yeah.
Better.
Better.
Now I will enter into the mesotympanum from either side of this perforation, aortic perforation. See this? What a simplest way. See, we know posteriorly the mesotympanum is good.
Yeah.
Are you sure there is no cholestotoma posteriorly? There may be cholestotoma.
See this cholestotoma. See this? So I will enter from the area where there is no cholestotoma. I want to enter in the pneumatized space at the middle ear. See this?
It may be filling more than what we thought.
See the middle ear space?
Yes.
There will always be some mucosal secretions there.
Yeah, glue.
Yeah. Perfect.
But
see what a clean middle ear cleft.
Yeah. That is glue, but here it is cholestotoma. See this?
Yes.
See this cholestotoma pocket?
Absolutely.
See that?
Yeah.
Yes.
Now I will go anterior to it, anterior to the margin of perforation, and enter into the middle ear, anterior to that.
Anterior mesotympanum.
Yes. Why so? I am segregating it, my area of interest. See here inferiorly, I have found this good middle ear space.
Yes.
And the middle ear mucosa, I have sucked little bit of the fluid. And see everything good, mucosa is good.
Yeah, healthy.
And I don't need to go anything beyond that because that is normal.
Yes.
I define my limit. Okay?
Yeah.
Similarly, I will define my limit anteriorly. And that is, see the annulus anterior superiorly. And I will enter into the sickle vena. Normal area. See this annulus?
Yeah.
See this annulus? And enter into this mucosa. See, anteriorly it's normal middle ear. Could you see?
Yes.
So anteriorly and posteriorly I have reached to the area of normal areas. You know, here and here. The whole problem is here in between. See this? Now this cholesteatoma, see this sac,
Yes.
see this sac of cholesteatoma.
Yes, yes.
Now I will remove this part of the bone here, this part of the bone here, to go to the medial side of the cholesteatoma. See, it's so clear. I can elevate this sac under vision. Once I remove this overhanging bone, I hope it is very clear there.
Yes.
If I remove this overhanging bone, I should be able to go behind the cholesteatoma and elevate it. See this?
Yes.
Because medial to that is no cholesteatoma. That is all middle ear.
Yeah.
This is the sac. See this?
Yes.
This chota cotton ball, chota cotton ball. So now I will drill away this part of the bone, patli drill, to exteriorize it. Chota. Drill. See this? This bone I will remove to uncover this cholesteatoma. एक साइड छोड़ forceps. See this part of the bone overhang I have removed, and let's see if I am able to elevate this. I hope the picture is good there, oriented.
Yeah.
I simply want to elevate this under vision. See this? All this is mucosa. See this? All this mucosa. Inflamed mucosa because of unaeration. Extensive. See the mesotympanum here. This part is intact. Now, having seen from both sides, see, I have reached here on this side and here on this side. Where is this is hanging? Where is the attachment? On the malleus. See this? See what I am trying to show? This is posteriorly. Hello?
Yeah.
I have seen my mesotympanum here absolutely normal.
Yes.
And similarly my mesotympanum there absolutely normal.
Yeah.
Yes.
Here is the handle of the malleus where this is attached to.
Yes.
What I want to do, I want to keep this inferior area away from my area of interest, so that I can deal with this superiorly where it is going behind. So I am cutting this. See this? This is like creating a central perforation here. You will understand once I cut this. Now see, the disease is left below in the aortic and behind. Can you see here?
Yes, yes.
Yeah.
See, it is left behind. This is all disease here. This is.
Yeah, yeah.
And what I have separated? This. See now, this is what? My tympanomeatal flap along with this central perforation. Can you see?
Yes.
Yes.
This I have elevated here. And I will push it there inferiorly because this is not to be at the end of the surgery. At the end of the surgery, when I happen to remove this disease completely. See this? See, I have to remove this disease. At the end of the surgery, I will reposit it. See this like this?
Yes.
And put a graft. See this?
Perfect.
This is central perforation. So I have elevated this normal area, segregated from the disease. And my now disease is localized here. This I have to deal properly now. Okay?
Yeah.
See, this is malleus, cholesteatoma, everything. And here in this pathology, we all know in the aortic cholesteatoma, I am not going to leave the malleus like this. Malleus is something you need to remove to see anterior to it. And anyway, even the handle, because I am not going to use it in osteoplasty at all.
So what is the status of stapes? Have you seen it?
Doesn't look like. I will show you. See now, my area of inferior area is separated from superior disease. Disease is here.
Yes.
Can you see very clear?
Yes, yes.
And below is a good mucosalized space. Can you see very clear?
Perfect.
And this area I have segregated, which I will reposit. And see this? So good.
Good.
Tympanomeatal flap.
This bleeding is because of excessive inflammation.
This looks like oval window with no ossicle. See this here. Anyway, I will look at it later, but it is good mucosalized area.
Yes.
See this? Now my target finally comes to the aortic here. This area of the cholesteatoma hidden behind this bone, now I have to remove that. Okay? Or this. I hope you are oriented.
Of course, yes.
That's what I have done. So what I have done, I have separated this area inferiorly, separated completely, and this disease is now focused superiorly. Segregated. So now entire target is to remove this disease and reconstruct. Okay?
Yes.
And see in the floor of the aortic, such a good mucosa. Absolutely healthy mucosa. See this?
Yes,
Now,
yes.
how to remove this disease? I don't know how posteriorly it is going. So now two ways. Either I keep removing this bone and come behind. That is known as inside out.
Yes.
Following the disease, I come behind. That is one way. Another is, in this way, I will end up damaging my canal wall. See this? Natural canal wall, I'll end up damaging. Second is, I don't know how posteriorly it is going right to the tip or not. So what I will do, I'll come from behind. I'll ascertain my posterior limit of cholesteatoma first, so that I can start removing it with preservation of the mucosa. That is the key. A lot of people do it inside out. You can do it inside out. Remove this. Then you remove this and then reconstruct this with the cartilage. But you don't reach behind the cholesteatoma, and before that you end up removing all the bone unnecessarily. So what I am going to do here, say this, what I am going to do is, let us ascertain how deep is the cholesteatoma, okay?
So would you like to remove some lower part of posterior canal wall, drill out?
Yeah, in case required, I will.
Yes.
I will reconstruct it. I won't mind removing the entire canal wall. I can reconstruct it. First, let's see how it is. I want to ascertain how deep this pocket is going. See this? A sort of unaeration. See this?
Very well mimetized.
I don't see any cholesteatoma here.
I think it is facial recess and it has.
I don't see any cholesteatoma here.
Yes.
See this? That is my tegment plate. See this? I am reaching towards the antrum.
Yes.
Yet don't see any cholesteatoma here. See this?
Yes.
See, I am going towards the editus. Now I am following it from behind. How deep the cholesteatoma is going. See this?
Yeah.
Still don't find.
No cholesteatoma in this antrum also.
So far, no cholesteatoma. See this? That means it is not extending far behind. It is limited in that portion of the atic.
Yes.
Retractor, additional retractor. Now I am going to that region of the cholesteatoma and unroof from above. Okay? See this, I will unroof from above. My canal wall is intact. एक साइड छोटी है. See the cholesteatoma coming in picture?
Yeah, just.
Bipolar. Now see the sac coming in picture.
So please centralize the picture.
See this sac coming in picture. Can you see the cholesteatoma sac?
Yes, yes. Very clear.
I will unroof from all around. See the cholesteatoma on both sides. What is there in between is the wall. Can you see very clear?
Yes.
I am not using a very robust cutting here as I am working close to the tegmen. I told you in order to remove the cholesteatoma, if at any point of time I need to remove the canal wall, I won't mind. Because we can reconstruct it easily. Only thing important here is removal of the cholesteatoma and preserving the bed mucosa. Mucosa in the bed. डाल पानी डालना यार छोटा दे दूसरी दे क्यूरेट This is all mucosa. Cholesteatoma down. And this is all the cholesteatoma now is going to come. See the cholesteatoma?
Yes, sir.
I will remove this part of the canal wall as I can reconstruct it later. So that will uncover everything. I'll have a same exposure like canal down.
Yes, sir. Sir, someone has asked about the anterior and posterior buttress. So
Yeah, so I am removing the canal.
yeah,
The
so you
end
can
will
show
be the
your the
buttress.
buttresses. So this is the buttress which is seen now. The
बड़ा है यार बड़ा दे दिया See, this is all cholesteatoma going. This is the sac. That is all cholesteatoma sac. See this?
yes, sir.
You can remove the canal wall to get the same feeling of same exposure of a canal down mastectomy.
Yes.
In terms of exposure.
So Dr. Girish Umredkar from Bhilai is asking management of iatrogenic CSF photoria by burr injury.
Yeah, like any CSF photoria, if it is iatrogenic, you have to seal it immediately. See the sac going behind.
Yes, sir.
See the sac going behind.
Yes, yes, sir.
See this entire wall. See this?
Yes, yes.
Use. Use.
So can you tell us something about the corner septum?
Corner septum is a persistent petrosquamous suture. See, this mastoid is formed by two bones.
Yes, sir.
The laterally is the squamous bone and medially the petrous bone. So if there is a persistent suture remains, when
Yes,
you
sir.
start drilling the mastoid, you'll find it looks like and a flat bone coming quite
Yes.
laterally.
Yes.
That can disorient you.
Yes.
See this cholesteatoma. I'm just increasing the exposure. I don't intend to remove it right now. I'm just improving the exposure. Huge, diffuse cholesteatoma, you know.
Yes, yes, sir.
वो बड़ी जल्दी देना थोड़ी. This canal wall, no issues. We can reconstruct. Can't
Yes.
compromise on the,
The
exposure.
pathology, disease, yes.
I think it will be going up to tip cells completely.
So, sir, usually you only follow the sac, or in all the cases you drill till the tip, or you only follow the
I
sac?
will follow it, yeah. Why? To remove unnecessary cells which are not involved.
Yes, so only follow the sac.
That will do in case we exteriorize.
Yes.
Then you have to exenterate everything.
Yes.
See? I'll keep going behind until I get the end of the sac.
Sac, yes, sir.
Okay.
I
That
think
is
this
good.
is the posterior.
Pardon? Side night. See this underlying mucosa which has become edematous?
Yes, sir. Yes. So you will remove those edematous mucosa?
No.
Okay.
Why? See this, my sac epithelium.
Yes.
There is one drug,
Hmm.
Mesna, if you have heard of.
Yes, sir.
That is very good in case wherever the cholesteatoma is, sticky, attached to the critical areas. You just pour the Mesna over there. It dissolves the disulfide bones in the cholesteatoma, and can be easily.
What exactly is this? Mesna?
Mesna is a chemical, sodium,
Okay, some kind of.
disulfide mercutoethane, something like that.
Okay.
Yeah, it is.
Sir, please send me the
Sodium.
pictures.
Yeah, see the.
It is. Yes, sir.
Because of the invasive epithelium.
Yes, sir. It is the sodium mercaptothenosulfonate.
Something like that.
Yes, sir. Yes. We have to apply it intraoperatively.
Just pour. If I pour it here, the cholesteatoma will be easily released.
Yes, sir. So, sir, I think in few articles that I've gone through, you have to dilute it with 80% of saline, 20% of.
It is now dilated available.
Okay, okay. So Dr. Nageshwar Rao from Vizag is asking, in your cholesteatoma series, what is the lowest age of the patient that you've operated?
4 years.
Oh, okay.
If you're talking of congenital,
see this cholesteatoma, I am elevating, see this.
Congenital
Yes,
cholesteatoma
sir,
you
yes,
can
sir.
have before that.
Sac, I am elevating.
The sac, yes, sir.
Yes.
Sickle. Leaving the mucosa behind, see this.
Yes, yes.
This one.
Yes, sir.
Yes, sir, you were saying something?
No, you said 4 years youngest. That acquired cholesteatoma fine, but you may have found some congenital cholesteatomas even earlier than that.
I have done at 1.5 also.
Yeah, so for
Congenital.
Yeah, congenital cholesteatoma.
yeah, it will be earlier age.
Yeah.
Ashim, boss.
Boss.
See the cholesteatoma, how it is.
Must.
So diffuse.
It's very diffuse, and that's very typical of these good eustachian tube functions.
Yes.
But you know, the advantage is that you are able to peel it off the perimatrix, leaving behind the mucosa.
Yes, that
So
is
therefore,
important.
this is a kind of case for reconstruction.
Yes.
All of this towards the tip, all the granulation Satish is removing, it's not really disease, it's just hypertrophic mucosa with some infection.
Reactionary.
Yeah, it's purely reactionary, it's not disease. So it will all settle down. The idea is, the caveat here is to resist the temptation to run the cotton wool out here.
That I don't want to.
That's exactly. So that's the point I want to
So you mean to say we should not?
No, because if you are reconstructing, you need the mucosa. As Satish earlier mentioned in his talk,
yes.
that unless you have good mucosa, there is no point in
Yes.
doing
Yes, sir, we can see the last bit of cholesteatoma. Yes.
See the sac being lifted?
Yeah.
Yes.
Leaving the mucosa below intact.
Yes, sir. Perfect.
Wonderful.
So when you do this inside out mastectomy,
we don't.
Why to?
But for limited, suppose some limited atic disease is there, then.
Yes, so when there is some limited cholesteatoma, why can't we do an inside out technique and just follow this remove like aticotomy or something?
Chondrometer is not a matter of a question of following the disease. The idea here is that once you reach the apex of the disease, what do? Then what happens in the deeper aspect? Most of us don't do MRIs. Often behind the matrix, you will have a huge amount of cholesterol granuloma in many cases.
You may miss the disease behind.
You will miss disease behind. And not only that, if you have a limited cavity, it is bound to discharge. Unless you follow the principles of cavity exentration. In which case, you are doing the full surgery any which ways.
Yes.
See,
whether you go from inside or outside, you are doing the full surgery any which ways. Then that's different.
Here I went behind the disease.
Yes.
Exactly.
Yes.
No question of leaving it behind.
Yes, sir.
Now I'll show you something under microscope, enlarging it about the mucosa. See what is preserved mucosa. You may not be appreciating what I have been doing.
No, it is evident.
Focus, sir, a little.
Can you see the mucosa below?
Yes.
That looks good.
Very clear.
See this is mucosa.
Yes.
Everywhere I am trying to lift this off the mucosa. That's it. Under higher magnification, this mucosa of the atic, middle ear and the antrum. This is key.
Medial wall of the attic.
Yes. Most important.
Very important.
Now, give me.
This is where it's going to go slow because there's a potential for facial dehiscence out there, right?
That is.
This is very important. Actually, many of us were of the view that these are the granulations and the unhealthy mucosa which has to be removed always. So this is an important point.
what I want to see this. अरे यार, कॉलेज कॉटन बोल दे. Oh. Cotton ball. डाल दे. See, you have to be careful. Using cutting, you may tear the flap.
Yes, sir. I have heard from Dr. Vijendra sir always that he used to always mention that Dr. Mahadevia sir used to always call it as a 24 karat gold, the tympanomeatal flap.
Obviously. Yes. See now. See, such an edematous mucosa.
Yes.
Yes.
Because of the ongoing inflammation. Oh, see this mucosa I don't want to remove. Lastly, patli dena, diamond.
So Dr. Ashim Kumar Banerjee from Kolkata is asking that we were discussing about this mesna. Is it toxic to the facial nerve?
No, it is very safe.
No. It's very safe.
Okay.
Facial nerve, ear, everywhere it is safe.
It's not ototoxic also.
Yeah.
Okay.
Boss,
yeah.
This is to ensure the last part.
Absolutely.
I have seen otherwise. I have removed.
Super.
I will tell you how to assess now. Primary goal is to remove the disease.
Yes.
Yes, go on.
Yes.
Forceps देना. Wash दे मेरे को. Forceps दे. Okay, now see what I am trying to say. This is my flap.
Yeah.
Yes, sir.
This is my central perforation.
Absolutely.
See this?
Yep.
Yes, sir.
Yeah. And I will reconstruct this with the canal wall. See this?
Yes.
Behind whatever the disease was.
Yes, sir.
See here. I have removed with this much of the defect. I have to reconstruct this canal wall only.
Right. But one more thing I would suggest is right at the level of the tensor, Satish, you can also think of considering a vertical piece of cartilage to prevent an anterosuperior retraction, which sometimes occurs when just the posterior canal is used.
Boss, if the aeration remains good, no retraction will take place.
Film डाल देना फिर.
If aeration is not good,
even the bone will get eroded. Right.
You put rock, not going to work.
Pathar will get eroded, no doubt.
Sir, here can you show us the area of sinus tympani?
Sinus tympani?
Yeah, in this case?
Yes. Yeah. That was only mucosa there. I will show you that sac I elevated from there.
Yes.
I am just washing away everything to show you. And I will reorient you with the anatomy.
Yes.
See here what I have ensured microscopically from starting from behind the disease that no cholesteatoma is remaining. See this? And this is the same exposure what you get with the canal down.
Yes.
Here. Okay?
Yep.
No cholesteatoma and ample of mucosa is left behind.
Yes.
See the floor of the attic completely intact. This is floor of the attic. See this?
Yes.
This is, that process, cochleariformic
Process is
process.
cochleariformis. Yes, sir.
Yeah. And
With tendon attached to
this
it.
is a tendon.
Hmm.
Yeah. See, this is absolutely intact, and I
Yes,
don't see any disease over there. Now, to show you the processes cochleariform sinus tympani region.
Hmm.
Boss, do you use auto endoscope to see sinus
Yes,
tympani?
that's what I was thinking. Exactly. Because I removed everything intact from there, and I think I should use the endoscope. To see the brilliant anatomy there, absolutely healthy mucosa. This is the stapes there. See, this is the processus cochleariformis.
Yes.
This is oval window.
Yes.
See this?
Yes, sir.
Yes.
And this is the facial canal covered by the mucosa. See this?
Mucosa.
Excellent.
Yes, sir.
Excellent.
Yes, sir.
I don't need to disturb. Everywhere it is intact. See that?
Yes.
The protocol is that for cholesteatoma surgery, autoendoscope is always kept ready.
Yes.
Yes, sir. Nowadays, because so any way to
for me
differentiate
now-
whether healthy mucosa or it's a granulation tissue, how can you differentiate on the just a sense?
Edematous and granulation has difference. Edematous mucosa and granulation has a lot of difference. Now see what I need to reconstruct, by and large. I have to reconstruct this wall,
Yes.
small area.
Yeah.
I have to reconstruct this perforation,
Yes.
and I have to reconstruct this hearing.
Hearing.
Yes.
From the only, foot plate.
Foot plate. Yes.
Okay?
Yes, sir.
I hope the things are clear.
Very clear.
Very nice.
Now I will show the anatomy with the endoscope. Louder.
Is this different from Bondi's mastectomy we used to do at that time?
Yeah, Bondi used to be done earlier, advocated for limited atic cholesteatoma with absolutely normal mesotympanum and intact chain.
Yes, yes.
And Rajiv boss,
Yes.
Bondis by definition means it is endoral approach.
I know some question was there, that's why I asked.
Now can you see?
Yes.
Hello?
Yes, sir.
See, this is all mucosa in the cells.
Yes.
Now perfect the mucosa is preserved. Beautiful.
Yes, yes. Healthy.
Yeah, this is sinus tympani.
Yes.
Can you show with the ball prop, boss?
Yeah. Ball prop.
Satish, you are using 3 millimeter autoendoscope or is the standard 4 millimeter?
Standard 4 millimeter, boss.
0 degree?
Yes. That's the area of the Eustachian tube.
Yeah.
That is the area of Eustachian tube.
Yes.
That is the middle ear, and behind is the, just a minute. That is the sinus tympani region. Here.
Yeah. Yes.
And see here it is oval window.
Yes.
Yes.
That is processus cochleariformis here.
Yes.
That is Eustachian tube. See
Eustachian
that?
tube. Yes, sir.
Yes.
And behind in the retrotympanum.
What do you feel? This the facial nerve is intact or it is dehiscent?
See now.
Just to confirm the CT findings.
The sinus tympani, everything intact behind.
Yes, sir.
See, good middle ear mucosa, Eustachian tube. Now I have to reconstruct this. Only stapes situation, number one. Reconstruct this canal wall. See this? And
Yes.
this is a small perforation. Three things.
Yes,
Now,
sir.
in order to reconstruct all these, I need cartilage and then fascia.
Dr. Salman asked me and Firoz Khan Saab, he's asking just the role of Mesna in detail, please. How you do, what is the use and
Mesna?
Yeah.
I think I should have used. See, I have a Mesna solution. It comes from the Cipla company. What you need to do is open that injection and pour in the middle ear and forget about 5 minutes. This breaks the disulfide bonds of the cholesteatoma. Circular. Now see my flap and all. Now for the osteoplasty, what I do, I will use a cartilage with a joint in it. Joint.
Yes.
Malleable assembly.
Yes, sir.
See, I'm raising the inferior flap.
Mm.
I will show you how I'll raise. And that is close to nature's malleable assembly. It cannot replace, but close to, at least it will not give complication. See, osteoplasty is something
Yes.
that requires a lot of things, and the most important, see the canal overhang.
Yes.
This patient has a huge canal overhang.
Yeah. Do we need to drill it?
Not really, boss.
Not really.
See the inferior annulus?
Yes, yes.
So I will use my cartilage with the, joint from the stapes to the inferior annulus.
Yes, sir.
Here. And for that, I will make a
Groove. Yes,
An
sir.
extra.
So, sir, while talking about this pediatric cholesteatoma, Dr. Nageshwar Rao from Vizag is asking, what exactly is the difference between a congenital cholesteatoma and pediatric cholesteatoma?
Congenital and acquired, the basic difference is congenital is behind the intact drum.
Yes.
Sometimes after the presentation it is difficult because both
Yes.
come in the young children.
Yes, sir.
But congenital is mostly anterior-superior,
Yes.
mostly. With the intact TM, no history of discharge and hearing loss. The patient present with hearing loss.
Yes, sir.
With no, Eustache and tube issues, no nasal issues, no discharge, anything.
Yes, sir.
And otherwise, pediatric cholesteatoma is mostly because of nasal issues.
Yes.
With multiple nasal problems, discharge and other things, the presentation is. So it's a clear-cut differentiation.
You see, mostly in the congenital cholesteatoma, the mastoid will be extremely well pneumatized.
Yes, sir.
The reason is that there is no reaction of inflammation because the body does not recognize the cholesteatoma as non-self.
Okay.
So this is due to, as they say, impregnation of epithelium in the fetal life.
Yes.
That's one of the theories put forward. And
Okay.
that continues to grow unhindered because the body, there is no reaction of inflammation segregating that part.
Okay.
So typically, as Satish very rightly said, it is anterior superior, and secondly, it can even be very, very invasive, go right all the way up to the tip also.
Okay.
And depending on how soon you pick it up. And as he said, there's no absolutely asymptomatic most of the times till they come with the hearing loss.
Okay. So this 1.5-year-old child that you operated, sir, Ashim Desai, sir, how did you diagnose this case to
They
be?
came with a mastoid abscess.
Okay. Okay, sir.
It had burst through. It had just
Okay.
expanded everything and burst through.
Now see how to reconstruct this canal.
Yes, sir.
I'm not placing a cartilage, tucking a cartilage from here to here, there. I am making the bed for the cartilage. Let me show you. Uday, diamond.
Is one Dr. Riaz Afridi from Pakistan.
Yes.
He's asking you, he has a bilateral tube functions are normal. Why he developed disease on left side? What could be the other pathophysiology in this case?
Oh, that you cannot explain. Nature.
See, sometimes what happens is that in these, this is a posterior superior cholesteatoma. That's right.
See now
So
what I'm doing, boss. One thing I want to show here.
Right.
See, I have to place a cartilage from here to there.
Yeah.
One can tuck a cartilage by all means, anything. I will make a bed of the cartilage so it will never mobilize. See this?
Yep.
I'm making a bed of the cartilage.
So where exactly you're making this?
Yeah, at the edge of the canal wall here.
Okay.
From where I have to reconstruct. See this. Okay, this bed. And when I place the cartilage coming from there, choti wali there. I will make sure that this cartilage doesn't slip out of the bed inferiorly. Got my point?
Yes.
So I will make it befitting. I will make like a normal canal, it will appear.
Now see, this maneuver would be almost impossible in an inside out.
Yes.
Impossible. Now I am reconstructing the canal.
Right.
Okay?
Yep.
See this groove is enough. This will prevent the slippage of the cartilage there. Okay?
Yeah.
वो देना बड़ी वाली वापस. As my cartilage will come from that side. And similarly a bed I will make on the other side.
Superior canal wall.
Yes. And then put a befitting cartilage. It will not slip from the bed.
First, thoda center, please.
Yes. See, this is the bed.
Yeah.
No. Yeah.
And this created a bar here, so cartilage will not slip. See this?
Yes.
Why I am creating so much of space so that my cartilage will not project.
Yes.
Satish, please zoom out and reorient it again because so many people are asking.
What?
Reorient again regarding where are you drilling and
Okay. See, that is the middle here. This is my tympanomeatal flap.
Yeah.
That is my tympanomeatal flap which I have to reconstruct. See this?
Yes.
That is the flap that is tympanic membrane.
Yeah.
And I have to reconstruct the cartilage from here to here. Okay? So here I have made a bed for the cartilage on this side. And then I will harvest the cartilage. And now I am making a bed on the other side. See this? Wait there. And this will make a good, body there. And see how befitting this cartilage is going to be.
Yes, sir.
Nice groove made.
And this will make the same canal, same circumference. Patla.
So Dr. Ravindra from Hubli is asking, is cholesteatoma always lined by sac? Now endoscopic ear surgeons are discussing about sac cholesteatoma and infiltrative cholesteatoma. What is your comment?
Infiltrative is, I don't know how this terminology they are using. This infiltrative is something like related to inflammation going on. Sometimes, like this was also looking like infiltrative. This is not a terminology. See now, the bad on this side and bad on this side.
Yep.
Now I will harvest cartilage and finally the graft. One cartilage for osteoclasty with a, joint in that, and other cartilage for reconstruction of the canal wall.
Yes,
And this will be done by my tragal cartilage. We prefer tragal cartilage because of its inherent, curvature. It is thin.
It's more flexible and both the sides perichondrium will be
Yes.
preserved.
Yes.
Both the sides.
Yeah, both the sides. As
Yeah.
far as possible, both the sides should be preserved for proper viability.
Okay.
Now, to answer your question, Paramita, regarding infiltrative, the correct word is invasive cholesteatoma.
Yes.
As we had earlier discussed 2 minutes ago, that invasive cholesteatoma occurs when the body does not recognize the epithelial ingrowth as non-self. So it goes through each and every air cell. It lines each and every air cell.
Yes.
Sometimes goes into the vitreous apex, sometimes the perilabyrinthine cells, and you have to really dig it from each and every part.
Yes.
So that kind of a cholesteatoma, I think, to do it endoscopically is a disaster.
Okay.
The only thing that you can put, the other type of cholesteatoma is the secondary acquired cholesteatomas, which generally occur due to a failure of aeration of some part of the isthmus tympani anticus or the isthmus tympani posticus. Sometimes, as Dr. Afridi was asking, why in this particular case this side occurred and not the opposite side, is sometimes because of the fact that some ears are very shallow. So what happens is when the promontory gets adhesive to the, say, to the tympanic membrane for a short period of time, say in teenagehood or late adult, early adulthood,
and now recovered to normal.
That is the beginning of the cholesteatoma at that time.
Now it has recovered.
Yeah, and that has recovered, absolutely. That recovered, that primary insult has long recovered.
Okay.
But that change in pattern of epithelial migration is what causes this kind of a cholesteatoma to develop. Do you agree, Satish?
Yes, yes.
So, sir, I have seen many giving eustachian tube wash intraoperatively.
Not in this case. How beautiful this eustachian tube is.
Yeah. So, but usually it should not be a regular practice in all the cases.
No, because you will traumatize the mucosa. Typically, in my practice, where I like to do a eustachian tube wash is when I see that area is filthy with granulations or there's an ingrowing of the epithelium into the eustachian tube orifice.
Okay.
That is when I would kind of consider giving it a wash. Or there is inflammation around the mouth of the eustachian tube, because sometimes I've seen a matchstick come out of there while I flush it, or a blob of inspissated pus, sometimes little fungal ball coming out of that. So all of that, but you can get a precursor knowledge of that by the fact that you will have some peritubal inflammation out there.
Yes. Okay.
Now, in this kind of a case, it would be wrong to sort of do anything to the eustachian tube. It's so perfect.
Yes.
Yeah, this is perfect.
Yeah.
Yes, sir.
This may have been weak at times, which has now recovered.
Yes.
Yes.
So here Dr. Sandeep Karmarkar has put in a nice point that there is a presence of structure called as Michael structure, which is present near the anterior-superior quadrant as an epidermoid structure. This presence is the commonest cause of congenital cholesteatoma, and hence it is common in the anterior-superior quadrant. Dr. Sandeep Karmarkar from Pune.
Yeah, that is potentially correct.
Yes.
So just
It's basically sequestered epithelium at the end of the day. That's all it is.
Right.
And they 100 years ago said very rightly, it's skin in the wrong place.
Yes.
See, I have harvested the cartilage here.
Yeah.
Not very good, but that is good enough for here, this purpose. For osteoclasty, I will harvest a different one.
Ashim?
Yes.
While we were discussing congenital cholesteatoma in Oman, we have got a good number of congenital cholesteatomas, and our observation has been that presence of OME is one of the initial presentations in these very small children.
Yeah.
And when someone does the myringotomy and he really does not find much fluid, or he actually sees the keratin inside, that is how a good number of them have presented. So this is for the residents, you know, your child is diagnosed as OME and you do myringotomy and you do not find much fluid against your expectations. One should think in terms of possibly underlying cholesteatoma, just anterior-superiorly where it has caused the eustachian tube blockage, and CT scan is a must in those cases.
Absolutely. Absolutely.
Good point, sir. Thank you for this.
Thank you. Thank you. That's a very good point. And
Yes.
I think each and every case, if the typical finding of fluid is not met, a scan is definitely a good idea.
Yes. Yes, sir. So can we use a
But you know,
concal?
sir, in these cases, I would consider, sorry to interrupt you, Paramita, but
Yes, sir.
in such cases, what we like to follow is the diffusion weighted MRI, because the scan may not differ in a congenital cholesteatoma kind of picture. The pneumatization is almost normal.
Yes.
So the CT scan does not really differentiate it, at least in my practice. So I would consider doing a diffusion weighted MRI for that.
Yes, this is also a very good point, sir. There have been few queries on this. So diffusion weighted MRI is something which we should consider.
Hello?
Yes,
Hello?
sir.
Yes, sir.
So I'm using this piece of cartilage here to reconstruct my canal. See here laterally?
Yes.
Yes.
See, I have to use a little bigger cartilage to, you know.
Get the curvature.
Yes.
And the spring. And the
yes.
Or Satish, if you can make this inferior groove slightly narrow and then, you know, little deeper, the same cartilage can fit in there.
Make a deeper groove, I think, that we can.
So, sir, Satish, sir, here comes a question from many to you. Why not concal cartilage? As we had discussed it in the previous case, but you can just...
Yeah, concal can be taken, but see here, you are able to preserve the perichondrium on both sides, number one. We have already mentioned. Scissors. We want a thinner cartilage, not a very thick one. The tragal is little thinner, and it has a natural curvature.
Another problem of concal cartilage is quite brittle. It's less flexible, and we are and it has irregular thickness in many a time.
Yes.
So now remember that the argument of thick cartilage, as Satish very rightly said, doesn't matter how thick the cartilage is. If the aeration is not there, it's going to fail.
Yeah.
Yes.
So thickness is not a criterion here. Here you are using this as a scaffolding to let mucosa and air into the mastoid, communicate freely with the mastoid and the middle ear.
Yes.
Just describe again the diffusion weighted MRI and diffusion coefficient. What is the difference?
Hello?
Sir. Yes, sir.
See now.
Asim, boss?
Yes, boss.
Just describe the difference between diffusion weighted MRI and diffusion coefficient.
So this diffusion weighted MRI, it will become brighter, diffusion coefficient will become darker.
Yes, sir. How it happens? Because they want to see, people want to, what is the difference between two? How they do it?
Satish, you want to take that?
What is the question?
Diffusion weighted MRI and diffusion coefficient.
Diffusion coefficient, that's what I mentioned, ADC values.
Yes, sir.
Coefficient is calculated, let me tell you, that's a calculation. That is called ADC values. In that, the tissues which have a, more cellularity will have less diffusion. Yes. Tissues which have more water content will have more diffusion. So when it is calculated by a software on the MRI,
In values, this is known as diffusion coefficient. See now, first of all, I will tell you. This is my tympanic membrane, which has come along with
wonderful.
My flap along with the tympanic membrane. This is the perforation, and this is my, see now, stable cartilage.
Now it is okay.
How stable.
Now this has a good aeration from underneath. See this.
Yes.
Yeah. Beautiful.
And good mucosa preserved in the atic floor everywhere. See that?
Yes. Yes, sir.
And it has a good height as well as to the normal cartilage where the normal wall was. See this height.
Yes, sir.
So it has to prevent, we have to prevent the meatomastoid fistula as well.
Yes.
So what I will do when we release this flap and place it back, I will cover additionally this area. So my skin of this canal, outside canal, will fall inside, not over it. If my skin falls behind, may lead to, it may grow inside and lead to meatomastoid fistula. So to prevent that,
Satish,
this height of this cartilage should be good. This height should be good. See how stable it is?
Yes.
Satish,
It is
in
little
this case,
extra size. Yes, Ashish?
in this case, obviously you don't need it, but should the stability be in question, is there a role for bone wax to on either side, like the soldering?
Bone wax?
Fix it?
Bone
not
wax?
bone wax. I mean the cement, the bone cement. Sorry, not bone wax.
Not really. See, cement cannot stick the cartilage. That is for bone.
Okay.
And Ashish, that area generally tends to granulate because it's avascular.
Yes.
Now see what we achieved. Number one, once I replace my flap back, see this flap back, I'll have a normal contour of the canal like before.
Yes.
Yes, sir.
And we have a complete cholesteatoma removal with ample of mucosa preservation. And now finally I will reconstruct with the cartilage from foot plate to the inferior annulus with a joint to give it a good hearing as well. And then we'll use a fascia to close the perforation.
And Dr. Salman Hashmi is asking how can we differentiate between infiltrative and erosive cholesteatoma?
Nature.
Just a clinical history, or you can say CT, I think we cannot.
CT will not show cholesteatoma.
Yes.
See, it is a definition for our convenience.
Yeah, just
that how invasive it is. Peter's bone cholesteatoma is what? Invasive cholesteatoma. Peter's bone cholesteatoma is what? Invading the various parts of the temporal bone. That is invasive, yes. Once it is, it is in the middle ear cleft only, it should not be called invasive.
Yes.
So now I will harvest because I have removed that cartilage.
Yes,
I will first place the ossiculoplastic cartilage.
Yes, sir.
I will graft the tympanic membrane and then finally place that cartilage in the place.
Yes,
I have done the rehearsal.
Yes,
Okay?
sir. So now this is a very important thing that we all need to know how you are carving the cartilage strut which has to be kept between the foot plate and the annulus, the inferior quadrant.
Yeah, see now here, I will take some cartilage. This is quite thick a cartilage.
Sir, one more important thing, Dr. Jivan Vedi from Nagpur, he's asking, for healing of mastoid cavity, it should be smooth. But here cells, there are quite depressions in the cells and they're irregular with edematous. How it will heal?
There is no cavity. There is no cavity.
Yeah, but this is actually, has been followed by many of us that it should be a smooth cavity.
Yeah, this is not cavity.
There is no cavity.
Yeah.
That's for canal down technique.
Yes, that's for canal wall down technique.
Yeah, this is
reconstruction.
We are leaving the cells behind.
In this, even if there are this irregularity, it will heal well, right?
See, it's no question of healing. It's going to be sealed off from the outside. It is going to be in communication with the eustachian tube. So there is not going to be any epithelium lining this.
See the kind of cartilage it is.
This ear canal is going to be indistinguishable from a normal ear canal at the end of this.
Paramita?
Yes, sir.
See, in open cavity, stratified squamous epithelium is there. The epithelial migration has to take place for its cleansing.
Yes.
So if there are irregularities or bumps there, then the epithelial migration is not smooth and you tend to collect keratin and recurrence of cholesteatoma. So therefore you need a smooth cavity.
See the kind of cartilage it is.
There it is a
So,
mucosa.
see, it's
Yes.
never a good cartilage.
So that is what Ashim sir was saying. It's always irregular. The
You see this?
cartilage. Yes.
I never like this cartilage for that reason.
Yeah, but sometimes you have the tragus has a small cleft in it that runs the length of the tragus. So you never get that necessary length. So you're forced to use this, unfortunately. That's what happened here.
See this cartilage?
Yeah.
It can never replace the tragal boss.
Yeah, that's true.
Then it may not be sufficient. So irregular a cartilage, so ill-shaped cartilage.
So, sir, some also believe in giving post-operatively nasal drops. So what is your say in it?
Nasal drops is good for some time.
Post-operatively.
Yeah, for the eustachian tube, decongestant.
Yes.
I give mucolytics. I give N-acetylcysteine.
Okay.
Especially in those intact canal wall procedures, I give nasal spray as well as not nasal drops actually, because then rhinitis medicamentosa thing will occur. But I'd like to give nasal spray immediately onset of autoinflation exercises. Valsalva should start immediately.
Immediately.
On day 2.
Okay.
Means 72 hours after surgery. Means third post-op day, Valsalva starts. Remember, there is going to be a reactionary exudate. That exudate is going to prevent the oxygen from reaching the air cells lining the mastoid cleft.
Okay.
The mucosa will have then a partial pressure of carbon dioxide increasing, and that will increase secretions. And that is why when they come to you in the immediate post-op period, maybe a month or so down, you will always, when you do a tympanogram, you'll see a flat curve.
Okay.
Why? Because in spite of good surgical technique and all, there is reactionary inflammation that causes reactionary exudate.
Okay.
So to minimize that, you need to give Valsalva immediately post-op, as well as N-acetylcysteine, as well as Disperzyme.
Okay.
I do all of this. Do you agree, Satish?
Yes, yes, absolutely.
Okay.
And acetylcysteine is a wonder drug.
It's a wonder drug, I'm telling you.
So you have taught us that, Ashim. There's no question of agreeing. We follow it.
Boss, how are you, boss?
Wonderful, wonderful.
Great.
We call it the Desai Otology School, the do's.
Yes.
Yeah. The do's and the don'ts.
You're too kind, Ashish.
No, I'm just honest.
So we missed the important part, sir. Satish, sir.
Yeah. I'm just measuring.
We saw that beautiful arch.
Yeah.
Beautiful arch.
Yes. So just.
It's very elegantly put and it's dipping into the oval window.
So you need to zoom in, Satish. We can't see the details. And your skin flap is coming in the way. Retract.
Yeah. So this is what I don't want. This is the. I'll take some good cartilage again.
It doesn't have enough strength, the bow?
It's not good.
Not enough curvature, I think.
Length, curvature, it's not all that good.
Yeah.
I want to give a good stiff assembly with a, a joint.
Stability, yeah.
Bringing effect.
The tragus is all, see his pinna overall is so swollen. The cartilage is never very good, but still we'll try to get some more. Only that.
So till then, we can also talk about the antibiotic protocol post-operatively.
See, most of these cases are going to be pseudomonas, right? So my protocol,
Pseudomonas?
mastoid is usually pseudomonas or staph.
Yes.
What about the diabetic? Suppose uncontrolled diabetic patient, what is the protocol? Suppose these cases.
Uncontrolled diabetic will have to have a proper gadolinium enhanced MRI preoperatively under any circumstance, because you could have a superadded malignant external otitis along with this.
Yes.
So no cholesteatoma is to be touched without a proper gadolinium enhanced MRI in an uncontrolled or even a poorly controlled diabetic, not necessarily uncontrolled. So generally the drug of choice, if there is a lot of pus, there would be culture sensitivity and according to sensitivity. Otherwise, routinely we give cefoperazone sulbactam for 48 hours and step down with cefpodoxime proxetil with clavulanate.
Okay.
Now, the second part of it is if we are suspecting staph infection, or if it comes staph, then linezolid is a drug of choice, along with a broad spectrum coverage for the first 48 hours.
Okay.
So, cefoperazone sulbactam injectable followed by linezolid.
Okay.
This is a preferred anti-staph agent.
Okay.
Linezolid for how long, Ashim?
5 to 10 days depending.
Okay.
Okay. So how long do you keep these patients admitted post-operatively for IV antibiotics? Or when can you start with the oral antibiotics?
48 hours. But I don't keep them admitted. Yeah, they go home the next day, they can take it by the local.
Ashim Desai charges by the hour in the hospital.
Arey boss. If fishes were horses, I would be on a Maybach like you, buddy.
Okay, folks, I'm going to take a break. I'll join you a little later.
Take care, bro.
So I'm just, find this cartilage to be better than before.
Okay, sir. Dr. Madhusudan Rao from Nandyal is asking, why can't you put an Ashoka pillar-like cartilage on the stapes foot plate?
Okay, 2-3 reasons for that. And Satish will definitely agree. Well, for that, one is that when you put an Ashoka pillar requires a base, and there is no base here. So there are chances of this getting tilted. The second thing is that because it's standing up like a tent pole, the fascia can drape around it and get adherent to the promontorium. That itself is not a problem. The problem occurs when that adhesion to the promontorium stops aeration to the round window. When aeration to the round window goes off, your hearing is going to go off. So you'll have excellent hearing for some time, then it's going to go away.
Okay. Okay.
That cannot work.
And the third, you see, this is going to literally, what Satish is doing is going to literally tent up the tympanic membrane up.
Membrane.
Yes.
So
the chance of anterosuperior retraction is not going to occur.
Yes.
See, this is good cartilage.
Yes. It's
See the difference in the previous and this cartilage.
Very sturdy now.
Yeah. I was not happy with that.
Yeah.
Any role
now see
of
the
giving
perichondrium on this side. Wash kar.
Yes,
see the perichondrium on this side.
Center it, please. Yes, perfect.
And any role of giving intraoperative steroid in your surgery? Steroid injection, I mean.
Typically, I give intra as well as post-op steroids in cholesteatoma surgery.
Betnesol.
Betamethasone, 1 milligram.
Intraoperatively.
TDS and then tapering. No. Intraoperatively, we'll give a proper course of dexamethasone.
See, Paramita, what I'm doing here.
Yes, sir.
Yeah.
This is my cartilage and see the thickness of the cartilage.
Lovely.
Yes. This is perfect.
Centralized.
Now, I will create a joint in this to make a malleable assembly. See,
God has not given us a columella. Anything, if I put a strut directly over it, anything you touch on the tympanic membrane can push the footplate inside. That's why God has given us a malleable assembly, incus, malleus, stapes. So even if you push the malleus down, the stapes is not going to be affected because there are a lot of joints. Okay? So here what I am going to do, I will judge the height required. I will take a little more height than the regular stapes. Can you see?
Yes,
sir.
And here I will make a partial cut. This height is little more than the height of the stapes, more than the height of the middle ear overall.
Yes.
See this? I am not going through the full thickness of the cartilage.
Yes.
See this? And this, I have not gone through the full thickness. There is enough elasticity maintained. And now what I will do.
So in this way, Satish is able to maintain the perpendicularity to the footplate.
Yes,
which
that
is
is important.
for sound transmission.
Yes.
He's also created a path of aeration to the round window.
What are the other options of Surbasti over here?
See now the advantage number one. First of all, it is our own tissue. No cost. Same area. The most important is we will maintain the middle ear space. More than that, this maintaining the middle ear space will not require any need of silastic or anything in the middle ear. See that?
It's an air containing cavity. Yes.
Now, see it is a vertical stud.
It is too big, I think.
It's too high.
No.
It is too high.
I need a little high. Little
Can
high.
you zoom in little, sir?
Yeah, and see the other end is going to go onto the depression which I created. See that? So what happens? See this movement. Because this is going to remain in the full length of the tympanic membrane in contact. See this?
Yeah.
And see this? This is kind of assembly. This is not in and out if you press from here. See if I press here, this is not in and out. In and out will be here. And this entire surface of the tympanic membrane will remain in contact with this cartilage. See this?
The efficiency is very good.
What?
It is not too high?
Little higher. Little higher. That is to maintain the middle ear space. See this? How stable it is because it is staying on the other end of the groove which I made. So first of all, for ossiculoplasty, it should be stable. It should be able to give adequate height to the middle ear.
Yes.
And secondly, it is a malleable assembly. See, even if I press hard, this will buckle. This will not allow the footplate to go in. See this? It is malleable. The biggest problem with the torp and porp is the rigidity. They can be sometimes dangerous. Their stability is in question all the time. See, it is how stable it is.
Very stable.
Yes, sir.
And this middle ear space which is maintained below this, this is a good space. This will maintain aeration. No need of silastic or anything to give adhesions. And now I will remove it. See this?
See, another problem of torp and porp is that since it's a very rigid assembly, remember that during healing that there is going to be some inward movement. The forces of fibrosis may cause a slight change in the relative position of the tympanic membrane to the torp or the porp. So if it lateralizes away, you're going to have this falling over there, it'll lose contact. If it medializes, there's even bigger disaster, it'll go straight through the footplate.
Footplate.
Yeah.
Pressure on the footplate.
There would be too much pressure on the footplate because it's totally rigid.
Yes.
Here it's flexible, so chances of that kind of a damage is not there.
So I have both the cartilage now with me. And now first of all, I will graft the tympanic membrane and then put both the cartilage. Okay?
Yeah.
Yes, sir.
So the cartilage I will place underneath later.
Yeah, first the graft.
Yeah.
So, sir, if suppose post-operatively the patient complains of giddiness, so
Complaints
do
of?
we giddiness?
Yeah.
What? Yeah. Hello.
Yeah.
Giddiness, yes.
Yeah, giddiness post-operatively. So, should we also think that maybe the pressure on the foot plate is too
Yes,
much because
that's
of the
why
strap?
that's why torp and porp are dangerous. Here,
So, even in this case, sir, even in this
even
case, have you
this
ever
case will never
experienced?
exert pressure, it will buckle. This is not a rigid strut. See, the horizontal part of the cartilage is in contact with the rest of the TM.
Yes.
So with the movement of the TM, this cartilage moves.
Yes.
And that gives a malleable assembly. It's a sort of, you know, it doesn't push in and out completely. Now this is my, see this?
Yes.
Graft, the fresh graft.
Yes.
I will place the graft first, then the ossicular cartilage and then the canal cartilage.
Yes. So, one more question, sir. Dr. Jeevan Vedi is asking, role of steroid-soaked gel foam on the edematous mucosa in the mastoid cavity?
Gel foam promotes fibrosis, so it should not be let to remain after the surgery is over. But yes, during surgery, certainly it can be used.
So, I've seen that some keep gel foams underneath the graft. So, is that required?
No, normally not. Normally not, because gel foam itself, like I said, is fibrinogenic. At the most, if you've done an underlay technique, then you don't have adequate adequate graft, or rather remnant anteriorly, then you can use one tiny piece of gel foam. Again,
to prevent.
To prevent it from falling in. But we do
in this patient,
so we never use gel foam, because another problem that we see in such cases is that when you're using gel foam, that itself will go and block the round window area.
Yes.
See, in this patient, I'll not need a bigger graft. There's a small perforation.
Yes.
Sir.
And we have to do an underlay grafting.
Yes, because there's a huge remnant.
Yes.
So in this case, underlay is the recommended thing. In this case, you don't do 360 degree.
There's no point. This was a perforation we made out of the atic perforation.
It was a planned perforation in the atic region. Anterior mesotymphanum is 100% normal.
Yes.
See this, just a small graft, nothing much. And now I'll place all the three things and we'll be through.
Okay.
All things are ready.
What do you do in mastoid cavity? You made a combined approach, or you can say temporary mastectomy. So you put some gel foam over there, or just leave it like that?
No, we don't put gel foam in the post-op period, because we don't want fibrinogen, and we want the air cells to aerate as fast as possible.
Most of the people put gel foam in the mastoid cavity afterward.
Yeah, but it doesn't help really. How does it help? It just creates a nidus for inflammation.
Yeah.
Welcome, sir. Dr. Morvani is online. Welcome. Good to have you on board.
Sir, good evening.
Very good evening to you, sir.
Sir, Dr. Sham Somani from Latur is asking, any role of acetic acid in the form of drops, intraoperative or post-operative in polycythemia?
Post-op is valuable.
Post-op is good.
Acetic acid, because of the acidic, nature, it prevents the growth of bacteria, particularly Pseudomonas and all. See, this simple underlay graft.
Yes, sir.
For my perforation.
Yes.
Any chance of fibrosis of this cartilage around the oval window in long term? And what the result you expect in these cases?
See, this is different, I tell you. Had this been an ossicle, the fixation could occur. Cartilage cannot get fixed with the bone.
There would be fibrous union which will not impede the sound transmission.
Yes. It will not be ankylosis.
Yes.
So this is my, the perforation closure?
Yes.
Yes.
Now I will put second thing my inner cartilage and then the canal cartilage. Ultimately what will achieve the normal functioning, middle ear. In the sense, ventilated middle ear down the Eustachian tube.
And ventilated mastoid.
Yes.
Yes, yes. And how much AB cap you expect after 3 months, 4 months in this case?
15 dB max.
Yes.
This is, you see why? Because there's a lot of perpendicularity.
Yes.
A lot of, see, the most important part for any ossicular assembly is perpendicular to the, it should be perpendicular to the foot plate.
Yes.
Whatever touches the foot plate should be perpendicular to it. So he's got literally 90 degrees to the foot plate. So that's going to work out brilliantly. The second important aspect for good ossiculoplasty is a air containing middle ear cleft. You can see that he's
the
given
stability.
Good,
Yes, sir.
excellent.
Yes, yes. Perfect.
Stability, middle ear aeration, perpendicularity. These are the hallmarks of a good ossiculoplasty, long-term functioning ossiculoplasty. We are talking of structural rigidity of titanium, so on and so forth. But please remember that there is, although cartilage is softer than titanium, the vibratory characteristics of any tissue is similar. So you will get a 10 to 15 dB airborne gap, just like a titanium, which much more safety, much more stability, and no risk of SN loss in the future. I will literally stick my neck out and say really no risk of SN loss.
Okay.
Give me some gel form. See, I am giving some additional height to it. I always use a little larger size than required.
Yes, because now another advantage of giving the little greater height is that during the healing process, the tissues, when they get pulled inwards, it will drape the cartilage better and give better vibratory characteristics.
Okay.
So any difference in concept, like suppose those are malignant diabetic cases or diabetic cases with the so much, will you go for reconstruction in those cases?
Absolutely. 100%.
Beauty of this assembly is the stability.
Yes, sir.
Diabetes will not change my approach. The aeration of the mastoid changes whether I give open or closed cavity.
Sir, here you are placing the gel foams first and then you will reconstruct the canal wall.
Yes.
Otherwise
so that it will not fall. Yes.
And then I will bring my flap to prevent meatomastoid fistula.
Yes.
So when you see from the canal side, you will have a normal cartilage.
Yes.
A normal canal, you know, in the sense.
Yeah.
Yes.
Your aeration is maintained through here.
Yes.
Yes. So, sir, please comment on the wet graft versus dry graft. Okay. Satish sir?
Yeah.
Please say us something about wet graft versus dry graft. Tell us something about it.
Neither I use wet graft nor dry graft. This is fresh graft.
Okay.
Best word is fresh graft.
It is absolutely fresh, so the maximum viability of the cells.
Okay.
Maintained.
What I believe, okay, what I believe, there is no question of controversy. This is not bad than a dry graft. Agreed?
I'm sorry?
This is not bad than a dry graft.
Not at all. Not at all.
Any publication about this technique? Somebody is asking.
Yes,
Have you published?
Yes, yes, we have published.
Yeah, okay.
Look at how beautifully this posterior canal is sitting. It literally is like a normal looking mesotemperum when you see it post-op.
Yes.
Maza aa gaya, boss.
The cholesteatoma was bad in this case, you know, so diffuse it was.
See, this case is worthy of you, my friend. No point in a tiny little disease and saying.
See now here, we have a stable canal You have a good aeration. This
Yes.
part is going to be aerated down the Eustachian tube.
Yeah.
And here we'll have a, see this flap. We have already placed the graft below.
Yes.
We have a ossicular cartilage below.
Satish?
Yes, sir.
I'll have to leave because, as I told you, it's a
Yeah,
working day here
yeah,
and I have
sir.
to go for my
Thank you
rounds.
so much for giving so much of
It was
time,
a
sir.
wonderful demonstration of surgery and I enjoyed the interaction.
Thank you, sir. Thank you so
Thank you,
much.
sir. Thank you.
Bye, Ashim, Rajiv.
Bye bye. It's a pleasure to have you on
Thank you,
board.
sir.
Thank you.
Thank you, sir.
Pleasure
We'll
is mine.
keep
Thank
bothering you, sir.
Sure, sure. It's my pleasure.
Now then.
Take care, sir.
See now, what I mean to say, I should not give a meatomastoid fistula.
Yes,
That is
sir.
important because when this skin goes, see this?
Yes.
Yes.
It should go there on the anterior side of the cartilage.
Absolutely.
So what you need to do, simple, prevention of this falling. Isko kholna. I'll do a simple trick. I will give a platform to this skin over here. So it will not fall back. It will stay on the platform. Find out. Find out. Very simple. There. This is a simple mistake which can give problem. See this.
Yes, yes.
See this. I will suture this
Zoom
over
out,
here.
Zoom out, please.
Yeah, it's a centralized.
Yes.
Yes, sir.
Yes.
See this. This is my cavity.
Yeah.
I will suture it quite anteriorly there and then here. So this cartilage, this skin, this will be the bed for the skin. See this like this.
Yes.
It cannot fall in the mastoid behind. Can you see?
Yes.
Suture.
Excellent, boss. And you are suturing the flap up so that it does not collapse into the cavity.
Yeah, this the external skin should not fall in the cavity.
And even the flap should not fall inside, so you are suturing the flap also.
And see this flap we didn't
Yeah.
use, so I'm suturing it back. As simple as that.
Excellent.
Those who are smokers, any comment for me? Any recommend? You asked them to stop it after this because of aeration issue.
Sorry?
Any instruction for the smokers after doing the surgery? I mean,
Smoking is bad.
Smoking, we always recommend that it should be avoided as far as possible. Having said that, if it's got a bad eustachian tube function, you know how I generally judge which case I will give open cavity and which case more or less a closed cavity. Two criteria. One is the size of the mastoid. One is if it's a very sclerotic mastoid, there's no problem giving an open cavity. And the second one is the condition of the mesotympanum and the eustachian tube. Now, how do I judge eustachian tube function? There is no real way of judging eustachian tube function except the fact that if there is a bubble of air on Valsalva in the anterior part of the in the anterior mesotympanum, then I will like to consider a closed procedure. But if there is the eardrum is sucked into the orifice of the eustachian tube, total middle ear atelectasis. In those cases, reconstruction is not going to be very, very useful.
See, this way it cannot fall down in the mastoid behind.
Mastoid cavity. Yes, sir.
Excellent, excellent.
Yes, sir.
This is perfect.
So maybe someday you can show us a canal wall down procedure where we would like to see the meatoplasty that you do, which is very, very important.
Yeah, whenever it is, our decision for that is intraoperative.
True.
Yes, and the obliteration that you do.
Yeah. Variety will definitely come. Now this will come. See this?
Yes, it's standing up. There is no problem.
It will not go anywhere.
Absolutely.
Suture kar dena. Now he'll suture for me.
Yes, sir.
Super boss. Maza aa gaya.
Yes, sir.
Not
Very nice.
that good.
So here's a question for Dr. Ashim Desai. Do you use double cartilage strut as Dr. Rabia Desai designed for such cases? Dr. Sanjay
Absolutely.
Gildial is asking.
Yeah. Sanjay, hi, how are you? Yes, of course, we do use the two cartilage technique. The second cartilage is in a little depression, and the first cartilage goes towards the anterior attic wall to prevent an anterior attic retraction. And of course, the posterior canal wall, so it becomes a three cartilage technique in this kind of a case.
Okay.
Yeah, two cartilage technique is required if you have a space. And this case also we could have done two cartilage.
Not required. You had a beautiful anterior mesotympanum.
Yes, superb.
So this was perfect.
Yes.
Miss, what's your protocol for post-operative thing? Sir, Miss, you give antibiotic for any injectable you give in these cases, such cases?
Satish or me?
You both. You.
Yeah. Post-op antibiotic, like I said, I'll give 3 days of 2 to 3 days of IV antibiotics, cefoperazone, sulbactam, and then shift over to step down to cefodoxime with clavulanate. And if I'm suspecting the staph, then I will give the linezolid. So Satish, do you differ in any way?
Yeah, it's all right.
Yeah.
And we recommend actually nasal drop also in all these cases because
nasal drops always.
Nasal spray, acetylcysteine.
Acetylcysteine always, nasal drops, and then after a few days nasal spray for few months.
Yes.
So Dr. Biplab Nath from Agartala is asking, will you keep any mastoid pack in this case?
Mastoid?
Pack.
We have closed the mastoid from the exterior, no question of a pack.
Pack. Where can we pack now? Nowhere.
Dr. Yosef Salah is asking, what about cartilage to oval window stability, contraction, and sometimes resorption? Is there have you observed this thing?
See, this cartilage is surrounded by perichondrium. It is supported on both ends. One end on the oval window with little extra height, and other end on the groove which I created. It is a very, very stable assembly and a malleable assembly as well, because the other end, after that joint I created, the entire length of the cartilage is in contact with the tympanic membrane. So with the tympanic membrane vibration, this mobility of this cartilage is given, that is malleable. Because as that other flange of the cartilage moves in and out, this cartilage moves. So it is like one cartilage up, and this is like, this is assembly. Like this. So this cartilage is in contact with the TM. So this cartilage is in contact with the TM and it moves. And that mobility is transferred to this cartilage. So this is very safe.
Okay.
For ossiculoplasty, it is safety, it is stability, and the aeration. If aeration is, whatever ossiculoplasty you do, it is going to be an utter failure. It cannot work.
Yes.
It is aeration which is important. So we could have done, anybody could have done, canal down for this, looking at the cholesteatoma. But what we have achieved is a normal canal. Our mastoid is aerated. We have a good space through which the aeration is going on underneath the cartilage. And we have ossicular assembly. But not at the cost of leaving the cholesteatoma behind. Removal of the cholesteatoma is the first priority. And after that, this was done. And see the floor of the aortic and everywhere, the mucosa was squeezed out. The mesotympanum was absolutely fantastic.
Yes. Yes, sir. It was a perfect demonstration, sir. It was really fantastic. Dr. Vinod Felix is saying, because of you, we are not enjoying the COVID era much more than the normal times.
Next case, what is that?
Yeah, so we have already started. And this case, I told you, the situation is very clear. Look at this here. Look at this here. What is the situation?
Screen.
It is a cavity with lot of cells remaining. See here. This is after 4 surgeries.
Wow.
See, there is a perforation, the irregular cavity, irregular ridge, and lot of cells. What you need to do now to excentrate all these cells, we'll do a, cul-de-sac closure. We'll remove
entire epithelium and mucosa from the entire cavity, from the canal, mesotympanum, and all the cells, all possible cells. Now see, where are the cells? This is the vestibule, these are the semicircular canals. All these cells along the tegmen, see the cells remaining? All these cells below the cochlea, see around the round window, this is round window. All the cells posterior and medial to the round window. Wherever this bad mucosa, cell, epithelium, whatever is left behind, see all this. Wherever there is, see number of cells left behind. In spite of so many operations, even the tegmen is not cleared of cells. So everywhere is the cells, see the facial nerve and the cells lateral to the facial nerve.
Yes, sir.
There are a lot of cells behind. So now the goal in this patient, he already has a profound loss. He has suffered 4 surgeries, discharging cavity. He is taking antibiotics for years. And what all we can give him? A dry ear. So now prerequisite is a dry ear. We have counseled him for the hearing. If he wants any time, we can do a cochlear implantation any time later on, because this possibility of cochlear implant remains intact even after subtotal petrosectomy and obliteration. We are not doing anything to the labyrinth. Now this surgery requires lot of work, bone work. In the sense, we have to exenterate all possible cell tracts. This is what I am going to show you. All perilabyrinthine, retrolabyrinthine, infralabyrinthine, pericarotid, peritubule. Those are most important cells which are left behind. And for the fear of injury to the carotid and going in that region, people tend to leave those cells behind. So we will remove all pericochlear, pericarotid, peritubule cells. And then obliterate the eustachian tube. I will drill away the entire bony eustachian tube, so there is no possibility of any cell remaining behind the eustachian tube.
Can you show us the eustachian tube on the axial view?
Yes. So, here is the eustachian tube orifice.
Yes, sir.
See, this is the carotid artery, horizontal carotid.
Yes, sir.
This is the tensor tympani tendon.
Yes.
That is the eustachian tube.
Yes.
And this is all cavity. He wants a dry ear now. He is fed up of antibiotics, and this is what we can give. This is a rescue procedure, ablative procedure, because now we are not leaving anything behind. Another procedure people used to do earlier was a radical mastectomy. This is something like that only. You exteriorize and leave behind for discharging. In this era, no patient wants discharge, and we have an option here. This is the ideal candidate for subtotal petrosectomy and obliteration for this purpose.
Okay, sir.
So the theme will be to exenterate each and every cell. We'll remove the mastoid tip, all peritegmen, perisinus, perilabyrinthine, retrolabyrinthine, retrofacial, then infralabyrinthine, then going anteriorly, pericochlear, pericarotid, peritubule. All those cell tracts will remove every bit of mucosa anywhere in the temporal bone we can see. All possible skin of the canal or anywhere, and do a blind sac closure by bringing the epithelium out. Since he has undergone multiple meatoplasties, so meatus is bad, so the blind sac closure is little difficult in this case. It's challenging.
Yes, sir.
As compared to the normal situation. So my associate has already started. We can take, we have 5 minutes time. We can take any questions or anything meantime. Ashim.
There's a question from Kanpur. Dr. Subhash Garg is asking, it is still if you can just enlighten us more about to assess the eustachian tube function intraoperatively, or can you just tell us more about it? Mm. 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 Okay, sir. Okay.
You
So
pack
Dr.
this. You pack.
Sham Somani from Latur is asking, any small drainage tube, will it help? Will it help in any way? Okay.
And how you pack the
Okay.
canal in these cases?
Hmm. 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 Okay. Hmm. 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 Oh, okay, sir. So Dr. Sandeep Amarkar is asking, has a conchomyoplasty already done in the previous surgeries? If yes, a cul-de-sac will be tricky, and that is the most important part of the success of the surgery.
Sir, this is Mahendra Varman. Sir, this is Mahendra Varman. Actually, if I'm on the audience side, I'm not able to hear you. Sir, yeah, yes. I mean, whatever the question Dr. Parmita asked, actually, we could not hear on the audience side.
Dinesh.
Yeah, on the audience side, it is not audible, sir.
Wait. Dinesh can.
Oh, yes. Oh, yes, sir. Even I got the messages now. Yes, sir. I think your audio was not at all audible of the previous question which I asked.
Yeah, last two questions we could not hear.
Yeah. No, sir. No one could hear you.
सतीश की आवाज नहीं आ रही.
Sir, in this group, you are audible. Sir, in this group, in our group, it is audible. But in the audience side,
can you hear me?
it is not audible. Yeah, I can hear you. And I'll just go and check in the audience side also now.
सर आवाज आ रही है?
हेलो, मेरी आवाज नहीं जा रही उधर.
आ रही है सर, आ रही है. We can hear you. We can hear you.
People are complaining that they are not able to hear my voice.
Sir, now we can hear you.
Coming, sir.
Now we can hear you.
Now it is
Okay,
coming?
sir. Yes, sir.
Yes,
It's
sir.
coming. So now, sir, again, you can just tell us about the preoperative assessment of the eustachian tube function, which you said.
Pre-operative you can assess in cholesteatomas or in this mastoid surgery. The best way to ascertain is if you have an air pocket in the middle ear close to eustachian tube. You can assume that the eustachian tube is functioning and providing air. That is the only function you can get to know by this clinical assessment. In perforated ear, otherwise you can do Toynbee and Williams test, as I mentioned last time during interlate tympanoplasty, by creating the positive pressure with the manometer by putting the tympanometry probe, and then you ask the patient to swallow, and the pressure, if it decreases coming to normal, that means your eustachian tube is working. But here in mastoid, like in this case with the intact drum, such a good air behind the intact drum itself is a good sign that the patient has a good eustachian tube function.
Eustachian tube function.
Had this been in place of this, been a plaster drum or something like that, we would assume that the eustachian tube still is not functioning. And secondly, many a times in atic cholesteatoma, it is a selective atic or epitympanic dysventilation syndrome, wherein the eustachian tube function is normal, but the aeration of the atic is blocked. Because from the mesotympanum to atic as an aeration through the anterior and posterior tympanic isthmus If that is blocked, the resultant retraction can, see this Prusak space is in the lower compartment of the aortic as compared to the upper compartment. Any resultant negative pressure in the aortic can lead to retract the epithelium inward, and this further collection of the epithelium debris can lead to cholesteatoma. So many times with the absolutely normal functioning eustachian tube, this is selective epitympanic dysventilation syndrome. And again the resultant thing is same, the cholesteatoma.
Okay, sir.
And this patient could be end result of that only, because this eustachian tube looks absolutely normal.
Normal. Yes, sir.
Well, this case,
Yes,
case had step is intact, but cholesteatoma in between crura. And would you, in that case, if you're not able to take out the cholesteatoma, then what could have been option?
I would use laser to divide the crura and bring out the cholesteatoma. That is the role of laser in the normal mobile foot plate.
Yes, go ahead.
In a normal mobile foot plate with cholesteatoma in between the crura, you cannot afford to mobilize a foot plate while removing the cholesteatoma, because it is thin epithelium, sometimes sticky, and sometimes it comes out as a whole pearl if you vaporize the crura, and then one you can easily remove. So in a mobile foot plate, the laser is of utmost use, most useful.
So now in this case, which will operate, the other side also on the CT scan, we saw there is soft tissue there. So what is the hearing status of the other?
That other side has a secretory otitis media.
Okay. Okay.
Dr. Joseph Salah is asking, can the tympanomastoid suture used as a guide for the face inner in recurrent cases?
Yes, this is one of the landmark, but this is a poor landmark. For facial now, the best landmark if you are doing mastectomy is a digastric ridge for the vertical segment, your incus for the genu and the tympanic segment, your processus cochleariformis for the tympanic segment. There are many more better landmarks than tympanomastoid suture. And in revision situation, you will not find the suture, because already some surgery has been done and you will not find the normal anatomy. But this processus cochleariformis, lateral canal, digastric ridge, they are constant landmarks.
Okay. So, sir, in such cases, in the same sitting, can you get a grommet inserted on the other ear?
Yes, yes. Already placed.
It's already placed. Okay, okay, sir. Sir, Dr. Abha from Delhi has a question. With one normal hearing ear, cochlear implant in deaf ear, will patient tolerate the different quality sounds?
Yes, that's how that is the basis of a, implantation in single-sided deafness.
Yes.
And mostly the indications are better if the patient has a tinnitus along with, because then the role of the implant becomes much better. Otherwise, most of the patients, do not get this done in the single-sided deafness, because though it is being done at many of the centers, but the patients who have the acoustic hearing in one ear, and what this cochlear implant is giving an electrical hearing. This electrical hearing doesn't have that dynamic range as compared to the acoustic hearing. So majority of the centers who are doing this single-sided deafness, if they have a lower frequency available, they do electroacoustic stimulation, and that is much better tolerated, much better appreciated rather than a plain electrical hearing. But yes, it is a best answer as compared to the Baha and all those things. Because this can treat the disease, Baha is not treating the disease.
Yes, sir.
There are so many questions regarding metaplasty that next week we have a radical mastoid case.
We'll show metaplasty.
That we show you the step, video and the steps, all the things.
Sir, Nitishore, who's been your student, has a question that a situation where the cholesteatoma in a contracted mastoid with exposure of posterior fossa dura and tegmen eroded. Above that, eustachian tube is congenitally bony blocked. How should we proceed? Is there any role of cul-de-sac closure?
Ablation, subtotal petrosectomy and blind sac closure. Now you can't reconstruct the hearing. to prevent problems forever now, ablate.
Okay.
While doing implants, suppose you damage cochlear duct, aqueduct, or you just go medially. Suppose the duct get damaged or somewhere that vein get bleeding, damage, then how you do manage at that time?
Yeah. Inferior cochlear vein damage, you mean to say? It has a negative impact because it drains the main vein draining the venous blood from the modulus as well.
Yes.
So it can lead to degeneration of fibers, spinal ganglion fibers in the modulus. There are not so many reports, so it may have been damaged by people. But see, we have such a huge dynamic range for the implant regarding the spinal ganglion fibers. Out of 36,000, even if you have 10,000, even if you have 5,000, the implant will work. So it is not going to give any appreciable difference, I think.
Okay. Okay, sir. So we can move ahead with the next case.
Yes, sir. Yeah. Let's go ahead. Kadri?
Do you have experience with TORP and PORP, Asim sir? Asim boss?
Is not there. Right
He's not
now.
there.
Yeah. So what is the next case series that we are having for Chori sir on Thursday?
Thursday we have a lateral skull base day.
Okay.
We'll be having caustic neuroma. We'll be having a glomus jugular.
Okay.
And one basic case also.
If time permits. Because caustic is a bigger case than glomus.
Hello?
Glomus jugular we have seen earlier. So we'll go ahead with straight away.
Okay. Dr. Nageshwar Rao is asking, in MRI, when is no cochlear nerve intact, what is the solution to get hearing?
On MRI, no cochlear nerve intact.
Yeah.
MRI, absent cochlear nerve, then there is no role of cochlear implant. If you are so sure that there is no cochlear nerve, if you have a doubt about a thin cochlear nerve or something, then is a different situation. Then you have to do further workup to get to know that implant is useful or not. In a thin hypoplastic cochlear nerve, still there are tests to know the implant is useful or not. And like Krishna sir said in the afternoon, the best is, see, like eBera, when you stimulate the promontory and get brainstem responses, that means the cochlear nerve is functioning. Similarly, the best clinical test is aided audiometry. If on aided audiometry you get responses in the hearing frequencies like 1K or so, that is a good sign that patient should be implanted. Because in the thin cochlear now, there may not be a full stimulation of the full benefit of the cochlear implant you may see, but still it is better than the best result of ABI. That is the advantage of the cochlear implantation. ABI is not going to give anything except auditory sensation. And that is too much a complicated procedure as an intracranial procedure.
Okay.
Now see,
Okay,
being the last case, the case was already opened, and see the myotoplasty is already done. Just to show you. The cul-de-sac, not myotoplasty.
Cul-de-sac. Yes, sir. The cul-de-sac.
See what you have done? Here, see this is the second layer. This is the second layer. And the cartilage, the canal skin is taken outside as a primary layer. Okay? Just to save time. There are so many occasions that we'll be showing cul-de-sac closure.
Cul-de-sac closure, yes, sir.
On Thursday also we have a case where we'll show cul-de-sac closure.
Yes, sir.
In the glomus, See now, so that we can focus better on the surgical aspect.
Yes, sir.
By and large, the canal was taken out, and this is the second layer of the soft tissue, which is reinforcing the cul-de-sac closure. Okay?
Yes, sir.
Now see the quality of the mastoid cavity after 4 surgeries. See this? Lot of overhang. Has already profound loss. No, go the bullet. Bullet. Yeah. Now you have to remove each and every piece of mucosa and epithelium. See this?
Yes, sir.
See, no suturization was done. Let's see what are the mistakes done by the previous surgeon.
Yes, that is
Once you do a canal down mastectomy, I told this should be properly executed. No suturization was done. Number 1.
Yes, sir.
See the perforation. Incomplete exentration of the cells. See this, how big a cavity it is.
Yes, sir.
All hidden areas. See high facial ridge, can you see?
Yes, sir.
The option for this patient we had was to revise the canal down, number 1. Which this patient has already undergone 4 times and he didn't want to. See the burr I am using is a very robust burr. Touch, touch. So more, forcibly. What's up? Yeah. So most of the work is drilling in certain critical areas. Now once you are doing a subtotal petrojectomy, you are not supposed to leave any trace of mucosa or skin.
Yes, sir. That is important. So Dr. Sandeep Karmarkar is asking, what is your approach in attic cholesteatoma with intact pars tensa, with intact ossicular chain? Any special technique would you like to tell?
Approach for intact ossicular chain?
With an attic cholesteatoma with intact pars tensa with intact ossicular chain.
Bondies.
Bondies, yes, sir.
See the cholesteatoma, see this.
Yes, sir.
See where it is hidden. This area is not exteriorized. See this completely. This will require a lot of work. These are bad cases. And now the treatment they require is a final one. This is the outer cortex work, crude work. So I am doing faster. इसको क्लीन करना नीचे से. क्लीन कर. See this mucosa. Hello? Hello? Hello, am I audible?
Hello, yes, sir, you're audible, sir.
See the mucosa cells.
Yes, yes.
All these
yes.
pockets discharging.
Yes.
I told you this will require huge bone work.
Yes, sir. Sir, while you're doing this bone work, if you can just tell us how will you manage a chronic tinnitus case? Dr. Kantilal Desarda from Pune.
Chronic?
Tinnitus.
Tinnitus?
What is your treatment for this?
Tinnitus is most difficult. And you know, we have a separate neuro-otology department for that. And they do a lot of tinnitus, retraining therapy and all that.
Okay.
We get imaging workup also done. And some of the patients we could find the cause.
Okay.
Treatable cause. Sometimes, like we have seen the sigmoid sinus diverticula giving tinnitus. We repair the diverticuli stop.
Okay.
Where the vascular loop in the CP angle repaired. So sometimes repaired. Many a time anxiety and other psychological aspect associated. Many a time they give hearing aid, noise generator, so many things. It's a complex problem. Can you see the sigmoid sinus?
Yes, very clearly.
What I was doing is a peri-sinus drilling. इसको clean कर दे.
Yes.
See, all these are the cells which have been discharging. This guy is taking antibiotics. What would antibiotic do?
Yes.
All this is, you know, osteitis, repeatedly discharging bone, become osteitic.
Yes, sir.
This is a very good burr, you know,
Yes.
for saucerization
Yes.
and faster bone work. This is very safe as well.
So Dr. Shailesh Pandey from Mumbai is asking, due to COVID and pre-op investigation, what tests you advise? You've said this already in the previous webinars. If you can just repeat it today.
Yeah, besides the RT-PCR, you mean to ask same?
Yes.
In suspected, in some patients, physician takes a call. Sometimes they get HRCT done. Sometimes they get a lot of other tests like ferritin, D-dimer, interleukin.
Okay.
क्या हुआ? दूसरी दे दे. See, all this is infected osteitic bone due to chronic discharge.
Yes, sir. So these are all granulations.
Yeah, this is now the bony plates limits. All air cells have gone from this region. See this?
Yes, sir.
No air cell remaining. I will not
If it is a
leave.
revision case, what precaution you will take while drilling everything in this area, like facial ridge area, facial area, or like that?
All regions to failure. All regions to failure in this case. Incomplete saucerization of the cavity, incomplete exentration of the cells, then incomplete lowering the facial ridge, perforation, then inadequate myotoplasty. Every region was there in this.
So Dr. Sandeep Karmarkar is asking, what will you use to obliterate the cavity in this case, abdominal fat or local muscle?
Fat from the thigh, always fat. The reason is, we have to follow these patients periodically with the scanning, you know.
Yes, sir.
So in case you suspect sometime cholesterol or something, or you have to follow it, obliteration with the fat touch karna is always better, because it gives you background to pick up the cholesterol or any disease for that matter underneath the obliteration coming up.
Yes, sir.
Because in MRI you can get a fat suppressed image. If suppose you obliterate with muscle or something, muscle because of the contracture, fibrosis, you know, on scanning variably enhances.
Yes, sir.
And then it is difficult to differentiate from a recurrent disease or a muscle. See how much of the work is required.
Yes, yes, yes.
All bad. Touch. मेरे को दे bipolar. See the tagman.
How will you calculate the height of facial ridge in revision cases?
Height of?
Facial ridge.
I will go right to the facial now.
Because already everything is destroyed.
Yeah, I will go to the facial now. Oi, clean karna.
Any other option than cul-de-sac closure in this case? Any other way you can, because even right now you can manage with the radical mastoid, because.
So again, either revise the same thing.
But since it is nothing been done, it looks nothing been done in this case. It looks that nothing been done in past, because no principle been followed. Suppose you do a radical cavity now and obliterate with the muscle flap, flap, etc.
See, the patient who has been operated 4 times, fed up with the surgical treatment, now he is only wanting a certainty of the dry ear. His hearing is gone. Had there been a, good hearing.
Suppose this case of moderate to severe hearing,
then would have been a different situation.
Yes, sir.
Hearing is the main point.
See, all these regions to discharge. All this skin I am removing. All this mucosa, skin, everything has to go. See the facial now.
Yeah, great.
Monopolar. I will take away the tip cells as well. There are so many groups of cells, This is a huge marathon case. वही दे बार. See, this is mastoid tip.
Yes, sir.
I don't want to leave any possibility of epithelium or mucosa anywhere in the cavity. Once this surgery is done, you will get to know what subtotal petrojectomy is.
What is the extent of bone drilling in this spectrectomy? What extent up to you feel?
Extent of
bone removal in this spectroscopy.
All wherever the cellulite is. I will track the entire cellulite. And the CT scan was our guide.
Yes, yes.
And now here,
Yep.
this is the mastoid tip area.
Mastoid
Yes,
tip
sir.
cells. Yes, sir. Yes, sir.
This is sinus, perisinus area.
I remember you had told in once in conference that you had operated a case which was 9 times operated before. Which is what is the maximum number?
Operated for what?
You had done a case, a revision case, which was 9 times operated before.
For ear.
Yes, sir.
Ear.
Yes,
Ear.
yes, for cholesteatoma.
Cholesteatoma 7th revision.
Oh, 7th revision.
And
Okay.
that I demonstrated in Germany,
Yes, yes, yes.
not in India.
Okay.
Sinus, I have operated a revision who had undergone more than 20 surgeries.
Okay.
See now the tip which is broken?
Yes, yes.
Yes.
Yes. This is how you can get rid of this.
So Dr. Sandeep Karmakar is asking that since you are tackling the tip, can you please explain the concept of sink trap effect and the need to remove the tip in certain cases?
Concept of what?
Sink trap effect.
Sink trap effect, like it is going to pull in all the muscles.
Yes.
Yes, yes.
And the
So,
need,
yeah,
that is
what
how we
he's
have to
trying to
remove the
say,
tip.
removing the mastoid tip doesn't increase the size of the cavity.
Yes.
In fact, it block in reduce it.
Yes. So what about in cases of severe adhesive in an atelectic ear? When will you operate?
See, atelectic ears are most difficult to reconstruct and their survival depends, the success depends upon the Eustachian and tube function.
Yes.
Those are the most difficult conditions,
Yes.
to ensure success.
Yes. So do you do a middle? Do you do an ossiculoplasty in these cases?
Yeah.
Okay.
But guarded prognosis,
Okay.
but drill there. 2, 3. See, I am reaching the level of the facial canal.
Yes.
Yeah, yeah.
Dr. Karthik Parelkar from Mumbai is asking, what is the fate of mucosa in the deepest part of the petrous apex, if that is left behind in a subtotal petrous section?
What mucosa?
What is the fate of mucosa in the deepest part of the petrous apex?
Most difficult part.
So that's what you have to see on CT scan. If there is, you have to go there. Petrous apex, I'll tell you the way to reach.
Yes, sir.
If it is pneumatized, you remember the previous glomus case we reached to the petrous
Yes.
apex?
Yes, yes.
And probably this glomus also will go there.
Okay.
Peter's apex is not unresectable. Peter's apex is, the infracochlear route is a direct route to Peter's apex.
Yes.
And Miss revision radical cases, revision mastoid cases, how much you get a newborn formation? Yes.
Yeah, newborn formation is a phenomena, happens very commonly. Because of osteitis, neo-osteogenesis. See the level of the facial now?
Almost.
Yes.
I am at the level of the facial now. See my facial ridge.
Yes.
Yes, yes.
See what we have achieved by now. See the tegment plate. See the sinus and the perisinus region. See the mastoid tip. And now, now I am in the perilabyrinthine region and then we'll go to middle ear. All this mucosa in the middle ear and all. See, I will coagulate and remove this. Everything. The coagulation makes the mucosa non-functioning.
Yeah.
Yes, yes.
Best tool for the if you cannot take out the mucosa from deep.
Yeah. Now see, this is towards the hypotympanum.
Yes, sir.
Here we saw on CT scan there was no retrofacial pneumatization.
Yes.
Otherwise, had there been retrofacial pneumatization, I would go here. What is retrofacial space? The space between the facial nerve laterally and the jugular bulb medially.
Medial. Yes, sir.
And the superior limit is the posterior semicircular canal.
Yes,
if that space is pneumatized, I would excentrate that and go below the facial nerve anteriorly into the middle ear.
Yes, sir.
See why it is called ablation. You are taking away everything.
Yes.
Cutting there. Cutting there. नहीं थोड़ा बड़ा देता ना बड़ी दे चल all this is bad osteotic bone.
Very bad, very bad.
Yes.
Bipolar. See, here is my facial now here.
Yes.
See this below? And
Yes,
this
sir.
is the all bad mucosa. Here is the tensor tympani muscle. Side circular. Side knife. See all this bad mucosa out. And see here, this is facial now, very clear?
Yes, sir. Yes,
Yeah.
sir.
And below, that is tensor tympani canal. See this? Out.
Yes, sir.
See this? All muscle, tensor tympani muscle.
Yes, sir. Very clearly see.
Yeah. This is one of the very common procedure we do. Bipolar. Forceps. Diamond, the medium size. Now see in the attic, lot of cells.
Yes.
This is supralabyrinthine region. And above the tegmen. See, this is facial now. This is processes cochleariformis and taking away. I will define the carotid canal. I will define the jugular bulb. That is carotid canal. Can you see?
Yes, yes.
See that carotid canal? There.
Yeah, we can see. Blue circuit.
Side knife. Side and then sickle. Side.
You cut tensile tympani before obliterating the tube?
Pardon?
Please cut. You cut the tensile tympani, na, full?
Yeah, to get a good clearance from the Eustachian tube.
Yeah.
Yes, sir. Yes.
I will widen the Eustachian tube to clear it thoroughly.
Yes, sir.
See, these are infracochlear cells here.
Yes.
This is cochlea, that is carotid artery, this is cochlea, and this is jugular bulb.
I
see this.
Yes, sir.
See all the structures.
Sir, Sandeep Yes, sir. So, Dr. Sandeep
Sickle.
Karmarkar has joined us.
Pardon?
Dr. Sandeep Karmarkar has joined us.
Hello, boss. Welcome.
Thank you. Wonderful.
He has to come on Thursday also.
Yeah, Thursday one.
Your day. Because of you.
100%. Looking forward.
See this?
Yes.
See this infracochlear region. This is jugular bulb.
Yes.
This is carotid artery. This is jugular bulb. This is cochlea.
Correct.
Yes.
And that's how you can go to the petrous apex infracochlear.
Yeah, in between. If it is pneumatized, in between these three structures, if I keep drilling, see this, if there are cells, that is a direct route to petrous apex.
Absolutely.
Yes, sir.
But in this case, it is not pneumatized. Direct route. This is most direct route to petrous apex. See now, I told you, I will drill away pericarotid cells.
Yes, sir.
I will drill away peritubal cells. I will show you. This is sinus. Jugular bulb.
Yes. And
That
how
is-
will you obliterate the eustachian tube, Satish?
Pardon?
How will you obliterate the eustachian tube?
I will use muscle and this thing, bone wax.
Okay. So what about the born alive granules, Sandeep sir, that you were asking?
Pardon?
Yeah, I had put in a question before I joined in that what is your experience with this bone alive granules, the neo-osteogenic activity which obliterate the cavity, especially in cholesteatoma surgeries.
Yeah.
So what's your experience? I mean, we prohibit using that because of the cost. Cost is a huge factor there.
What granules?
The bone alive granules.
Oh my God, what is that?
It's a material which
Hydroxyl.
stimulates. Not exactly hydroxyapatite, but something similar which stimulates the osteogenic activity and leads to new bone formation and is especially used to reduce the mastoid cavity size.
पतली diamond है बिल्कुल.
Have you, so you have been using it, Sandeep?
No, not. I used a few. It's definitely good. It gives a nice rock solid, bony contour. But then the cost is very prohibitive. It's something around, 5 or 10.
See now the clearance of the infracochlear region?
Yes.
From around the round window?
Absolutely.
Any special consent you take in these cases?
Yes, obviously, because the reconstruction ability is gone now.
Yes.
But yes, Baha and cochlear implant can be used.
Yeah, we can. Even any cochlear implants should be done in same setting, or can we do after some time? Because
anytime after, when we obliterate, any time when patient wants to get done, just open from behind. See, this is your round window.
Yes.
Yes.
What then you have to do is just open it, remove the fat over it.
Yes, that's
do your work and replace the fat back.
Simplest cochlear implant.
Yes.
No fight of which approach to be done.
Yeah. See this infracochlear region.
Yes, sir.
For last 10 minutes, I am here between the carotid, jugular, and this cochlea.
Yes, sir.
See the carotid artery very clear anteriorly.
Yeah, very well, very well.
Yes.
You can
This
see
is,
that
rukna.
Swish U very
This
well
is
now.
this is carotid. This is jugular.
Yeah.
And all this is infracochlear region, And this is round window.
Yes.
See now?
Yes.
This is your facial now.
Yes.
Let me do little bit of the retromagnetine work. I have to do a lot of work in the Eustachian tube.
Yes.
Dr. Oli from Kargil is asking, why not cochlear implant in the same sitting?
The patient didn't want. I given him an option. But see, this patient has a good hearing in the other ear, number one. Unilateral deafness, you can't force. I mean, it's not a very something where the patient cannot live without it.
Yeah, and psychologically, the patient has been so much traumatized because of multiple surgeries that he just wants a dry ear now.
Yeah.
That's a very common concern.
It's exercise, buddy. See how each and every cell has to go. I've already removed the tip.
Yes.
There's a sinus. You see the dura, sinus, anterior wall. This is the. And now what I'm skeletonizing is the labyrinth. This is my lateral canal. See?
Yes, very well.
Yes,
This is posterior canal here.
Yes.
And this is superior canal. See the whitish canals.
Absolutely.
Could you see skeletonization of all the canals?
Yes.
So what if the previous surgery, there was it would have been a myatoplasty which the surgeon would have done, then how would we have done this case?
Myatoplasty, he had already done myatoplasty.
Okay.
But
So the
inadequate.
closure- Okay.
Yeah, so which worked for our benefit. The inadequate myatoplasty worked for our benefit here.
See, supralabyrinthine, retrolabyrinthine, infralabyrinthine.
Yeah.
Cutting the 2 minutes. See my labyrinth here.
Very well defined, yeah. Can see all the 3 arcs very well.
Now cutting bar. This is retrolabyrinthine. Sinodural angle. See now, complete skeletization.
Yeah, yeah.
Yes, yes, without any.
Yeah, no cells to be
See the
left
plates below.
Yes.
This is the sinodural angle. See this?
Yes, yes, very clearly seen.
This is labyrinth and this is retrolabyrinthine. You have to do a complete job once you are committed to a subtotal petrojectomy.
Satish boss, I believed you were to demonstrate a case of meningoencephalic herniation of temporal lobe.
Yes.
Yeah, yeah.
So I mean, I think that also is a very good indication for
Yes,
this.
yes. But this week, boss, this Thursday, I've told you.
Yes, yes.
We'll be having acoustic neuroma.
Yes.
And gloma jugular.
Wonderful.
And that will require diamond. Subtotal petrojectomy as well.
Yes.
So maybe during that time you can also show us how do you harvest the abdominal fat, because many were requesting even in the previous
Okay.
webinars.
Next time we'll show how to harvest abdominal fat, how to do a meat over this thing, cul-de-sac closure.
Cul-de-sac closure, yes sir.
Done. Now give me. रुक जा. Sickle. पतला देना section.
Still lots of cells are left.
See the amount of bone work required.
Yeah.
See this infracochlear region. अरे यार क्या हुआ?
Microscope is moving.
चलो. And now see the oval window region. Hello?
Yeah, we are there.
This is the round window. You have already done all these mucosa in the cleft. See this? All mucosa.
Yeah.
Then here is the oval window, all mucosa. See this? Can you see?
Yeah, very well. Good clean there. Yeah.
All mucosa out. Yeah, now there, diamond. छोटी दे यार.
This subtotal petrosectomy is such a beautiful approach, actually. And
it
we have
opens up
used it for
everything.
variety of indications. I mean,
Yeah,
a lot
variety.
we've done quite a few revision acoustics, who were operated initially by suboccipital approach with a lot of residual tumor left behind.
Amazing approach.
I think even in Grupo, this is their favorite.
Exactly.
Yeah, I told you this is our one of the favorite surgery.
Yeah.
Yes.
Very regular feature.
Yes.
Every other day. इस size की cutting दे. Now see the carotid artery, and now I am going further. Sickle दे.
Yeah, very well.
To the Eustachian tube. I will ablate the bony Eustachian tube completely.
Yes.
See, this is the cell.
Yes.
Yeah.
Infracochlear cell. See this?
Yes,
sir.
You can't leave this. See this?
Yes.
So now it will be complete.
Correct.
See that?
Yes, sir.
अरे नहीं यार cutting चल ये देता.
Sometimes even the heat of this diamond burr can burn the.
See this infracochlear cell. Now it is completely removed.
Yeah, all nice smooth bone down.
No, there is no more.
Yeah, absolutely.
Now cutting there, medium size. And finally, and then we will obliterate the cavity. थोड़ा muscle भी लेना. See this.
Yes.
This is our Eustachian tube going there.
Yes.
This is the anterior canal wall. All this is the anterior canal wall. Thinning. धीरे. See this lateral wall of the Eustachian tube.
Yeah.
Sir, for the juniors also, can you tell us how we have to be careful for the TM joint anteriorly when you thin?
Yeah, you can remove the bone. What I can do, see, this is the periosteum.
Yes.
I can coagulate. See this. I wanted to thin out. ये मोटा दिया section. तू पानी ज़्यादा डाल रहा है. Drill. And now use taken two finally.
Yes.
Sickle. Sickle off. Hello.
Yes, sir.
Now see, this is the area lateral to the use taken tube.
Yeah.
Yeah, bipolar. See this mucosa in the use taken tube.
Yes.
All this is bad mucosa in the use taken tube.
So, sir, Dr. A.P. Shah from Patna is asking how safe it is to do a cochlear implant with the same sitting in this infected cavity.
Yeah, once you do, see the definition of the infected is if there is active infection. If there is active draining infection, you should avoid. But if it is a wet cavity, little bit of the wet is always there. If it is a cavity, that is not a contraindication. Active draining infection is a contraindication. That's it. See now I am drilling away completely the bony use taken tube.
Yes.
Yes.
See the anterior aortic completely.
Yeah, true.
Yes.
This is my facial now going there deeper.
Yes.
This is the facial now and rest I have completely. See the cochlea.
Yeah, the cochlea and the carotid relation is seen very well.
Relationship with the carotid and this lateral wall of the carotid, this bony use taken tube has been completely taken away.
Yes.
See this peritubal cells.
Yes.
I told you pericarotid cells. This is what subtotal petrojectomy is.
True.
See this. See, I am working on the carotid.
That's why it is not popular, because so many things to be removed and so many around the carotid artery, so many things, so much drilling has to be done. That's why people avoid it.
And
That
if
is
you
the
fail to do so, sir, then it will be a problem, right?
more disastrous.
Once you do, it will be a disastrous.
That's how you rule out the future possibility of infection, boss.
Yes, absolutely.
But
we have closed the external, see, we have closed the external auditory canal from out. We have removed all mucosa and skin.
Yes.
From each and every nook and corner, everywhere.
Yeah, that is the key actually.
And then we are now obliterating the use. See the cavity now, completely
Yeah.
Yes.
skeletonized, you know. Now I am working anterior to the carotid artery. See that?
Yes.
This is complete exentration of the eustachian tube.
Yes, sir.
The bony eustachian tube is 1 centimeter only.
Yes.
Yeah.
The cartilaginous is bigger one.
Yes.
And see now completely remove the eustachian tube. See that?
Yes, sir.
And here is the genu of the carotid underneath.
Yes.
Yes, sir.
Very well.
All pericarotid, peritubal cells have been taken away.
Yeah.
Yes, sir.
This is what the pericarotid, perisinus, perijugular bulb. See now?
Yeah, wonderful.
No question of anything coming back from here. See now.
So Dr. Manish Munjal is asking if the
Yeah.
facial nerve was exposed in these cases and fat is used
Yeah,
to
yeah, it is, see,
obliterate
it
the
is, it is
cavity.
exposed here. With the
Yes.
periosteum exposed, nothing will happen.
Yeah, yeah.
Okay. So have you ever noticed facial paresis when you
No, no.
obliterated with the fat?
No, no, no. Why?
In fact, in glomus tumors, we actually expose the
Open
nerve
the
and
fat,
swing it.
yes.
Yeah.
See, I have done the work around the facial nerve, oval window, round window, infracochlear region. See this? Around carotid, jugular bulb, eustachian tube, every in the supralabyrinthine region, labyrinth, perilabyrinthine region, and retrolabyrinthine region. Retrosinus, mastoid tick taken away, this thing, anterior wall and the superior wall completely skeletonized.
Yes, sir. Smooth cavity. Yes, sir.
थोड़ा मसल लेना मसल ले मसल बोन
So
वैक्स
Dr. Salman from England is asking how to differentiate between a semicircular canal's lumen and cells in the retrolabyrinthine area.
cells in the
Retrolabyrinthine area
see this
and
see
the
this
lumen of
see this see this retrolabyrinthine. See what is retrolabyrinthine. Can you see here?
Yes.
This is sinus. Can you see?
Yes. Yes.
This is dura. This is completely skeletonized retro sinodural angle. This is labyrinth, the lateral canal, the posterior canal, superior canal, and this behind the labyrinth. There is a thin bony plate. If I go there now, it will be, this is Trotman's triangle.
Triangle.
Yes, sir.
Between the labyrinth, you know, this superior petrosal sinus and this sigmoid sinus. And if I drill this bone, I will be right on the cerebellum.
Yes.
Okay?
Yes, sir.
Yeah.
Sandeep, your TV is on, Sandeep?
Yeah,
Pardon?
I think
TV is on?
background sound. Yeah.
Sure.
One, I'll see.
Right हो गया? Now see.
Is it better now?
See now what I am doing. See the eustachian tube which I have completely drilled away.
Yes.
What I am keeping? A muscle.
Muscle, yeah.
Muscle gives good scarring fibrosis. We don't
Yes,
want this area to open up again.
Correct. Quite often we even bipolarize the mucosa of the eustachian tube.
Yeah, completely bipolarized.
Yeah, and plug the fat in.
Completely
Suppose that by chance at this level carotid some nick do happen, then what will do?
That is something you have to avoid for sure, boss, in this surgery. Use use the diamond there.
And
See this.
yes, yes.
Yeah.
So eustachian tube completely
Yes.
segregated. See that?
Yes.
Yes.
Now there cannot be any source of infection.
Yeah.
External canal we have sutured in 2 layers.
Yes. So Dr. Satya Prakash Dubey sir from Bhopal has mentioned excellent dissection field.
Oh, is still awake, sir? One of the best human beings we have seen in life.
He is the ultimate.
Ultimate is.
Very unassuming and very humble.
Very helping to everyone.
So, if you suppose, how do you know that you are entered in TM joint?
Nothing, you just coagulate the periosteum, nothing will happen. I have coagulated.
That's right.
Because I thin this anterior wall completely. Then only you can drill the Eustachian tube. See this anterior wall completely.
Yes, yes.
Yeah, and sometimes the pneumatization goes right up till the zygoma.
Yes.
Yeah, very deep, very deep.
See this zygoma completely drilled off here.
Yeah.
Now, Devai. So now we'll start obliterating with the fat.
Yes.
Main two connections for exterior have gone. The semicircular canal, the extraordinary canal
Tube
and Eustachian tube.
Yes.
So now this will be a totally dry area. This is the basis of this surgery for the infection in the ear.
Yeah.
And you have to implant. Patient suppose is operated for cholesteatoma or having cholesteatoma or cavity, whatever is the situation. Now has a profound deafness and need to be restored. By any approach you do, the infection can come back. Now the implant is it's a child's play.
Yes.
With this exposure. When you have the situation like ossification of the cochlea, you have to drill out. See, this cochlea is such a small structure here.
Yes.
If you drill out the cochlea, carotid is very near to it. If you don't have an exposure like this and doing through the posterior tympanotomy the drill out, it can be a disaster. Got my point?
Yes, sir.
You need subtotal petrosectomy. The reason is infection, as I told, if the patient develops CSOM after the implant in place, what will you do? Many of such patients have been explanted.
Oh, okay.
If not, they may develop ascending infection going to the brain, to the subarachnoid space.
Yes.
See, in these areas, I am putting small pieces. Yes. This is all soaked in rifampicin.
Okay.
How come the pulsation over here? Dura is exposed, I think.
I hope now you have a fairly good idea of what subtotal petrosectomy is.
Very well. Excellent.
Yes, yes, very well, sir.
This fat is soaked in rifampicin and?
Rifampicin. See, all these areas, the pockets, you have to individually.
Yeah, so that it gets plugged in better.
Yes.
With direct contact on the bone.
Yes. See now?
Yes, yes.
And now, see a big piece.
Yeah. The cortex outside should be bigger.
And we do little over.
Yes, always.
And we have a flap disc here that will suture to the inferior part to keep it pressed, you know?
Yeah, correct.
And this is already the cul-de-sac closure here.
Yeah.
So now it will close. This is rifampicin soaked. It's a good antibiotic as well. And then we'll close this cavity.
The superior waist flat in this case.
Yeah. So that we will suture it to the inferior. Suture karna. So this is about subtotal petrosectomy.
Wonderful.
And very soon we'll keep a case of cholesteatoma with cochlear implant for subtotal petrosectomy. And cochlear implant, same stage. Same stage.
It's an excellent demonstration.
Yeah,
sir.
wonderful.
See, this is marathon surgery. You know, a lot of people, why they are not using this as an approach for CI, for difficult CI. For me, any CI which gives the possibility of a, this thing, any cochlear implantation you plan, which gives the possibility of CSF leak, I will do only subtotal petrosectomy approach. The reason is, once you seal the CSF leak, No other. Without this approach, if you seal the CSF leak, it may open up. Now with this exposure and this much of obliteration, any CSF leak will be stopped. There is no question. This is the final answer. Forget forever. Similarly, for all ossification cochleas, this approach. So like CSF leak, all common cavity, IP1, IP3, or in anywhere the CSF leak happens, subtotal Peter. Any difficult condition of the temporal bone where you are implanting, narrow sinus, forward sinus, lower dura, angled cochlea, malformed cochlea, this rotated cochlea, narrow, high jugular bulb, narrow facial recess, anything. For any difficult situation, you do a subtotal. Now you have a good exposure. Now with this exposure done, what is left in cochlear implantation? Just open the round window, do a little bit drilling there, and then you have an implant.
Absolutely.
Yes, sir.
It's the ultimate answer in many situations.
All traumatic cases where the patient develops after trauma of the temporal bone, profound loss, and you are rehabilitating with a cochlear implant. This is the approach. The reason is, if otherwise, because this trauma never heals with bony fixation again. They heal with fibrous union. And there is always a possibility of infection coming to the temporal bone.
Yes.
Always do a subtotal. Whenever the question of infection, subtotal peterectomy, obliteration, binds closer, you stick in tube closer.
Yes.
Any patient coming to us with CSOM which requires an implant, maybe simple central perforation, for that matter I tell you. If you close the central perforation, you can do implant after 6 months. What is the success rate of central perforation? Long term? You never know why it happened, no control over the pathology.
Yes.
If it comes back after 2 years, we have seen cases.
Yeah.
Then infection with the implant in place is something which will warrant ultimately explantation.
Yes.
It's difficult. So,
like even we can try in difficult cases like IP3 or this, we can do in those cases also.
Yeah, all difficult. I am doing more of adult implantation than children because we don't have government scheme. So all those skull-based surgery, all post-radiotherapy, sensory neural loss,
Yes.
osteoreactive radionecrosis of temporal bone. You drill away the temporal bone like this, subtotal peterectomy, and then implant.
Yeah, even in some malignancies, they tolerate radiation better if you do a subtotal petrosectomy. In cases of malignancy which require radiation later, you do a subtotal petrosectomy, and after a few weeks, they tolerate radiation much better. The chances of osteoradionecrosis is very less in such cases.
Yes.
Okay.
The only problem is with this approach, you have to execute it properly by means of removing all air cell tracts.
Especially around the carotid.
You have to
People don't
go
want to
through
go
the CT scan, find out all air cell tracts on CT scan and follow them, track them.
Correct.
You have to work extensively around carotid, jugular bulb, eustachian tube. For the fear of working around a carotid and leave carotid air cells open. You know what happens? Even if you obliterate the eustachian tube, some of the cells will bypass and open in the distally in the eustachian tube, and the CSF rhinorrhea will start. Infection may come back. It's all complete failure. If you leave the mucosa behind by means of incomplete exentration of the cell, mucocele will form and invite infection. That's a disaster. A lot of people call about cholesteatoma. See, if you are doing a canal down mastectomy, it gives you good exposure to remove cholesteatoma. This exposure is 10 times better than canal down.
Absolutely.
How can you leave the skin behind now? It is not the skin, it is the mucosa which is the issue.
Correct.
Yes, sir.
Skin, with this exposure, how can somebody leave the skin?
Yes.
But still, the protocol suggested by Professor Mario Sana is to get a MRI at the year 1, 3, 5, 7, 10.
7.
Yes, correct. Absolutely.
That is. In implanted child, CT scan. Even if there is some fat or something, the cholesteatoma coming, it will have a different intensity than fat.
Yeah.
Yes,
So people are want MRI discussion on this part also, temporal bone. And next we have gloom is this acoustic neuromas. I think long discussion will be there about the
decision making.
Yeah. So can you tell us something about malignant otitis externa? What is
Yes.
your?
We'll keep a case. I am working up. This is the answer. Subtotal petrojectomy. Many of the patients who are not responding to drugs, they develop microabscesses. Necrotic tissues. Completely necrosis. What will the antibiotic do? We have seen many of the patients, the necrosis of the temporal bone, peritemporal bone tissues, infratemporal fossa, nasopharynx, clivus, everywhere necrotic tissue spreading. Even the carotid artery necrose with completely thrombosed vessel because of the inflammation. Now in such, if you keep on giving antibiotics, what they are going to do? Ultimately all those patients die. They are already immunocompromised because of the diabetes.
Yes.
So in that, your diffusion weighted MRI is the key to pick up microabscesses, necrotic areas, and if you have those, excentrate. I mean, this thing, like gangrene, you have to, debride everything.
Right.
Everything, whatever is a necrosis, you have to debride to leave finally fresh areas where the vascularity is, and then the antibiotics will work. These patients, then they improve dramatically. Because in necrotic areas, if you are giving antibiotic, they are not reaching.
But more than the mastoid, many times it's the infratemporal fossa,
Yes,
parotid,
yes.
that's where it
Oh,
spreads.
intratemporal, parapharyngeal, it reaches everywhere.
Absolutely.
We have removed this necrotic tissues many a times, complete parapharyngeal, infratemporal fossa excision, starting from the ear till nasopharynx. Nose and ear is a huge cavity, common cavity. There's nothing in between.
Absolutely.
And you have to put a flap then.
So in malignant otitis externa, you will not give antibiotics and wait and watch.
Primarily we'll give if it responds, because antibiotics you have to give for months.
Yes.
Infection in the bone requires antibiotics injectable for months.
Which antibiotics, sir? Any specific?
Pseudomonas directed. Mostly it is Pseudomonas.
Okay.
Like piperacillin, tazobactam, meropenem or something like that. Then you have to titrate with the ESR.
Yes.
One investigation is ESR. Other is the functional investigation. That is PET MRI. Or if you have a facility with a gallium scan, that gives functional information. So, but that is costly, time consuming, difficult for patient to afford every time, because that requires on timely basis to see the progress. So what do you see? Get ESR done. ESR is the best measure. If the patient is responding, ESR will decline. And in spite of that, if it is not coming down and rising, you have to take a call. Because these are all immunocompromised diabetic patients. Their immunity is never going to improve.
And the role of long-term quinolones and rifampicin?
Yes, quinolone have penetration. Rifampicin also is good drug. Sometimes you have to add antifungal also. Difficult to differentiate whether it is fungal or not.
True.
What you can do is you can get serum galactomannan test to rule out fungus.
Yeah, absolutely.
If it is, then you have to add voriconazole also.
Yes.
Many times patient present with cranial nerve palsies and all that. A difficult situation, but with aggressive debridement and surgical management timely, you can save many of these patients.
Yes.
Many.
So what is anterior petrosectomy and posterior petrosectomy? Dr. C.S. Tengley from Gulbarga is asking. Can you put some light on anterior
petrosectomy as an approach? What we have done is posterior petrosectomy.
Yes.
Ear is housed in the posterior part of the petrous bone. So what we do, this subtotal petrosectomy with posterior petrosectomy. Anterior petrosectomy is an approach used by neurosurgeons. By subtemporal approach, they drill away the anterior part of the petrous bone to reach the posterior cranial fossa. That is anterior petrosectomy. And this is also known as, on the name of a neurosurgeon.
Rare happening today. You're missing something. Rare happening, you're missing something.
So that's a popular approach, anterior petrosectomy.
But this is a subtemporal approach with the extension of drilling of the anterior petrous. So you get a huge excess of the posterior cranial fossa directly.
The preauricular subtemporal, something similar.
Preauricular subtemporal.
Yeah.
Your posterior limit is intra-auditory canal,
Yes.
cochlea, so that you preserve the hearing. And anterior to cochlea, right till petrous apex, you have to drill away everything.
Okay. That stitching must have been done. You put drain in these cases?
No, not really. There's no bleeding. This is just obliteration now. Why to put a drain?
Where's Sandeep Naidu? He's very active.
Naidu is here only. He was here only. Ever smiling.
Ever smiling.
I know. Great.
It was nice. Implant was very good today. Implant was well attended, and
It
I
was
think
an amazing day.
maximum. Devang was. He's with us since the starting.
Hi. क्या बात है?
boss, बढ़िया.
All good.
All well, sir.
So implant was well discussed. Of course, colostoma was very much discussed.
Yeah.
Thorough details.
Plant all these. Luckily, we had today Dr. Dubey and Kirtan sir. So all well, everything.
Thank you all. Thank you. Thank you so much.
Thank you, and thank you for
Thank you so much, sir. It was a great day today.
Yeah, and thank you for letting me in last minute.
Yeah, I'm there, sir. Thank you very much.
Thank you, sir.
Thank you very much.
Okay.
Pharmacare division of Montec Apex Support M, sir. Thank you very much. It's once again a lovely webinar.
Thank you, Sun Pharma.
Once again, sir. Thank you.
Thank you, everybody. Thank you, Satish Bhai,
Thank you,
Rajiv.
Thank you. See you on
Thank you, sir.
Thursday.
Good night.
Yes, pakka.
Yeah. See you on Thursday, sir.
Good
night.
Night.
Thank you.